Welcome, everyone. We're delighted to have you all with us today. I'm Robert Klitzman. I am a professor here in the medical school in the School of Public Health at Columbia, where I also direct the Masters of Bioethics program. And we're delighted to welcome you all to today's program on When Clinical Judgment and AI Diverge, the clinical, legal, and ethical considerations. We'll be addressing several cutting-edge issues today that have major implications, as we all know, for all of us in healthcare, whether we're providers, patients, policymakers, administrators, researchers, and any of the above, or all of the above. We have an extraordinary group of speakers today from across disciplines who will be sharing their insights and wisdom, and we see this also as a very interactive session. So for those of you online, please feel free to ask questions at any point, and we'll also be having polls, and we hope you'll all participate. And also for people in the room, please feel free to ask questions. We'll have set Q&A periods where we'll be able to field the questions to the speakers. I would also like to thank several individuals without whom today's conference could not have occurred. First, the Data Science Institute here at Columbia, and Garud Iyengar, Alexis Avedishin, Aaron Elliott, and from the Masters of Bioethics program, Marie Gunyashev and Katie Mendez. I'd also like to give enormous special thanks to Charles Binkley, who did a superb job in taking the lead in organizing today's conference and bringing us all together. And please welcome me in joining Charles to say a few words before we begin.
Thank you, Bob, and welcome to everyone who's here in person and all of you joining us online. I also want to echo Bob's appreciation to the Data Science Institute, also to the Bioethics program, and to all the speakers who so generously gave of their time to come to New York or to come out with us today and to work on this project. So a little bit about me that may help to make this program fit into the world of clinical AI. So I'm a surgeon by training, and I think about three things that patients would come to me and ask when they would consult with me, largely from newly diagnosed pancreatic cancer. And the first question they would ask is, Doctor, how long have I had this? And so I oftentimes didn't have the answer to that. And the second question that they would ask is, what took you so long to diagnose this? And the third question, and the one that probably haunts me the most, is that they would ask, how long do I have? And I didn't have the tools to answer any of those questions, and they're extraordinarily pertinent. And I thought about how we might find answers to those. And so pancreatic researchers, pancreatic surgeons have searched for decades to try to find tumor markers that may help us answer those questions. Earlier diagnosis, narrowing clinical uncertainty, being able to provide more accurate prognosis and more personalized care. And nothing that we have identified is actually borne out. So when I started to learn about artificial intelligence, I saw a great opportunity to answer some of those questions, to answer those questions that patients had asked, to really provide patient-centric care. Also to help us as clinicians narrow the range of uncertainty and deliver better patient-centered care. But when I think about those clinical decisions, I think about the potential that AI could actually make it more challenging for clinicians. How do you think about disagreements, divergence, dissonance in that relationship? Because we're really bringing artificial intelligence into a relationship, and a relationship that has certain normative expectations between the clinician and their patient. So that's the background that bore in informing me about this topic. How do we think about that relationship between AI and the clinician when it goes well, and when there can potentially be tensions in that? So today, I hope we're able to explore that. I don't know that we'll answer all the questions. I hope we raise as many questions as we try to address. But I think it's very important for us to think about that tripartite approach. How do we think about this clinically, right? How do we think about this from a legal perspective? Because there certainly are legal ramifications to medical decision making. And then how do we think about the ethics of it? How do we think about informing patients of our use of artificial intelligence in a way that's holistic and, again, patient-centered? So that's the overview of today. This is what we plan, what we hope to be able to start to explore is this relationship between the clinician and AI. Because remember, in most instances, the primary interface is going to be between the clinician and AI, not the patient and AI, but rather the clinician. And so as we explore that today, again, a very warm welcome to all of you who are here in person, all of you joining us through our live stream. I hope the day is insightful and raises as many questions for you all as it answers as we continue on this journey of integrating AI into clinical care. So thank you.
Okay, next we're going to have Charles talk about what is human AI dissonance and why is it important. And Charles is the Director of AI Ethics and Quality at the Hackensack Meridian Health System. He's also an Associate Professor of Surgery at the Hackensack Meridian School of Health and a lecturer in bioethics here in our program at Columbia. So please join me in welcoming Charles.
Again, thank you, Bob. When Beth sent me her presentation, I don't think I said this is all wrong. I certainly didn't think this is all wrong. I kind of feel like I should spend the next 30 minutes defending my position. But I think it will become clear as I was listening to Beth and reflecting on why I thought of these things as higher risk. I think it's going to fit in very well with what I'm going to talk about. Because in my mind, what made these things the highest risk is what was the ground truth? Was there an opportunity to be able to say that one was right and the other was wrong? If somebody so I think about the risk from two perspectives. What is the likelihood of harm? And then if there is harm, how grave would that harm be? And I think about that from the clinical perspective of measuring a blood pressure. If you had a blood pressure, an AI-enabled blood pressure measuring device, the ground truth is that you put a blood pressure cuff on someone, right? And you can determine that that's the ground truth. When there's discrepancy about a pathology slide and you sort of are at the pinnacle of that ground truth between an expert and an AI, then there's much, much more opportunity not to be able to know. And that's really the background for today. So a lot of what I'm going to be talking about, a lot of what we're going to be addressing at the conference in general, is clinical decision support for clinicians, many times in real time. And it can be delivered in any number of different ways. It can be a predictive model. It can be used as a large language model. There are all sorts of different ways to come about that. But what I really want to focus on is that point of decision making and how that information that an AI solution is providing, how to integrate that and how we think about it, not necessarily when there's congruence, but how we think about it when there's divergence. So, Beth told us a lot about how New York Presbyterian is really a leader in this space of AI for clinical decision support. I'm going to think about it more in terms of categories. So what are the clinical categories that we're thinking about in terms of providing decision support? So certainly in diagnosis, that's the first icon there. Helping to narrow the range of uncertainty, provide more personalized diagnoses, being able to think about, how do we actually diagnose? How do we go about identifying something as that? And it really is pattern recognition, right? The way that I know somebody is septic is that they have a fever, their heart's beating fast, and their blood pressure is dropping. I know that pattern. So AI is much better at identifying patterns and making associations than I am. So you can see where the ability to leverage AI for better diagnosis, it's a huge opportunity. Treatment, the next. And we've all, I'm sure, heard about opportunities for using AI to improve treatment. Some of these others people may be less aware of. And the third is intraoperative or technical decision support. Huge interest, as much as surgeons hate to admit it, there are moments of great uncertainty in the operating room. and that's high stakes decisions. I think about a routine operation like removing someone's gallbladder. When it's routine and you identify the correct structures, then and it can be very easy, it can be a very straightforward operation. When there's confusion, there are two structures that have to be identified, and when you misidentify them, you can cause a great deal of harm. Very routine operation. This happens in the operating room frequently, right? And so if we are able to provide intraoperative or intraprocedural technical decision support, illness trajectories. Again, I think about someone with an acute neurologic injury who's in the intensive care unit, and the family wants to know how much functional recovery can we expect. And many times the clinician doesn't know. We're not sure, we'll have to wait and see. How much time is a reasonable amount of time? So could we potentially be able to map illness trajectories to say this is the likelihood of recovery for this person, this is the functional recovery that we would predict? And increasingly, this last box is the prediction of future health states. And I actually think that's the one that concerns me, that's the one that keeps me up most at night, is the ability to use AI to predict future health states. Because there are two questions that come up in predicting someone's future health state. One is, would the person find that information important to them? Would they value, do they want to know? And the second is, do you want it to be known? Because in order to know it, it has to be known. Most of these will go into the patient's electronic medical record. And so we have to think about how do you entertain patients' informational preferences. Right now, if I have your data and there's so much data in healthcare, if we have access to your data, there's no limit on the predictive analytic we can run. It's really our own sense of should we be doing this. And whether that be suicide risk, risks of violence, things that may not be directly related to that person, there's the ability to make those predictions. And so I think I want to sort of keep an eye, and again, how do you correlate that clinically? So I think we have to think about the prediction of future health states. And in some ways, we're able to predict things that we would typically rely on genetic testing to predict. In that case, patients had agency. They could refuse to contribute cells, a buccal swab or a blood test. In this case, we already have the information, and so there's much less of an opportunity to exercise agency. So what are the potential benefits? And again, Beth did a great job of talking about the potential of AI, thinking about it from a surgeon's perspective, decreased uncertainty, enhanced precision, to actually be able to tell that patient, not in general patients who have this complication, or in general patients who have this illness, this is how they tend to do, but for you, this is how we would expect your illness trajectory. Thinking about instances as a pancreas surgeon, there's always been a debate about, what is resectable pancreatic cancer, which patients should go to the operating room and which shouldn't. And there was a retrospective study done 20 years ago now at Hopkins, where they in general, we had decided that there were these categories that these patients did not benefit from surgery. And so we would not offer them surgery. But if you actually look back at some of the data that was collected at Hopkins, there's a small number of patients with disease that has progressed that if you operate on them, they actually do pretty well. They do as well as patients without locally advanced disease. It's a small set, it's about 6%. It's about 6%, but they're there. Right now we say we'd have to operate on 100 people for those 6 to have a benefit, and so we say that it's not worth it, but what if we could identify those 6 and not have to actually make that trade-off? Right? So those are the sorts of things that I think about in terms of enhanced precision. Earlier identification of disease. So how sick is somebody? How septic are they by the time they have a fever, by the time their blood pressure is low and their heart's beating? They're pretty darn septic, right? But that's the best that we have many times at identifying disease. So you think about what was the point of the inoculum and a patient who's septic. There's going to be hours between that. So could we identify those patients earlier in the illness trajectory? The difficulty is that we have to think about how we're going to mitigate, right? I know as a surgeon, I know very well how to take care of a septic patient. I don't know what to do if you let me know that somebody's going to become septic or that if you predict that there will be septic in the future, right? And our ways of measuring and identifying, diagnosing sepsis are meant for later in the illness trajectory. By the time someone's hypotensive and have these other signs of sepsis, they're very sick. And then less subjectivity and variation. So if you look at the way even common conditions like heart failure are treated in the hospital, there's wide variation in practice, even though there are guidelines. So is there an opportunity to actually provide less subjective and more standardized care according to guidelines? And would that be associated with improved patient care? Again, these things have trade-offs, and we're going to see some of those trade-offs. But is there the opportunity to leverage AI to be able to provide more standardized, less subjective, and care without as much variation? So one of the things I like to think about is, so what's new about AI? Like, what is it that makes these conflicts? Like, if I read a textbook and I don't agree with it, I just don't agree with it. But what makes this so high stakes? And how does AI for clinical decision support differ from the ways that we typically seek the tools that we use for help in making decisions? And I think about, the medical literature, journals, textbooks, sort of the foundations, the foundational knowledge. I think about clinical calculators, risk scores in the middle. We think about Apache scores. We think about, the National Surgical Quality Improvement, surgical morbidity scores. There are a myriad of these scores that are meant to help us make better decisions. And then our colleagues, probably for me, the source of decision-making that I find most valuable, because I can talk to a colleague, we can criticize each other's perspectives, we can try to find fault in our logic, and really important, I don't have to ask my colleague if they have the best interests of the patient at heart. I don't have to say, is your goal to provide the best possible care? I know that, I can assume that, and I think that's also a key difference. So what are the differences? AI is highly accurate, much more accurate than we would find in any of these things, than the textbooks that we would find in the clinical calculators or even with our colleagues. Again, very personalized care, being able to take that patient's information and be able to make predictions based on how the computer model, how the AI has been trained. Most AI for clinical decision support, it doesn't just give you information, but it actually prompts an action. Giving you information without prompting an action could be misused. That information could be misused. I think about mortality predictive models that are being used in hospitals. The purpose of most of the mortality predictive models is to help clinicians think about where patients may be on their illness trajectory to be able to match goal concordant care. To be able to say this patient may benefit from advanced care planning, this patient may benefit from palliative care, or this patient with the highest mortality risk may benefit from talking to someone from hospice. Again, to be able to align the patient's goals with the care that you're providing. However, you can imagine how a mortality predictive model could be misused. It could be taken as a proxy for futility. If the patient has a predicted 85% mortality risk at a given time, a clinician may say, why offer things? Why bother even, right? But that's not really the purpose there. So we have to think about not just the information, right? Not just providing the information, but prompting an action. And I also want to highlight that unless we're very thoughtful about what that action is and how that's built into a workflow, that could actually cause greater harm. So for instance, the fall predictive model. Being able to very accurately predict that a patient's going to fall doesn't prevent them from falling. You have to have a clinical workflow in place, right? It's not just the information there, right? The most accurate information isn't going to mitigate harm unless you have a workflow, unless you have an intervention. So I try to match the information with the action. On the downside, most of the AI predictive models aren't explainable. It can't tell you why it's making that prediction. It may be able to give you a probabilistic, in some ways it's a trade-off. The best models are the least able to be explained. right? So there are trade-offs there. And some of the models be able to give you the contributing, these are the highest contributing factors, I think, about some of the deterioration indices that may be able to say these are the things that are contributing to this patient's likelihood of deterioration. But to be truly explainable, particularly if you disagree, to be able to have that robust conversation like you would have with a colleague, that simply is not possible. I think also important, most of these are being pushed out to clinicians. So it's not like I'm seeing a patient and I need some advice. I'm opening a patient's chart and I'm getting information that I may or may not be related to why they are seeing me. And it may or may not be information that I'm even prepared to use. Several months ago, I was part of a panel that Bob and the bioethics program at Columbia hosted. We were talking about HIV predictive models. And there are a number of primary care sites that this is embedded into patients. So a patient may be coming in for some completely different reason, and their predicted risk of HIV is being made. And the clinician's getting this. This patient is here for toe pain, and they're predicted to have an 85% chance of developing HIV in the next 6 months. Now, it's somewhat of a dramatic, but not completely atypical example. Then how do you integrate that into your conversation with the patient? How do you tell them, is that an invasion of privacy, right? I think about it from the perspective of, if I have a patient with a mental status change or who comes in with an acute mental status change, I must test them for substances. That's the standard of care. But if I just want to know if a bunch of my patients on my service are using drugs or not and randomly test them without cause, I think that's an invasion of privacy. So I think we have to think very carefully about knowing these things. Just because we can, should we? And then the shared ethics and values. So what contributes? So we have this opportunity here. We have this information, these actions being prompted. So what may be the sources of divergence, and how do we think about them? So in many cases, there's more than one solution. We see this all the time. There may be more than one way to achieve the goal. It's actually fairly seldom that there's only one way of doing it. We certainly see that with colleagues. Colleagues have different approaches. There's not always one antibiotic that will treat the infection. Sometimes there's a range, and we think about, what are the trade-offs? We can certainly give different weights as clinicians to the information that we're using, particularly with the more complex questions that have more variables. We may place different values, we may place different emphases on different pieces of information, right? And it may be related to our experience, our training, our last case in some instances. Whereas AI, we think, based on the pattern that has been trained to identify, we'll be able to weigh both individual variables and also variables in combination with each other more objectively. And so we may find a difference here based on how we're weighing the information versus how an AI solution may be weighing it. Certainly patient preferences. Most AI solutions don't take into account a patient's preferences. They're making a prediction that the assumption is that this is the outcome the patient desires, but that may not be true for every patient. So there may be divergence when a clinician is factoring in patient preferences into their recommendation. Certainly just human subjectivity. Humans can see things very differently, and this gets in a little bit of how we weigh information, but that weight of information may not be completely cognitive. We may well have biases, right? People look different, and the way that they appear can sometimes influence our decision-making. A very common thing that you'll hear, particularly among surgeons, is the eyeball test. Go eyeball that patient and see how they look. A subjective assessment based on their appearance in real time. But it speaks to us. Let's look at them. Let's see. And we talked about, I think it was the McNamara effect last night, where you have the data and then you have the reality, and there may be a discrepancy there. So I'm not completely discounting the importance of a clinical assessment, but I'm saying that it's subject to our own biases and our own experiences, and AI may be somewhat different. I think clinicians may have a different risk tolerance, right? And AI may be, again, more objective and less influenced by individual levels of risk. And then subclinical disease. Again, getting back to that sepsis predictor, like how far upstream should we be? Are we able to predict illness? And then what if we can't clinically correlate it? I think, and again, where I'm so looking forward to Flo's presentation from radiology, but I think about subclinical radiographic findings or other subclinical findings. And how do we think about that? I'm again not a cardiologist, but my understanding is that some of the AI predictive models are very good at predicting patients who will develop atrial fibrillation. You have a normal EKG, but it will predict this patient's at risk for developing atrial fibrillation in the future. I don't know what to do about that. Do we take that patient to the EP lab and try to find a focus and ablate it? Do we put them on a beta blocker? Do we watch them? Do we tell them? Right? Do we tell them that you're going to develop atrial fibrillation in the future and there's nothing that we don't know what to do right now? So what's at stake? What's at stake for the clinicians? And I'm focusing on the clinician here, but what's at stake for the patients when there's divergence? So because the interface is really between AI and the clinician, that's where my focus is. I think probably one of the biggest risks is, we talked about narrowing the range of uncertainty. What if it actually backfires and it expands the range of uncertainty? I never thought of that. What's wrong, right? What if it actually causes us, in that second, what if it causes greater confusion, right? And instead of decreasing the variation, causes greater variation. The medical legal concerns are certainly going to be in people's minds. What if I agree and it's wrong? What if I disagree and it was right? Right? And how do I think about, I don't have a ground truth, particularly in these cases where you're the expert, right? Think about the pathologist reading a slide. You say that looks like carcinoma, and an AI predictive model says, no, that's benign, right? Only one of you is right, and the stakes are high, right? So how are we going to think about resolving that? And then certainly, none of us wants to hurt a patient, and I think that's where that risk factor came. As I was looking at those, like hurting a patient is the last thing any of us wants to do, right? And so, what are the moral repercussions of that, and how does this create for us a moral conundrum? So how might we resolve these? And we're going to hear that today. My clinical colleague is going to talk us through how they might go about resolving this. But I want to suggest maybe an overview. The purpose of this talk is really to give an introduction to what we'll be delving into deeper from a clinical, from a legal, and also from an ethics perspective. So I'm going to suggest that what we need to do is reframe this. That we think less about the divergence and more about what does the collaborative model look like. Right? Not who's right, do we arm wrestle, do we toss a coin, but rather how do we use that information for collaboration? So we think about a second set of eyes. How many times, Gabe is here, he's a surgeon, there may be other surgeons. How many times have we been called into a room, take a look at this, right? Just take a look. Radiologists, take a look at this. Nursing, take a look at this patient and tell me what you think, right? Another set of eyes, right? Can we think about this as another set of eyes? Pause and consider, slow down. One method of intraoperative decision support is simply slow down, a little bit like a danger's ahead, right? You may not see it, but there's maybe a source of bleeding, or there may be a structure ahead of you, so slow down, pause and consider. Ruling in and ruling out, sort of a methodology, a process to say, so this is what I believe, I'm going to rule this other option out, and I'm going to rule mine in. So thinking about it from both perspectives, not just I'm right. What we want to avoid is, on one hand, epistemic authority. I'm the clinician, I've had all this training, I've had all this experience, I must be right, that AI stuff. Or on the other hand, that AI is so powerful. Right, so powerful. It's been, and me, and if I don't follow this, then what's going to happen to me? So automation bias and epistemic authority are sort of the poles that we want to avoid. I think it's an opportunity for us to reflect, to examine our own subjective inferences. What is contributing to my decision here? How am I weighing the information? And then also prompting a skills assessment. Do I really know this well enough? Am I good enough in this area? Is this something that I'm really comfortable with? And maybe it's my lack of skill, my lack of knowledge in this particular area. So a glimpse into the future. What does the future of this collaboration look like? So my sort of paradigm for this is that we have an existing normative relationship, and we're introducing AI into it. And I hope I've convinced you that AI is different than a textbook or a colleague. It's probably more like a colleague than a textbook. So what's the future? How should we be thinking about this? And how does today set the stage for all of you who are attending to be able to think through this? Because it's not going to be asked and answered today. And it's also not going to pause for us to provide the answer. It's going to be evolving very quickly. And so I think, at least I hope, from today we're able to have a way of thinking our way through what I think are going to be some of the opportunities in the future. So Ethan Go and his group from Stanford published this. It's a small study, but it's gotten a lot of attention. Essentially, it's a three-pronged study, essentially. I think we're probably going to see more of these three-pronged studies, comparing judgment of the clinician alone, clinician plus an AI, clinical decision support, and then the AI by itself. So 3 arms to those studies. And this arm, the clinician plus their standard decision-making tools, and the clinician plus AI, in both of those groups performed less well than AI alone. Now these were cases. There are lots of flaws that have been cited in this study. It's small. It's using cases. It's using one type of medical decision making. But at least, but see the headline, right? Defeat doctors, right, at medical decision making. So think about that, right? Think about sort of what the takeaway is. So I expect that we're going to see, there's going to be 3 buckets. There's going to be things that we clearly do better as clinicians. There's going to be things that AI clearly does better. We're going to have enough humility to be able to be able to say the ethics there is that this is why we don't give mercury for syphilis anymore, because we have something that's more beneficial and less harmful. This is why we use multi-agent chemotherapy for metastatic colon cancer to the liver and not single agent as we did for many years, because it's better, and we know that it's better. So if we know that things are better, we should adopt them. That's the ethics. Patients may start to like AI better. It's not grumpy, it's not tired, it doesn't want to go to lunch, it has lots of time for you. It likes to chat. I recently about a year ago, established care with a new primary care doctor, and I'm talking, and I'm told that we only have 5 minutes left. So patients may start to like it better. The data right now are that in terms of communications, patients like a lot of AI-generated communications better, at least the tone. Right? The tone is better. They're not monosyllabic responses. This just came out of Utah recently, where Utah has, however you want to think about it, approved, licensed an AI agent to renew prescriptions. And these are non-injectable, non-scheduled prescriptions, routine medications. There are lots of questions here. But I wonder if we're going to start seeing a push. I mean, there are financial advantages to this, right? It saves the cost of an office visit. There are certainly equity. This is much easier than seeing somebody, particularly if you don't have easy access to care. So I wonder if we're going to start to see more AI like this, right? Some of these functions that we can automate. The New Yorker, a few weeks ago, if AI can diagnose patients, what are doctors for? That is the question. I think that is the future question. I think we have to do that soul searching and find out what we bring to. I know we bring something to the table that's extraordinarily important. Extraordinarily important. I think we have to think about what that is, and we have to get really good at it, because we can't compete with AI in some of these categories, nor should we try. But instead, we need to get really good at the things that make us human as clinicians. And I think that's our future, is really identifying. And I certainly talk to medical students and residents about that, just thinking about, what does it mean to be human in the relationship with the patient. So thank you all very much. I'm looking forward to your questions.
Next, we have a wonderful set of 3 speakers on how should human-AI dissonance be addressed clinically. So first, we're going to have Florence Du. She is an assistant professor in diagnostic radiology and nuclear medicine at the University of Maryland School of Medicine. She is the director of innovation at the University of Maryland Medical Intelligent Imaging Center and faculty at the Institute for Human Computing there. Also, we're delighted to have Gabriel Bratt. Gabe is an assistant professor of surgery at Beth Israel Deaconess Medical Center and an assistant professor of biomedical informatics at Harvard. And thirdly, we have Sarah Collins Rossetti. She is an associate professor of biomedical informatics and nursing at Columbia University Medical Center. So please join me in welcoming them.
Hi, everyone. So my talk today is AI is not the human eye and what that means for radiology patient care. Here are my disclosures, and I'm not going to read them to you, but very important for my talk is that the bottom right, all discussed items are for educational purposes only. They're not product endorsements. So some housekeeping is that this red box means there's an activity. This is going to be very interactive, so hopefully some of you can join me in these activities. The first one is, how many of you are using AI in your personal life? Oh, good. So how about professionally? Use it in your professional life? Okay. And have you ever disagreed with your AI outputs? Oh, okay. Good. So I don't need to give this talk then. Well, as you all have already experienced, you are all human and intelligent, hopefully. And what we're trying to do now is interface with artificial intelligence, right? And that piece of it, that interface, really may have some episodes of dissonance where you might disagree with the outputs. So I'm going to talk about this in this kind of structure. We're going to talk about AI, go into radiology, talk about some examples, and have some last thoughts. So I know that we had already gotten an introduction to AI this morning. I'm going to dive really deeply into this imaging piece of it. The classic way, as we had discussed, is you'd have to have a bunch of labeled images, maybe cats and dogs. It would be fed through this convolutional neural network that would detect some features of the cat or the dog and decide whether that picture that you gave it was a cat. Now, here is a really difficult question for the New Yorkers in the room. I picked this on purpose. The bagels versus the puppy. I'm not going to quiz you right now, but at your seat, think about whether or not you can identify whether or not that's a puppy or it's a bagel. A little more challenging for that convolutional neural network to determine those features. As a radiologist, when people ask me, oh my goodness, your job's going to be taken over, I said, don't worry, it's a puppy or bagel problem, right? Because you've got CT, you have MR, PET, radiography, mammography, fluoroscopy, ultrasound, a plethora of different types of imaging modalities. You have all these different specialties, from abdominal imaging through nuclear medicine to interventional radiology. You have all the different anatomical features that are found across those imaging modalities and specialties, like your liver or your breast or a certain blood vessel going through that structure. And you have all of the findings on those structures. So you have something like a normal finding or a stenosis or clot, or you have a mass or a cancer lesion, right? And you think about this grid of puppies and bagels across this entirety of radiology, and you realize that's a really, really difficult problem, right? This grid becomes very, very complex very quickly. And if you take out just one finding and you find this one thing on a PET CT in nuclear medicine, you might find this one feature. But that's not very helpful for the radiologists that are thinking about this entirety of the grid, because that knowledge needs to be encoded and codified in some way. So in the now old slide, it says current, but really recent past. A human would need some programming skill and label some data, develop a programming application, and deploy that in real life somehow to output what we call single narrow task AI. Is there a fracture on this image, right? And code that in. And as Beth had mentioned before, we're kind of moving beyond that into a more interesting future, which is now you can feed this image in, as I'm sure you've tried before, and you say, hey, what's in this grid? Please tell me in a tabular format, and then it would spit out something like this. And this is where a bunch of radiologists got scared again, right? Is it going to take over my job? Because, hey, it can do this really well now in about 2 seconds rather than a couple years. So I'm going to have you all try this other feature now in this new future. You can either try this website or your favorite tool that you already have. I just have this because you don't need a login. The task I want you to do is to put in image generation. Please generate an image of a white coat human doctor cartoon in Mario Kart. Whatever your favorite tool may be. I'm just not naming them because no product endorsement. And then just kind of like stare at me blankly once you've done this so I know you're done. Okay, I got a couple stares. And if you don't have your phone with you or your computer with you, it's okay. Just imagine what you think this image should look like. All right. This is the result that I got when I did this a little while ago. A white coat human doctor playing Mario Kart. Or if you chose a different tool, this might be what you get on the other side. Okay. So someone got some variation of this? Yes? Nods? Okay. Well, what's fascinating is if you thought about this for a little minute and thought about, wait, what features are being represented in a white coat human doctor, right, playing Mario Kart, that if you tried a black African doctor helping poor and sick white children in photojournalism style, right, what would you have gotten? Just think through that image for a minute before I pop up what this is. You don't have to type this into your chat box. This is the image that pops up, right? Is this a black African doctor helping poor and sick white children? That is the exact image, and it got published in the Lancet Global Health because generative AI tools have these weird blind spots of how it doesn't understand, based on the variety of data that it's gotten and trained into, that it is an extended version of that cat dog. And if it did not get those training data, it would not be able to feed that information back. So I do want to use this as a highlight that it's a very powerful tool that has very interesting blind spots. Okay, now let's take this a little deeper into radiology. So my question for your audience, for this audience, is how many tools have been cleared by the FDA in radiology? Throw out a number. Someone. I can't. 612 is what I got here. Anyone else? 200. Okay. I'm going to give you the number. It's 1,039 tools have been cleared in radiology. And it's actually leading the pack. Over 75% of FDA-cleared tools are in the realm of radiology. It's really fun and interesting to think about. I think of this as maybe a convergence of things like Facebook photos, Google Photos, wanting to organize your photos in general, that imaging was just a fun space. And it just happened that people were exploring it. So my next question for you, how many of you think your doctors are using AI for your healthcare? Okay, good. Biased audience? Yes, right? I'm going to say for radiology, there's this interesting article in the JACR, how are American College of Radiology members using AI in 2020? So before the advent of the start of AI in 2022, apparently, right? So in 2020, 33% of respondents had been using AI as part of their practice. And then they predicted that in 5 years, 20% more would be adopting it that hadn't already been using it. And how exactly were they using it in 2020? Well, here you go. Here were the most popular algorithms back then. 9.8% were self-developed. Then it was screening mammograms, pulmonary embolism, which is a clot in your lung, then MR brain analytics, and brain hemorrhage. Okay. And now, when I talk about AI tools, and that was a small subset of tools, I want us to understand the workflow as a patient or as a radiologist coming into the system. Here's our very basic radiology workflow. When I talk about the top tools and everything else, I want you to understand where it lands in my day-to-day work. So this is the 4-step thing, which is you go through scheduling, you gotta schedule your exam. Then you get to take the image. You acquire the image, you do pre-processing, maybe you do some optimization steps. And then there's computer vision or image-based tasks, which is kind of what that last slide was showing. A lot of that image processing, what you can consider radiology, looking at the image, interpreting it in some way. And then work list and triaging, which includes when your image is taken and somebody looks at the image, that it orders the work list and it gets sent out back to the EMR in some way. All right? So I'll call the first two and the last one non-interpretive AI. And we're going to call this middle one, the computer vision-based task, interpretive AI. So those are two different buckets when you talk about AI tools and how they're purchased. So when we're talking about interpretive AI, I want us to now think about the human task of what this means. All right, this is another interpretive task if you're ready for it. Here you go. This is a painting from the 1800s. And the task I want you to do together with me is to assess the ages of the characters. I'm going to give you a few seconds and think through how old you think these characters are. Okay. I'm not going to ask anyone to tell me what they think, but hold on to that thought. Now the next thing I want you to do is assess the material circumstances of this family. How rich or poor, what they're doing, material circumstances. Everyone has in their mind what they think? Okay. Well, here's what's fascinating. I hope your eyes, right, had done something like this when I asked you to do assess the ages of the characters. I don't know if that's exactly how your eyes were patterning across this, but this was an eye tracking study. And then this was the assess the material circumstances of the family, that your eyes looked in a completely different area. This is your human eye behaving and training, right, what you thought was important in the scene, just for these two tasks. And what radiologists are doing are multiple tasks, and I'll describe this very shortly. So with clinical radiology, we have an image to report. That's what we're doing. We take an image and we kind of decipher what's in there. We kind of give you the findings and the impression and what we think. So here's a radiology image. And as you're looking through this, right, think about the fact that there is no, I'll call it single path of how your eye is tracking and thinking through things with all of the different imaging modalities, all the different anatomical findings, right, and all the pieces that you might need to assume. So let's step through this, right, to generate what you would see in your electronic record as a wall of text, a report. How do you do this? Well, we develop a search pattern, and I'm going to describe this to you, so you're all going to be radiologists when you walk out of here today. Here you go. So in my mind, some basic questions that I'm asking are the top 3 questions on the right. Is something obviously wrong? Which organs are affected? And what exactly is the pathology? So, right, I'm thinking through this. So I'm going to walk you through how we would look through some of the organs for a first-year resident. Take a look at the liver for a second and just stare at the liver that's outlined in yellow. We're going to step through this. And your eyes are just staring at the liver. You go back up, you look at the gallbladder. The gallbladder's popping in and out right next to it. Then you look at the body and tail of the pancreas, and you're going up and down, and it's disappearing onto your screen. Maybe look at the spleen in the red outline on that far right side of the screen there, right? Looking at each aspect of the spleen. And then maybe looking at the kidneys in blue on either side. So you're looking at all these organs and you haven't noticed anything abnormal. This is just looking at the general overview of the screen, right? Each organ and looking at it very deeply. And your eyes had to be very focused on each of those organs as you were looking, because if you were just gestaltly looking at this whole thing, your eyes would not be capturing the information that you would need to look at that image. That's what a radiologist, a human radiologist, is doing. Okay. Great. Now, what happens in that process? And now we're scrolling through it, and maybe you're noticing on the other side now as that video is playing, and you've maybe developed that search pattern to look at each organ, that you're seeing some little stones in that gallbladder on that side. So we first have to perceive that information. We have to generate a hypothesis in our minds, use heuristics to guide the likely diagnosis. We interpret the information in the light of a history. If I told you this is a woman in her mid-40s, right, who has right upper quadrant pain, what that would change your diagnosis for, and how you would verify, stop and think about it. Is she coming in acutely overnight? Is this happening for many, many years? Okay. So that type of thinking is type 1 thinking, right? That's the first two pieces where you're fast, intuitive, kind of scrolling through really quickly to make sure you're not catching something very dangerous. And the second part of type 2 thinking, thinking through the additional history, looking for other information, synthesizing your knowledge together, is type 2 slow analytical thinking. And I posit to the audience and also for the AI developers and all the people thinking through this, what type of thinking is AI going through? And how do we think through that and explain that to a clinician or to a patient? Okay. And I want to now flip into how AI is thinking. So for interpretive AI, computer vision, very, very basically, and if you're a developer in the room, just forgive me for a minute, there's classification, detection, and segmentation at the very basic end, and then there's predictive analytics, risk prediction, and prognosis prediction. What I want to highlight here is that when we measure quote-unquote good performance, it means very different things, and I'm going to describe what that means. Classification just means if something is present or absent, right? If you have a liver metastasis, which is a cancer basically spreading into different places, you're looking for additional masses or lesions that shouldn't be there. And so if it's present or absent, well, this one is present. If you want to do object detection, you put a bounding box exactly around those areas. So rather than just saying, hey, it's there, you're saying, hey, it's there, but it's right here in this box. Okay, so the red box here is a metastasis, the blue is the aorta, and then you have the spleen there in green. Okay, and then segmentation is even more precise. You need to draw an exact mask, an exact border around that lesion. And for each of these things, there's a different implication about what information is being given to me as a radiologist or to other clinicians. And really importantly, I'll just highlight a use case for the segmentation in particular. If you're getting radiation therapy for your tumor, you want to blast the area for radiation, right, and only that area and not beyond it and kill healthy tissue. So you do want to have that segmentation be very precise. Okay, so thinking back again to how I was using AI, let's look at those most popular algorithms. And we're going to take a look at this exact example to talk about the human cognitive dissonance in those two examples. The first one being pulmonary embolus, the second being screening mammogram. All right, you all ready for this? So, radiology example number 1. Pulmonary embolism triage. You first, in order to detect a pulmonary embolism, a clot in your lung that could kill you, you have to inject somebody with contrast, basically dye, right, through their vessels, and you can then dye the pulmonary artery. And you can see here, this is the image we would get. And in case you have really good eagle eyes, you're going to notice that there is a very small area that is not being filled with dye. We call it a filling defect. I'm going to zoom in on here so I don't have to test your eyes. But just imagine that whole area isn't white, right? If you injected dye through it and it's white dye, that entire vessel, that's a little highway, should be painted white. But if there's a blockage in the highway, that's dark because there's no contrast going through it. So you can see here, there's a pulmonary embolism. Okay. Well, if I had used interpretive AI, which we did, you'd get this little thing. It's a heat map. And you would see that bright red area, theoretically, is where the PE is. And luckily, in this case, it matched. Yes? So this would be automatically popped back up to my work list, actually. It's running in the background, detecting the PE, and saying, this is an acute finding. Move it to the top of your list. Typically in my workday, I would go down my list. If you came at 9 a.m., I'd read you first. If you came at 9:30, I'd read you next, moving on. But in this case, if you came in at 10 a.m. and I'm still reading the 9 a.m. for whatever reason, they say, no, stop, move the 10 a.m. up. I want you to do that one next. Very efficient, saves your life, right? And very interesting algorithm. Well, this is what I'm going to show you. So this is the work list, and you can see that this person came in after everyone else. It got popped up to the top of the list so I could read it next because there's that AI positive badge. That's a work list triage algorithm. Notice that I said it's a triage algorithm. Even though it detected the PE for FDA clearance, it's much safer in some ways to say, oh, we're just going to move it up the list so the human can look at it, and not necessarily say, well, we're confident we're diagnosing PE. Different bar to clear, right? So this is a triage algorithm. Well, here's one of the first ethical considerations. So let's just say that in this specific instance, this is anonymized, even the date for the patient's confidence. So you see that a triage alert was triggered by the vendor for pulmonary embolism. In the yellow text, the system has pushed a notification to the desktop app, but has not logged relevant engagement with it. So nobody clicked on the heat map, right? Please find below the relevant processing logs, blah, blah, blah. Which part is ethical here? Is that the AI was running and nobody used it? Or is it okay because this was standard of care anyway, because there's no standard of care saying you have to use AI, right? So that's one potential issue in the back end. And maybe your administrator, what kind of information does that tell you? How would you use that information from an admin side? How would you use that as a patient? Okay, now this other case, this was an older version of the tool, but it actually had said something like no PE findings detected. There is what I call in radiology an arrow sign here. I put the arrow so you don't have to guess whether or not this was right. Okay, so in this case, there is a filling defect in the left main pulmonary artery. And here is the reporting system that one of the institutions had used. I want you to pay attention to the fact that there is a box for artificial intelligence here. And what we do is we have a pick list. You can say AI is positive, the human is concordant. AI positive, the human is discordant. And why? AI negative, concordant, AI negative, discordant, AI unavailable. Is this how we would want to record how AI is used in a system? I will say that this is one way one of our systems had done it. It's not universal in radiology. It's just an example. Okay. Next, I'm going to pause there for a second in case anyone has questions. Okay. Next, I'm going to go into the, oh, there is a question.
Yeah, doesn't that slow down your workflow?
I'm sorry? Oh, yes, it does. It slows down my workflow. Absolutely. Great insight. Absolutely slows down my workflow. And I didn't highlight this, and I'm going to mention it since you very kindly brought it up, is what if I had more than one tool, right? How many boxes do I need to fill out then? And does it slow down? Maybe there's 5 PEs coming in, and it's slowed down. I'm like, oh no, which one do I do first of the 5 ones that were flagged? Great question. Thank you. All right, I'm going to jump into my next example now for radiology. I don't know how many people in this room have gotten a screening mammogram. And just to show you that this is the screening mammogram workflow, you get a craniocaudal view and then an MLO mediolateral oblique view. And then, or sometimes tomosynthesis where you get more than that. Then there's a callback process where you come back for the diagnostic mammogram. I'm highlighting that there's a difference between screening and diagnostic because diagnostics where you actually get to know if there is a cancer there or not. With screening, it just means, do you need to come back because there's an abnormality we need to think about, or is it negative? That's all. The screening mammogram is not meant to diagnose cancer, okay? It's just meant to detect abnormality or not, come back for a diagnostic, and then we'll tell you. And there's a time lag, you'll see at the bottom. You have a screening review, and then you have a callback that's scheduled, and then you do your diagnostic workup. So focusing on the screening where I said, hey, this is where you get your only the abnormality versus normal or negative. There's only 3 scores through the breast imaging reporting and data system, the BI-RADS assessment, 0, 1, or 2. Okay, period, the end. Yeah, that's what your report should say. The 0 for the callback is not just an abnormality. Sometimes it's even used for saying, I don't have your prior. Please bring your prior imaging back so I can see if this is normal, right? So 0, 1 or 2 is negative, or 2 is benign. I saw something, but I know it's a normal cyst, for example. Okay, 0, 1, 2. So really, for somebody who's going through a screening test, I would be really nervous, right, as a patient, if I was getting a 0 compared to 1 or 2, because I know 1 or 2 come back in a year. 0 is like, I don't know what's wrong. Do I just bring you my CD, or is there something wrong with me? Okay, so this is a real AI tool that's being used in the US across several institutions now. And you'll see that there's 2 different findings on the right craniocaudal breast, and as well as the left. And you'll see that there's a 79 score for a calcification here, and a 49 score for a mass, quote unquote, on the other side. And I just want to highlight here that they take the highest region score, and they give you, it points over to the elevated region here. There's an abrupt cutoff at 75 and then 40. No explanation of what those numbers mean, by the way. And then it gives you this score of E. Did you see an E, hopefully if you're paying attention, on the BI-RADS scoring system? No, right? As a clinician, there is no direct tie back to the tried and true clinical method of the BI-RADS guidelines 0, 1, or 2, but there is now EIL, theoretically, that should align with elevated, intermediate, and low. And of course, if you fall in that elevated category, maybe you'd be confident saying, okay, I've got to come back anyway. But what if you were the I or L category, right? Is it that you would trust this model to say, hey, it's okay that it gave me a 0, 1, or 2 from the human side? All right? For our system, how is this recorded? We put this wording into our reporting, and we have the traditional report otherwise. So this only goes in the technique section. It doesn't say anything about the EIL scoring in the actual report. We just say an AI tool was applied to mammography images and tomography slices for recognition of suspicious findings and used as a concurrent reading aid. That's where that goes. Okay. And I want to highlight one more application here is the screening mammogram use. So aside from that traditional use of the EIL for 012, you have this, the risk-based prediction, future cancer risk, right? And here is the report that you might get. You have a 1.3% estimated 5-year risk of breast cancer. And that's what you get as a patient, right? Is this okay with you, and what would you do with that information? I'm not going to ask you right off the bat, but I'm going to post this thing, right? Is a weather thing is probably the most similar. What about the weather next month or next year? Would you trust the snow prediction in 2027 or in 2032 in this case, right? 5 years down the line that how likely you are to develop breast cancer. And that's where I think the maturity of the tools are. If you don't trust it for your weather report and how accurate it's anchoring on that percentage, how are you trusting it for your specific care? And that's a question for me ethically. And my last thoughts, I know I'm a little bit, I think, over time, okay, is this is a survey that was done, and I want to do it here with the audience. Should patients be able to opt out of medical AI being used on them, yes or no? Hand raises? Yes? Okay. Unsure? Okay, no, they shouldn't be able to opt out. Interesting. That's an interesting spread. So this is what the actual result was from this one institution in the South. They said that 91% of their patients that they surveyed preferred to be able to opt out, right? And I wish I could break down the room and who had raised their hands, patient versus data scientist versus clinician. Unsure was this percent, and then no. All right, next question. If AI was applied to my medical images, I should be informed of the AI results. You strongly agree? You want to know the AI result. Okay. You're neutral. Okay. How about strongly disagree? I don't want to be informed of the AI result. Okay. Interesting. That's interesting. How about if AI detects 10 additional diseases my doctor could miss, my insurance should pay for this service? I'm getting some laughs. Okay, strongly agree. Okay, good. Neutral? Okay. Strongly disagree. Interesting. Okay, so people want people to pay for this. All right. So here's the actual result. And they broke this down actually by socioeconomic status and the differences in answers between those groups. So if AI was applied to my medical images, I should be informed. Interestingly, the high and middle socioeconomic statuses said yes. Low socioeconomic status said, not sure. Maybe because they don't have the context and understanding and educational level maybe to interpret that. I don't know. That's a hypothesis. And a lot of people agreed that overall people should be paying for this. Very fascinating conversation there. All right. Last question here for you is, how should radiologists report discrepancies with AI? First one, provide summary, explain disagreement, unsure, and then provide summary with no result. First one, provide summary, explain disagreement with AI. So you like the AI concordant, discordant blurb, okay. Be unsure. Okay, you're unsure a lot of things. Okay, last one, provide summary, but no AI result. Just tell me kind of what you think gestalt-wise. No? All right, here's the final result. That the patient preference was indeed provide that summary and explain how you disagreed with the AI tool. I think this is very interesting for the liability perspective, or I know we're going to hear about that from the legal perspective later maybe, and it's just going to be fascinating to explore that ethically later on. And I do want to highlight really quickly the generational gap here. How people want to be communicated with is a different question. I think I want us to explore as well that Gen Z actually does not prefer email. Look at them, 31% prefer email. And everyone else kind of has this gradation of whether or not they prefer text messages, phone calls, video calls, social media to be communicated with. So aside from all the like, oh, do you want to know about AI? I'm like, do you even want my radiology report? Like, you're not going to read it. I think you want it as a text. Okay. And this is my last thought, is in the stroke journal, one of the very top journals in medicine, there was this diagram that showed the door into treatment of a standard of care algorithm, standard of care workflow. It takes 206 minutes. And so if, of course, someone said, let's do AI-based care, it's going to save us time. It only will take 86.7 minutes compared to 206. Isn't that fantastic? Somebody's missing from this AI-based workflow, and I'm just going to put, again, a box sign now about who is missing from this workflow. Radiologist, ED physician, neurologist, interventionalist, all gone. it's only going to be AI-based, fully autonomous, right? That's exactly what everyone wants. So this was published in 2022. And so my quote here is, be part of the innovation in human AI interaction. The medical profession has made a mistake in not shaping the creation, design, and adoption of most IT systems in healthcare. The same mistake can't be repeated with this current era of AI. So my request for you is please give me some thoughts and feedback about what you think about AI in radiology and beyond. Thank you so much for listening.
Thanks, everyone, for letting me present. So my name is Gabriel Bratt. I'm a surgeon and intensivist at Beth Israel Deaconess Medical Center. I'm also a bioinformatics professor at Harvard Medical School. I have no relevant disclosures. So I'm going to talk about basically the application of AI in surgery. And about 6 months ago, there was a paper that came out that really caught the attention of the public because all of a sudden it made people think that maybe this future of autonomous surgery was going to be a reality. And basically what they showed in this paper is that they could get a large language model to control a surgical robot to perform a part of a surgical procedure, in this case, the removal of a gallbladder. Now, while that future is very exciting, there is a lot to surgical AI that comes before that. There is a lot to think about the scenario where these systems interact with humans as opposed to replace them, and where we think about the processes of augmentation. And Dr. Brinkley so nicely spoke about this idea of collaboration, and it's actually the thing that I'm going to focus on as well. But just to build on Dr. Du's work, I'm going to give an example of how to frame this idea, where there was a paper in 2023 where they looked at, in a simulation environment, the collaboration between a radiologist and an AI system. And what they basically showed that the performance of the radiologist was actually in some ways negatively impacted by actually interacting with these AI systems that were providing recommendations. They actually talked about this idea of automation neglect, which I think is really relevant in this case, which is where the radiologists were presented with the recommendations from the AI, and instead of improving their performance relative to their baseline was actually worsened because of that interaction. So in other words, the radiologist by themselves had a certain performance. The AI by itself had a certain performance. But when it worked together, in certain cases, it actually caused worsening of the overall performance. This is a counter to the other form of automation bias, which is automation where a clinician, instead of, as Dr. Brinkley mentioned, instead of resisting an AI algorithm, they are actively deferring to that algorithm. So basically we have these two ways of thinking about these systems on opposite sides. We have automation neglect, where you're essentially actively avoiding the system, versus automation bias, where you're essentially deferring to it. And that system, that conflict, that dilemma, is the thing that we have to think about quite often. And so in surgery, the examples are few. But I wanted to kind of premise on two ideas that I think are central to how we might think about the application of AI systems in that discordance in surgery. And my first premise is that there's this thing called predictive coding, where our brains produce mental models of the world at all times, and we expect the world to essentially validate those mental models. And when the world validates those mental models, we get a sense of wellness, we get a dopamine hit. The great example is when you're sitting in the car and you're singing along to Taylor Swift, and the song comes up exactly the way you expect it to, that feels good. Have you ever wondered why it feels good to sing along in the car? So if suddenly we were to change some of the words to that song, the sense would be actually quite jarring. And so that is called predictive dissonance. That dissonance is inherent to the processes that we're talking about. that dissonance is when conflict arises between your expectation of what is right in the world and what actually comes out to be the case. So if you have an AI that is telling you something that is in conflict with the way in which you expect the world to be, that conflict, we have to acknowledge that there's going to be some level of discomfort around that effort. And especially in high acuity situations, when you have to deal with this conflict, you can imagine that if you have the choice between dealing with this conflict or falling back on your learned responses, whether that be automation neglect or automation bias, that is more likely to be what you're going to do in certain cases. And so I want to just, as a first premise, I want to point out that there's always going to be a discomfort around these conflicts. And there are many asterisks to this. Of course, when we are not invested in these systems, we have a different perception. There's a different way in which we think about this. And you can always change this, and this is what we'll talk about. But at the end of the day, there has to be some level of conflict around that discordance. The second premise, which is maybe a little bit more provocative, is that AI systems are only really valuable when they are in that left upper quadrant. Because if the AI and the human agree, then why did you need an AI? And if the AI is wrong and the human is right, then why did you need an AI? And so the only scenario where really AI has value is where the human has a certain perception of what the world is going to be, and the AI is telling them that they're wrong. And so if you take these two premises into account, it basically points out that inherent to any AI system being of value, it has to essentially come into conflict with the humans that are actually using those systems. And so the best example of this inherent thing, this is my daughter being told that the only way that she's going to get her iPad to actually work is if she plugs it into the wall because it's out of power. And so there is a total conflict between how she sees the world, where she thinks if you just put that little adapter on there, that it's going to work. And what I'm telling her as an AI system, where I'm explaining to her that her view of the world has to be updated. And that has to be, instead of a conflict, it's what Dr. Binkley said, we have to think about this from the perspective of collaboration and that transition from one to the other. So I'm going to give a few examples that I think are relevant to this conversation. And I think it's really, really important to say this in advance, which is that in the field of surgery, if you looked at Dr. Du's slide, there were 6 FDA cleared devices in the field of surgery versus 1,034 devices in the field of radiology. And this says something very clear about the advancement of these systems in these different fields. And so I don't have a lot of examples of the ways in which these tools are coming into conflict today, because the reality is these systems are not being implemented clinically because we haven't figured out how to address this process just yet. And so part of what I'm going to talk about is kind of a little bit of a thought experiment to take us from where we are right now to where we can be. And I'm going to highlight what the conflict is, and then I'm going to highlight, at least in these situations, how people have thought about addressing this conflict. Because, as I said, inherent to the value of these tools is to essentially raise this conflict in clinical decision support. So here's an example of surgery trajectory prediction. This is the outcome modeling that was mentioned before, mortality prediction, or what's going to happen after surgery. This was a paper where the folks at Florida had developed a system over a course of multiple studies where they've shown that the algorithm actually works much better in the pre-surgical period than the surgeon. So it is well known to the surgeons who were part of this study that the algorithm performs much better in its predictive capability, both overall in terms of mortality, but in terms of actually the subforms of morbidity. And what they did is they presented these physicians with these cases. They asked them to essentially rate their risk. They then showed them the risk score, and they asked them to update their risk prediction. And they evaluated their interaction with the model. And functionally, what they showed is that there were no substantial differences not only across mortality prediction, but across any of the ways in which the surgeons were changing their behaviors, across all the different ways in which the prediction was actually presented to them. So in other words, the surgeon did not change their behavior based on the risk prediction score. Now, you can argue that this was done in simulation, and there are other things that are very relevant critiques to this, but at the end of the day, despite knowing that the model works better than them at doing this task, they did not change their prediction. Okay? And when they were then asked why not, only half of them thought the algorithm was helpful and innovative, but they did think that it was providing information that was somewhat useful, but somehow they didn't change their model. What's fascinating is there was a similar version of this that was done and published just last month in Nature Communications, where they did a randomized clinical trial in the emergency department with a version of a similar tool, but for the ED. Highly performant. Everybody knew it worked better than the ED docs in terms of its outcome measurement. And yet, when they asked physicians to change their behavior, and this was in real life, so this was no longer in a simulation environment, out of the 650 patients that were part of this process, they only changed their treatment once. And so the 0.16%. So the question is why? In both these cases, the failure is that the information that is being provided to them is not being provided in a way that is actionable. Telling you that the patient is going to be going to the ICU after surgery isn't necessarily something that says, well, this is what I have to do after the procedure in order to avoid this outcome. And so the conflict that is coming into play is not just one of disagreement between what reality is and what the prediction is of the clinician, but that the information is being provided in a way that obviously does not allow the clinician to act in a way that feels safe for them, because they can do lots of things, but that doesn't mean that they're doing something that is going to affect the outcome that is being predicted. And so one of the things that people are clearly thinking about is how do you provide these actionable statements? Let me give it a second example of this. So many surgeons in the United States do robotic surgery. And one of the aspects of this is that the amount of data that we now have access to from the intraoperative period is incredible. You know everything that has happened. Not only is there a video of the entire procedure, there's the movement of every instrument, the changing of instruments, the amount of time it took, who was at the console. Every piece of data about even the amount of heat that was applied to tissues is now available. And that information is available in extremely granular fashion to the surgeon across every procedure that they performed on this robot. To the point where not only can you see you can also see the path of every single tool during any part of the procedure, and you can use that as information to analyze how you look relative to other surgeons. And so you can imagine that with this type of data, not only is it valuable to you as the clinician, but it's valuable to compare and to understand what your skill is. And so in this space, there's been this move to provide some kind of feedback. And it's a very kind of unclear thing right now, but this is what it looks like right now. And to me, this says something fascinating, because the way that this information is being provided to the surgeon, it's doing something. It's trying to nudge them to say, this is who you are relative to your colleagues. This is the national average, and then this is the top 10%. Now, that is a fascinating statement, because it's not saying you're not good. It's not saying this is what you should be doing, but it's giving you a nudge. It's saying this is what other people like you, this is what they look like, and this is whether or not you are an outlier. Even though you may think you're doing a great job, this is how other people are doing this task. Now, the interesting question here is what happens once it's not just the surgeon who has access to this data? And that's one of the questions that we're going to discuss later, I'm sure, today. But the interesting point here is you have data that is extremely valuable. But the question is, if these systems are actually able to make surgeons better, is the best way to get them to change their behavior is to essentially say, this is what other people in your field look like, that this is what the standard of care should be or is. The x-axis is the number of cases. So this shows that on the national average, over the number of cases, this is how much time it takes them to do the procedure. So I'll give one last example, and this is really kind of a little bit out there, only because this clearly doesn't exist right now, but I wanted to just kind of give it as a possibility. So when we now have a number of tools that in research have provided intraoperative surgical guidance. One of the early ones that got a tremendous amount of attention was this idea when doing laparoscopic gallbladder surgery that you could have a computer vision algorithm overlay what are called go, no-go areas. And so this is an area on the screen where it says, you know what, you as a surgeon should be operating there. And this is another area on the screen where you as a surgeon definitely should not be operating. And the idea is that with this type of information, that it would help surgeons actually be able to more safely operate. Now, there's a lot to be said about this because it's very clear that for the most part, the scenarios where it's obviously go is the areas where the surgeon already knows to go. And so the only scenarios where these tools are useful would be if they're providing you a go or no-go recommendation for a location that you're uncertain. And for the most part, these tools, it's not clear that they can do that task. But let's assume that they can, okay? And so the question becomes, so how do you build these tools in a way where they're providing the kind of collaborative assistance where they're telling you, you're about to do something wrong, you're about to do something dangerous, you believe that it's right, but it's a no-go zone. And this is a fascinating problem because at this point, you have your experience, your training, all that you've learned as a surgeon, and it's coming up against a tool that is telling you that you should not be doing this, the thing that you're about to do. And how do we actually do that in a way that is both safe, assuming that the tool is actually right, and that actually respects the autonomy and expertise of clinicians? And so I think that, let's see if this, hopefully that works, yeah. And so there are a number of ways that companies have thought about doing this. This is in no way an endorsement of this company, but what these tools can do is they can essentially expand the amount of information. And if you look at what they're doing, is they're personalizing the explainability of the data. So they're making it so that the information is available to the clinician in a way where the recommendation is provided in a personalized, valuable fashion so that they can say, you know what, in this case, I agree with this. Now, this is not going to be possible in all scenarios, but at least this is moving in the direction of the idea that different people need information presented to them in a way that is useful, and that's not necessarily a generic thing. I love this paper because this paper was a great example of the thinking about this. So this group wrote a paper where they presented a surgical AI tool that was doing automated computer vision analysis of a surgical field. And they asked people to identify elements of that field. They then they published a paper on this. They then did a very similar task with a slightly different group of people. And they got the opposite finding. And all of a sudden, so then they wrote a third paper. And the third paper was, wow, we got two different findings of the same task, and why is that? And what they did is they essentially came to the conclusion that this thing that I just mentioned, this personalized explainability, is critical to making it possible for people to feel that they're working in a way that is collaborative, making them feel safe about using the data. And so when they had different types of data presented in different ways, they got different outcomes. And so what this suggests at the end of the day, that what we have in these systems is we have a scenario where if we don't provide that level of comfort so that these discrepancies are able to be addressed in a way that allows people to maintain their autonomy, the expertise, and to feel safe, then these tools will never be effective in the clinical space. This is just essentially a re-explanation of the same thing that I just said. But basically, we need to find ways in order to essentially overcome these discrepancies, to personalize explainable AI. We need to clarify what the standards of care. We cannot ask people to have discrepancies with these tools, but then not say what the standard of care is for how we should be handling these scenarios. And then there has to be a form of transparency that makes it clear for people to actually behave. If the next step, if the next action is either unsafe or one that is not clear, then there's no scenario where the discrepancy in accordance with these tools will actually lead to a positive outcome. And finally, and most importantly, we have to acknowledge the reality of what it means to be standing in the operating room, operating on a patient when you get this data, that this is a highly sensitive, difficult scenario, and we have to be respectful of the limitations of these tools in a scenario where everything is stressful and we're trying to do the best for each patient. So thank you so much for the opportunity to present, and I'd love to chat about all of this later.
Great. Thank you so much. I'm so happy to be here. I'll be talking about when and why AI in nursing practice may diverge. So I'm an associate professor in the Department of Biomedical Informatics, and I have a joint appointment at the School of Nursing here at Columbia, and by background, I'm a critical care nurse. Okay, great. I have no disclosures. And I'd like to acknowledge, though, my funding for several studies that I'll be talking about from Assistant Secretary of Technology and Policy, from AHRQ, from National Institute for Nursing Research, and from the American Nurses Foundation. So we need to move from burnout to balance for nurses and really for all of our clinicians. We have an opportunity with increasing, AI solutions. I think important to note as I begin this talk, nurses for the 23rd year in a row have been identified as the most trusted profession. But we should reflect on the fact that many of the IT solutions for nursing don't actually fully incorporate the nursing process and support nurse decision making. If you actually look at a lot of what we call the clinical decision support for nurses right now, much of it is telling them when their documentation is late. Now, when things go wrong, nurses are very well aware that they'll probably be asked one of these two questions. Why didn't you use your clinical judgment, or why didn't you follow the protocol? So let's kind of talk about some of the context of nursing practice. Now, interestingly, our electronic health records actually don't really capture the nursing process. That's the diagram that you see up here. You could start up there with assessment, diagnosis, planning, implementation, and evaluation. And so nursing diagnoses and planning are largely not captured in the electronic health record. Now, you may be thinking of the plan of care, the care plan in EHRs, but those are highly structured. And as the past few decades have evolved, those care plans largely look the same for all patients in the hospital. And so they're really not capturing the variation of the decisions that nurses are actually making and planning on an individual basis for their patients. And those arrows, purposefully too, are in the light blue to note that within our EHRs, nurses capture highly structured data, and we don't do a good job of linking the different data that they capture in terms of linking their actual implementation to evaluations and assessments. So this is information that's really missing within kind of our digital data sources. We also know nurses are burdened by excessive documentation, manual data entry. A lot of the information that nurses still record is manually entered. And so in a conversation in a day where we're talking about AI, we might forget that, but it's really important for some of the points later on. And still many usability issues. So they engage in workarounds, we know that. And there are implications for patient safety and burnout. So we've talked about kind of some of the current states. Important to reflect on that when you're talking about AI, data inputs are really important. So if we have incomplete data within our EHRs that's largely thought of as that's the nursing world, then there will be some issues, as well as absent of the nursing process in terms of inputs for AI models that are built. We may end up with some outputs that have divergence between nursing practice and prediction. So I think we really need to reflect on moving beyond these two questions to answering some broader questions from the scientific community, from the informatics community, really to support our nurses. Why is there a divergence? What is the AI missing that nurses observe? And what's the AI detecting that nurses don't observe? So I'll have several quotes throughout this talk, and many of them are from a study I've been doing with a national sample of nurses, where we've interviewed them over the past year, and so you'll see those throughout. So all the quotes here are from practicing nurses. And one here says, "You can't replace nursing judgment and nursing experience. So yes, AI to me is welcomed in this field, but I think it shouldn't be the be-all and end-all. There should be some built-in component for clinical judgment because you're at the bedside, you're laying eyes on the patient, and I think that's paramount." Now, one nurse said, "The idea of AI being fully automated without some human involvement really scares me." And then you see the spectrum to, I feel, cautiously optimistic. A few other perspectives. There's an opportunity with using AI. The bedside nurse can spend more time actually providing patient care as opposed to care, document, care, document, care, document. As long as it's well thought out and trained by clinically experienced individuals like yourself. Referring to, I have a research team with many nurse scientists on it. So we're now going to dig into some particular clinical scenarios. First, we'll talk about blood glucose management and insulin administration, a surprisingly hard problem. Then we'll talk about early warning systems, and then we'll talk a bit about ambient AI. So for this first scenario, what's so interesting about this is that I think at first glance people think, well, of course, this is a very common thing. We can model blood glucose variation and the insulin that should be administered. In the outpatient setting, maybe there's more advances in that area because we have some continuous blood glucose monitoring devices. But in the inpatient setting, it is actually quite a different task and quite complex. And just to kind of lay the foundation for what happens in the inpatient setting. So for a patient that's receiving insulin, it may be that they need it typically 3 to 4 times a day. They need it right before they eat their meals. In the ICU, they're receiving a continuous drip of insulin, and so it's more frequently checked. The key to it, though, is that you have to measure their glucose before they eat. And that you then, need to administer their insulin in a timely way then before they eat as well. And so the nurses here are saying the tricky part with insulin is that you're relying on so many moving parts. Hopefully there's a good schedule, but sometimes it's just a struggle. And so, I want you to think about why is it that it's been so hard to model this in the inpatient setting? Well, this intentionally busy diagram is actually all of the information over this past year that we've learned in our interviews with nurses that is important to them when they make decisions about insulin dosing and timing. Now, I'm a former ICU nurse myself. Sitting down to actually put this, to actually make the visual of this is wild when you actually think about all of the pieces that, are informing these decisions. And when we first talk to nurses, the initial reaction is, well, we just look at the protocol, right? And it's simple. But when you actually sit there to unpack it, it's quite complex. And so we'll just highlight a few things here. So some of those quotes. How much data can we pull from the EHR to help us make a judgment to manage the blood sugar? AI cannot predict how much a patient's going to eat, whether the patient is drowsy, sleepy, or they just don't like the food at the hospital. They want to eat outside food. They want Uber Eats. Patients don't always like their meals, and so we'll take blood glucoses and then we'll give them the insulin for their full meal, and then we'll come in the room an hour later and they'll only have eaten 30% of their meal. You have to give them the insulin before the meal. What's the best practice? What if your patient doesn't eat their full meal? Oh man, okay, do you want some graham crackers? Let's try to prevent this hypoglycemia. And so here in this diagram, you see, what's highlighted there. What is the likelihood of the patient's food intake? Many different factors that can influence that. And then what did they actually take? 50% of the time, though, patients don't want to wait. They're really hungry, or this might be the highlight of their day. I don't know if any of you have been hospitalized or you have family members who have been hospitalized, but lunchtime is a very big deal. And so they don't want to wait. They want their lunch, and they might not understand the importance of taking a blood sugar right before eating. So it's really hard to sit there as a patient and watch your meal get cold while you just wait. Like, when is my team coming to check my blood glucose? So why is that so hard? Well, you have to manage that with the meal delivery timing, which depends on what unit you're on. It might typically be an hour late, but you don't even know day to day when it's going to get there. And what's also really, I think, in terms of thinking about this case scenario, then kind of thinking about nursing in general, is the fact that your nurse is not only caring for one patient. And so certainly you would think, okay, well, let's just wait for that cart to come up and we're going to be able to quickly get in that room and check that glucose. That's not always the case, because you have to prioritize other things. Otherwise, you're not going to get anything done. Which patient do I prioritize? Is this insulin administration a higher priority than me going in to check on another patient who's had a status change? Where is the priority? It's really hard when you have really tough patients. When all of your tasks seem really important, it's hard to prioritize something like insulin. I understand the importance, but so many patients have insulin, where other tasks sometimes feel more prioritized because it's just at every meal. So the really interesting complexity here is that because it's 3 to 4 times a day, it actually it can be more challenging to prioritize it highly. And so, you have other patients' needs that you really have to account for. So moving on to scenario 2 here. I'm going to talk about an early warning system for clinical deterioration in the hospital setting. For years, for decades actually, we have known that a nurse's concern about the risk of patient deterioration in the hospital setting is a recognized and valid reason to call a rapid response. But that was subjective concern. We could never actually measure that concern. But I co-lead a study called the Concern Early Warning System Study with Kenrick Cato, and we have successfully measured that concern. So we're actually measuring tacit nursing knowledge. And the way that we've done this is by modeling nurses' behavior in their interaction with the electronic health record. And so we've looked at entries with increased frequency and entries done at uncommon times. So what does that mean? When a nurse is worried about a patient, they are in the room more frequently. They're taking more vital signs, and they record those in the EHR. And it's not just that they're taking more vital signs, it's also that they're doing it at uncommon times. So for your med-surg patient who should be sleeping through the night, they're doing this at 3 a.m. They shouldn't be going into the patient's room at 3 a.m. Under normal circumstances, perhaps for that patient. And so that rises up as a signal. And we built an AI model. We've used machine learning and ensemble-based modeling to detect these changes in patterns. And we've been able to model nurses' concern, identifying patient deterioration 2 days earlier than other early warning systems. We've built that into clinical decision support, where it shows a red, yellow, or a green icon to indicate the level of risk for deterioration for that patient. And in a multi-site randomized control trial, where this alert is shared with the care team, with the nurses as well as physicians, PAs, and NPs on that clinical unit, we did show that for patients whose care teams received this alert, and this was of over 60,000 patients, there was a decreased risk in in-hospital mortality by 35.6%, decreased risk of sepsis by 7.5%, decreased length of stay by almost half a day, and earlier ICU transfers. We were thrilled to have colleagues from the University of Utah independently validate our modeling approach, and they used the eICU dataset, which is an open public dataset of 200 ICUs, and they showed that it is reliable, reproducible, and generalizable in terms of looking at these patterns of nursing documentation. So I'm going to talk for a minute about this within the concern study, about this concept we've been able to unpack of early versus late ICU transfer. If you look at the literature, it's not well defined. If you ask any clinician what's the difference between an early transfer and a late ICU transfer, they're probably going to tell you a lot. It's hard to define in the literature because it's hard to measure. So deterioration isn't something that we've really been able to measure well. We can measure the event, we can measure the mortality, we can measure ICU transfer as an event or sepsis occurring as an event, but that actual process of deterioration is hard to measure. So we took the opportunity from the trial that we did, since the concern score runs hourly, to use that score as a measure of deterioration. And we looked at that for all the patients in our intervention group, and then looked at this duration of time from the score change to ICU transfer, and then looked at those patients' outcomes to see what it meant. So here we're just looking at patients who had an ICU transfer in our intervention units. And what we found was that all patients who died were transferred more than 36 hours after the score change. So really demonstrating this early versus late transfer matters. Each 1 hour delay of ICU transfer increased odds of death by 28%. We've also, in the concern study, done work to look at the concern score generation with nurses' agreement in terms of them actually looking back on chart reviews, because this, is an important thing for us to establish, and found high agreement there. So how does this really, what is the context of this when we're talking about AI divergence? Well, one really interesting thing to think about is nurses have been experiencing this concern for years, but there hasn't been an actual score to support that concern. And so there has been divergence in terms of nursing concern and perhaps sometimes the ability to get that early ICU transfer, because there wasn't recognized objective changes to the patient's physiological state. Because at this point, the vital signs are late changes. And so the patient's vital signs may still appear to be normal. But if we really think about here, we were able to model nurses' concern and align with that. But if we have other types of AI models that aren't using the nursing process to incorporate into them, those really may have later predictions, which would be a divergence from when the nurse is concerned, and we have that subjective concern from a nurse that we actually know is associated with outcomes. I want to shift gears a bit here to talk about ambient AI and its influence on practice patterns. And first to start, my focus in talking about ambient is not that nursing decisions will differ from ambient, but actually to reflect on the fact that ambient will change our data inputs for AI models. Now, I actually have used this slide in many different talks because part of my research is focused on documentation burden reduction. And so we do see ambient AI as a real potential game changer for that. And for nurses and physicians, it is looking like there are a lot of positives for it to reduce burnout, reduce documentation burden, increase data completeness, enhance care relationships. Now, we're still really early on here in these tools, and really early on in nursing implementation of these tools. So there are absolutely potential pitfalls, and we have to study these. Unintended practice changes, not monitoring for new inefficiencies, errors, and burdens, over-reliance on clinician and patient vigilance, ignoring cognitive science principles in our implementation, and defaulting to labels of system training issues and user blame in our implementations for them without really exploring how these fit best with workflows and new workflows. So I propose we certainly need a culture of AI safety. Maybe we need training simulations to really explore how these should be best fit into practice. And we also need ways to continuously capture feedback from end users. And we haven't historically done that very well. Capture real-time feedback and maybe lean on some AI tools for that. Now, why, again, does this matter when we talk about AI divergence? There's a lot of thought that ambient AI tools will really change nursing practice patterns. And so that will change the data that's available in our electronic health records. And this is likely going to be a continuous cycle that we're a part of, and that we have this kind of real-time experiment happening as new AI tools, emerge. And we have to be really aware of the fact that we're in this continuously changing state, and it's not just the outputs in our tools. And we all know about AI drift, but to really recognize that our actual inputs here are greatly changing over time. So in summary, why is there a divergence? Well, one reason, and I think that there are probably several that I haven't even been able to explore, but is that AI inputs really matter. The EHR is missing key activities in the nursing process and decision making. Multimodal data will be really important. We don't tend to have that yet about nursing care and nursing practice, and the need to model approaches that capture the nursing process and nurse decision making. Nursing expert involvement is needed all along the AI development pipeline. we have to answer these questions. What is the AI missing that nurses observe, and what is the AI detecting that nurses don't observe? So the opportunity for AI outputs that do leave room for nursing judgment and this feedback cycle. And then really be open to exploring and continuously evaluating how this divergence changes over time, because our inputs and the data that we're capturing from our clinicians is going to be greatly changing in the years to come. Thank you.
Well, thank you for those terrific talks. So now we have time for a Q&A. And we had planned a half-hour Q&A and an hour for lunch, but we're actually going to change that. So we'll have a good hour for Q&A and less time for lunch. So if I can have all the speakers come up here. All right, so the question was the relation of the nursing strike that's going on at the moment and AI.
Yeah, I mean, my area of research doesn't relate to, it doesn't focus on the nursing strike. So, I'm not going to kind of comment about that specifically. But AI in terms of nursing, there's a lot of research that we need to do. I think that, I included some comments up there, quotes up there from nurses that we've interviewed over the past year. And there's a spectrum of perspectives about it. And there are different sites that have implemented some AI tools to different measures. I think I would say as a nurse, informatician, and researcher, we need to make sure that we're evaluating these tools as they're implemented. And including, evaluating them with nurses and make sure that they're designed with them.
Okay, next question is from online, Dheeraj Nagpal. In the medical legal environment which we live in, how much should we be worried about the hallucinations and confabulations AI is famous for? So, anyone on the panel want to comment on that?
I think someone else may be mentioning some of this in a separate session, but very briefly, I think when you're mentioning confabulations and hallucinations, it's more with the LLM, generative AI-based tools. And I will say that for now, in radiology, we have some impression generators. So we'll take the base findings and summarize everything you were saying and make it into an impression. Fortunately or unfortunately, right now, everything has a human touch to it. So a human still reviews the report. So at the end of the day, the radiologist is responsible. And I feel like for now, that's medical legally, that's where some of the burden still lies on the physician and human. When it goes to this autonomous version of that, that will be a very interesting medical legal battle because right now it's from I think the patient perspective and legal perspective, everything still looks like it's physician only because of that interaction.
Comments? Questions from the audience? Yes. Just wait for the mic here, sorry.
My question is in terms of AI governance. How does that process work at the hospital?
Yeah, it's a great question, and there's been a few iterations of that. So the way it works is every technology that comes into the hospital goes through what we call the ITPMO, which is a process and we review things like information security, whether the person who's interested in the technology has money to pay for it, very important, architecture, and a variety of other things. And that's true for every technology. And then if a technology has an AI component, it comes through a sort of an off-ramp of that process into our AI governance committee. And we review the 3 risks I discussed earlier in my talk. So the risk to patient privacy through model training, the risk as a result of replacement of physician decision-making by an AI tool or augmentation of decision-making, and then regulatory risk. And so we review those 3 risks. We have a knowledgeable data scientist write up a summary, and then a 15-person committee consisting of privacy, regulatory, clinical, technical, and risk. I almost forgot the 5th. Experts from all 3 institutions meet every 2 weeks and review those summaries. So we have a discussion about any kind of ambiguity. And then if a technology is deemed to be medium or high risk, we actually have kind of formal decision trees that we're working on that help us be more standard in this process. We have a team within the data shared service, which is my team, that will actually help the person design an appropriate evaluation. And so there's several pieces to this, right? Which is the process is actually, it's new enough that those first pieces are pretty well worked out, but then the evaluation piece, we're still in the early stages and we haven't seen a product that's gone through an entire cycle of evaluation and come back through yet. So we're really excited about that. I'll also say one more thing. Sorry, I could talk about AI governance forever, so you're probably sorry you asked. We are partnering. I really believe that with the volume of products we're seeing, we need some kind of commercial solution to be able to monitor all of these products continuously. We can't just do it on spreadsheets and ad hoc because the volume is too high. And so we're actually partnering with a startup company that has developed an AI governance solution, and we're kind of co-developing it together to try to see if that will serve as a place where we can sort of have everything running and then the outputs monitored and have the ability to communicate about the products and any kind of adverse event observations or anything about the products. So there are a lot of pieces here, and I think a lot of health systems are struggling or thinking about each piece. Kind of how do you evaluate the technology initially? What do you care about in terms of risk? Then if it's deemed to be sort of highish risk, how do you design an appropriate evaluation to combat that risk or to be able to understand that risk? And then how do you monitor it going forward? So it's multiple pieces.
And just to add to that, just sort of zooming out for a little bit, the model that Beth described is basically, I think, the model that most large health systems have adopted. There's sort of lurking in the background here is that many health systems, we're sort of designing it as we go along. There's not great external guidance on how to do this. There's some national organizations that are trying to help health systems think about what's the ideal governance structure. Particularly, how do we think about governing throughout the AI lifecycle? Both from the use case, like I have an idea that I'd like to propose, to decisions about decommissioning, right? Because we really want to think about how do you govern it, and because, as Bev said, most AI solutions are really in the beginning of the life cycle. We haven't really built out those robust structures to address things that occur later in the AI life cycle. One question, one governance question that I hear lots of people asking is about vendor buying an AI solution, bringing it in. And then how do you do your due diligence, right? How do you think about governance of something that you don't really control? And what is the right level of due diligence in assessing a vendor tool, particularly when, unlike a medication or a medical device, there may have been clinical trials, there may be the opportunity to actually look at outcomes data. For many of the AI solutions, what you're going to get is validation data rather than showing how it is actually clinically beneficial. And there's oftentimes a gap there. Right? The most accurate AI solution may not actually confer a clinical benefit if it's not integrated in a way that promotes that outcome.
There's one more comment, something we've seen recently. I think it's easy to imagine for simple AI algorithms that are making like a single prediction. You get the prediction, you get some kind of measure of the gold standard, you compare them against each other, you make nice graphs of positive predictive value, you have error bars, and you're like, oh, if the thing's out of range, we throw an alert. Like, that is a beautiful picture, but hopefully you saw from the variety of products that I discussed this morning, that's not always possible. And one thing we're seeing is there are frequently products where you don't have access to any of the model outputs, or the model predictions or whatever the model's doing are embedded in the workflow of the tool. And in many cases, that's proprietary information for the software vendor, and they could have multiple different models working in tandem within their product, and they're not willing to tell you anything about them or give you access to any of that stuff. So what the heck are you supposed to do to govern that, right? It's a soup in there. And so we're really thinking a lot about communication around the products, some kind of human in the loop, some kind of surveys. What are the ways we can start to address these risks when we don't have access? Or maybe in the future, these companies will be forced into providing access to some of this stuff. I don't know.
Okay. Oh, yes.
Oh, I was just going to add, actually, as you spoke about that last point, there's an element of this governance piece that is even kind of a second order effect here, which is once these tools are in place and we are concerned about issues of drift and changes in the ways in which they perform. And yet when the tool has now taken over a certain task, you have no way to continue to validate that tool because you have nothing to compare it against. And so you can give the example of registry-based systems. If you have a registry tool that has now replaced all the people who were doing the task historically, the only way that you can continue to validate the tool is by bringing people back to do the task manually again. And so there's this very strange reality about what is required in order to ensure that there's appropriate governance that really requires a complex set of analytics around which people do you need at which time in the life cycle of the tool.
Okay, so here's a question. There's a few like this. This is from Mackie Immaculata Rondon online. Dr. Binkley, when will human judgment and AI recommendations diverge in clinical workflows, and how will this affect physician training and doctor's touch? So there's a few questions about clinician education and loss of doctors' trust, or there's a question for Dr. Du about you're having essential human input somewhere. So just some concerns about that.
I can say a little bit about medical education, resident education, and formation. I think we really have to start thinking about these sorts of things, how to integrate AI into medical decision making at the level of medical students. I'm on the AAMC's AI competencies working group, and we are developing AI competencies that will be the standard that medical students and that medical schools will be guided by in terms of curricular integration of AI. Again, I think we're going to have these three buckets. We're going to have things that very clearly the collaboration between AI and the human is going to be better than the human alone or the AI alone. And so what we really want to think about is that responsible use. And again, those two poles that we've talked about, there are going to be some decisions that are going to be very high stakes. And I'm hoping that the disagreement, divergence is really the minority. But when they do happen, there needs to be a process in place for how to address that, so that people aren't just left hanging and wondering, what am I supposed to do? What I would like to avoid on a large scale is kind of a new wave of moral distress, to use that term. Right? A new wave of not knowing exactly how to proceed, but feeling some potential pressure to acquiesce to the AI solution simply because it's the AI solution.
Can I? There's this big push for the idea that the thing we need to do is to educate students and educate clinicians around how to use AI tools. But I think that actually is very complicated, because when you have 12 per month, when you have 12 systems per month that are being evaluated, there's no way for any clinician to be able to effectively have the set of tools necessary to essentially know how to use these models effectively. And so actually we wrote a paper about thinking about what an algorithmic consultant might look like. And we actually said something that I think was a little bit provocative, which was that algorithm consultant doesn't need to be a physician. If you look at the system, if you look across healthcare right now, there's a system for a algorithmic or a consultant that is very effective, which is pharmacists, where what they do is they are experts in understanding how drugs work. And so when a physician is approaching how to use or prescribe a drug, what they do is they talk to the pharmacist. And the pharmacist says, well, when I look up the data on this drug, here are the risks. And that pharmacist is also in the background evaluating the use of these tools in a way that makes them safer. To me, that model is much more likely to be successful than one where we continue to put all the pressure on the clinicians and lead to that kind of moral distress. Because even if I completely change the training regimen of my medical students, in 10, 15, 20 years, what AI is will have changed again. And so we will just be as unsure as we are today. And so to me, the systems that need to exist, they need to exist external to the clinicians in a way that is supportive, but actually doesn't take away from their autonomy.
So in my slides, I don't know if I just remembered, I don't think I put this in there. I had used artificial intelligence as a trainee. So I was in that batch of people who had gotten it in my second year. So I had 1 year without AI. Starting in my second year, I started having it. And how that affected my educational journey was a little fun. And I will say this, I had asked the question at the beginning of how many of you had used AI, And part of it, I'm sure you watched some videos on how to use it, but some of it was just exploring it and figuring out what worked and what didn't, right? And those kinds of lessons and thinking deeply about that kind of informed how my slides developed and how I thought about artificial intelligence. And in our field in radiology, a couple things have come up. One is the question of something similar to cursive. So I know in the educational system, in elementary school, people suddenly are not writing in cursive. I don't know if anybody knows still how to write cursive in this audience. Maybe in a decade or so, I'm going to have a different answer. I had heard on some podcasts, though, that the unintentional consequence of not writing in cursive was that people's flow of thought had suddenly changed. Like there's an inability to have fluidity of thought that was truncated in younger generations. Very fascinating side consequence, right? Why I'm saying that evidence thing is that one of our attendings had gotten a call from the VA next door, Veterans Affairs Hospital, next to the School of Medicine. That hospital does not have AI turned on. Our hospital does. And the third-year resident, for that pulmonary embolism case I just showed you, called over to our main hospital and said, Dr. So-and-so, could you help verify that the pulmonary embolism is there? If you're not a radiologist, you won't know that that's highly concerning because a third-year resident is 1 year away from graduating, and so that should be a very basic skill to have to just be able to look through the arteries. And that was a missing skill. So I was a little concerned, I think, to how would we go backwards to figure out which skills were being lost, right? And which kind of unintentional consequences were not apparent right away. And then comes the next question is, as AI evolves, right, and maybe in a few years we'll have a foundation model that does this 100% of the time accurately, maybe it's supposed to be lost, right? We don't have typists nowadays, but that used to be a whole career. Maybe the pulmonary embolism detection will be so good that at some point we will have autonomous AI, and this will definitely be a skill that will be gone and should be gone. I don't know the answer to that question. And the last thing I do want to point out is from the nursing example, I loved that example, is so many of those things, now that you've done those examples with me in radiology, a lot of that thinking is not written into my report anywhere, and it's not stored. And those types of things, checking, verification, synthesizing all that information is not clear in our educational system, I think. And a lot of it is experiential, which is why we make people do residencies of needing to do the thing. And so I don't know the answer to how do we shape our education, but I do recognize it's actively evolving. And if anybody would love to collaborate on this, I have lots of thoughts. I would love to hear yours as well.
I think we're at a point of exceptionalism where we don't yet feel comfortable turning certain things over to AI, yet at the same time we're finding that there's benefit. Now I think about like ambient AI scribing and nursing, and then for physicians, and it's, writing the note is where many of us do our reasoning, right? So if we replace that with an editing function rather than a composition function, we're editing a note rather than writing a note. Where's the reasoning going to happen? Even if you're an experienced clinician, writing that note is oftentimes your sort of system of checks and balances. Did I miss something, right? Did I order everything that I was supposed to order? Did I say everything that I was supposed to say? So that's something that we're thinking about actively in medical education. Where do you create a space for medical reasoning to occur if it's not occurring in the composition function?
If I could just add one note, jumping off of that, some really interesting data for nurses with ambient is, and this is coming out of Cedars-Sinai pilot study, that the more senior nurses love ambient the most. So you don't often see a new technology roll out, and it's the older, more experienced ones that are loving it the most. So actually for several decades now, nursing has moved largely to structured data, and they've taken the end of shift note away, which I think is a miss there in terms of being able to synthesize your day. But we actually have nurses that are more senior that perhaps when they started and were training, they were not using an EHR. They weren't bound to those structured fields. And so there was this much more fluid interaction, perhaps, of the assessment and then writing it down narratively. And perhaps this is now going back to, more of that feeling, which is really interesting.
Okay, here's a question. It's from Corbett Walsh. Hi, Corbett. How could we define which types of clinical uncertainty to involve AI and in which to protect or deliberately remain as human judgment? So there are areas that should be human judgment without AI.
I mean, so we're actively thinking about that question specifically. And so I think it has to do, we're thinking about it from two perspectives. The first perspective and the most important perspective has to do with what data is available. And so the reason why there's uncertainty in any given scenario is because there's inadequate information available to somebody to be able to make a diagnosis or a treatment plan or some kind of, to make a decision about the system. And that lack of information has either to do with the fact that time hasn't progressed necessarily, or the lab isn't available, or there isn't a study that we can do, or we're time bound in a way that is actually limiting our ability, or we're in the operating room, some kind of thing that is limiting the amount of information that is available. And so in those scenarios, whichever entity has access to the most amount of data is the entity that should be making that decision. And so in this case, so that's why the way that we're thinking about it is if you can look at situations where we have what we call algorithmic equivalence, where an algorithm looks at two individuals and they look identical, but there's a piece of data that a human has available to them, even it's the eyeball test, right, that has available to them that says this person is different from this person, then clearly, in this case, human has more information available to them. On another hand, if you have a scenario where the best decision is made by taking in the entire longitudinal course of the entire patient as it compares to what is happening right now, then clearly my ability to integrate all 430 notes that have been written about a patient is less than that of an algorithmic tool. And so the way that I think about this and to address that question is from the most simplest perspective is to address it from the perspective of who has the most data, and then to build the tools based on that. That has one very natural and quite discomforting outcome, which I will say in what we're thinking about, is that means that you should consider things like delegation as opposed to the simple versions of what we have now, which is any tool provides a recommendation and then a human absorbs that information, then it makes a decision. You could see a scenario where limitations of data make it so that the human actually shouldn't be making that decision and another tool should be. But ultimately, this has everything to do with who has access to the most data, and then that decision, that entity should be making the decision.
I want to add in too, I think we really should reflect on the growing opportunity to better understand human expertise.
Yeah, right.
And to try to unpack, what is that eyeball test? Why does it work? And once we can do that, we can actually find ways for, I love it, that collaboration with AI, because we don't want to lose that human expertise, but let's leverage it and let's compute on it.
Yeah, Sarah, I loved, by observing the nurses, the worried nurse is going to take vitals more frequently. And so I think about that, like maybe we should be incorporating our human behavior more into how we're training the models. And maybe that should be an important data source. Maybe it's that intuitive piece. And if I oftentimes get the question, is there a box that we should put certain functions in and leave them completely untouched? So I don't think there's anything in my mind that is so sacrosanct that we do that should be completely untouched. However, I think we have to think about patient preferences, right? It's not just about the cold calculation of, who does it better, right? There's also, would a patient prefer in certain situations? I also want to be cognizant of the fact that there are certain things that we can't give patients agency over. It would not be realistic to say, you can choose not to have AI involved in your care. It would be like, do you want not to have electricity involved in your care? But we do recognize patients' agency to say, I don't want certain ways, certain means of applying electricity used in my care. For instance, electroconvulsive therapy. So there may be certain AI use cases that either have some intrinsic value or are so risky that patients actually do have the ability to say, I don't want that. But I think, in general, we have to think about how patient preference is going to play into the use of AI.
So I think the themes that I'm hearing from here and in the audience so far have really actually centered around trust. And I remember I'll call it the advent of internet shopping, that when Amazon was created, right, people did not trust websites to buy things. And the reason why Amazon took off was that they picked books to start with, that everybody could trust that you get a book in the mail and there was no deviation from what you thought a book was. And now you buy anything and everything on Amazon. And why I'm saying that is here, there's this sense of gatekeeping, right, that comes with, oh, okay, so you have access to this AI tool and I don't have access to this AI tool and blah, 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 blah. And it's really an access to knowledge and information, who you trust at the end of the day, to get back to the question of what should be left to a human. I think, and it seemed to me from looking at the audience, that you all had different preferences on when you wanted to know something from the AI tool and where that was in relation to your job and your education level and your personal preferences. And I'll add to the person's question, hopefully from online, is I do wonder where, like, at what point do you get to choose? We do that for blood, right? So if you don't want blood transfusions in your care, you can choose not to have that. And for religious reasons, all sorts of things that we should accommodate, things the human experience should be accommodated for. And I wonder if AI can help us expand that access in very unique ways, but also question our human experience and what it means to be human. And I feel like that's really fascinating, because the art of medicine has been very quickly lost, I think, in the last few years of that. People have tackled, I think, the healthcare systems to be like, why can't you be engaged in my care? And that speaks to that trust level. And I don't know how we can codify trust in numbers and things. It's very hard for me to articulate. So if anybody has ideas about that, that's another thing I'd really want to think deeply about. So I'll give it.
I wanted to say, Gabe, I love the way that you framed that about the system that has access to the most relevant information should be the one that makes the decision. And I was trying to think about it in terms of examples from earlier and like, what does that really mean from a practical perspective? I think for things like signal and image interpretation, these systems are provably better in many cases. You know, there was an algorithm built here at Columbia that predicts whether a patient has structural heart disease from an ECG, and it's provably got a positive predictive value, twice that of a physician. And so it's a very interesting question of, well, should the physician be allowed to ignore that thing, right? Because it's frankly better than them. But then in cases where I was thinking about, like, the alternative would be some of the predictive algorithms built on EHR data, they really have access to very limited information, and there's incredible bias in terms of what gets entered into an EHR based on a patient's insurance status, how frequently they access the health system, how much they're willing to divulge, you know, all sorts of things. And maybe that's a case where there has to be a greater input from the clinician. Do you agree with that assessment?
Oh, I love that. We, about 4 years ago, we wrote a paper that for some reason is probably one of the papers that's gotten the most attention that I've written, which was called Standing on or Over the Shoulders of Clinicians. And basically the idea was that a lot of prediction-based algorithms are literally just looking at the tasks that clinicians are performing and then building algorithms on top of that. So it's exactly right. So although it looks like the algorithm knows more than the clinician, that's not the case. A lot of the stuff that Karen Deep Singh wrote about is exactly in that realm. The paper that we wrote, we showed that you could predict the outcome of the patient just as well by building a model on the behavior of the clinician, and as well as knowing the actual numbers of the patient. So what that was saying was that many of these models were essentially doing exactly what you're saying, where they were taking information from the electronic medical record, which was having already been filtered through the clinician who decided what to put into the record or what labs to check, et cetera. And that was deriving the whole thing. This is the whole point about these sepsis models, where the sepsis models use whether a clinician chose to get a blood culture of the patient. By the point that you've gotten a blood culture of the patient, you clearly are concerned about sepsis. And so how can you use that as a measure to predict whether you need to give a signal to the clinician? And in those cases, it's very obvious that clinicians have more data available to them when a patient comes into the hospital than any EHR-based tool.
Mm-hmm. A question from the audience here, yeah.
Hi there, this has been a really great discussion. I'm Chetan, I'm a pediatric informaticist, and I have a question that was inspired by being in clinic over the weekend around ambient scribe use, and also inspired by Dr. Do's comments on transparency. I was using the ambient scribe that's part of New York Presbyterian, and I actually had a parent ask me if they can get access to the raw transcript the ambient scribe generated. And I said, it's a really good question. I will find out. And so I personally think it's a good idea because, I know parents get access to the note that gets generated, but I personally think it's a good idea for families, patients, to get access to the raw transcript. But I'm curious to know what you all think.
I'm actually not even sure they're stored. I would have to double check that.
They are, yeah.
Okay.
You can access it in Epic.
So I will say that maybe this is from the perspective of a surgeon. There isn't that much that is actually going on in our conversations. I personally have they're all post-surgical patients. We're just following up on whether or not their wounds look okay. But I would never have any issues with my patients having access to those because in theory, that should be a representation of what is actually going on in the conversation. Just like I've never had an issue, our hospital was one of the first to start with open notes, and so I've never had an issue with the idea that patients should be able to see the discharge summaries or the notes that we generate for them, except in very limited situations. But this is just a more granular version of the document that actually occurred during that whole process.
Although I actually heard a story recently of, I think it was a hospital in California, where a patient's family wanted the raw transcript, and it turned out it was owned by the vendor who actually did the summation. And so the answer was no, because the hospital actually didn't own it, and the vendor said no for some reason.
Yeah, let me actually extend your question a little bit, Chatham, and so ask, how should we be retaining the records of our collaboration with AI, particularly if we're going to override an AI prompt? I mean, one of the things just using a radiology use case, and Flo, please don't hate me for always picking on radiology, but if there's if an AI-enabled CT decision support system identifies something in the pancreas, and again, not to be disparaging toward my radiology colleagues, but if I get my magnifying glass out and I call, Flo to come and look at it, and we both decide there's nothing there, should I retain those records that AI identified an area of concern? And so I hear this question being asked a lot about all kinds of different decision support, and not just the other thing that I'll say about data ownership is I was on a uniform law commission where I learned that we don't own our data. Everyone may know that, but and it was a bunch of lawyers. It was a bunch of privacy lawyers and me, and they were telling me about something about properties like a bag of sticks or something. I mean, there's property law. And apparently, I don't own my spleen, and so I don't own my data either. And so there's this whole, so what does this mean? Like, what does it mean that we don't own our data?
It means I can buy it if I want.
Right. Well, you can't. I mean, that's that was one of the legal cases, is that your data as an individual isn't valuable. Data is only really valuable in aggregate.
Thank you.
Other comments on that?
I was just going to say that the fundamental concern in all of these scenarios isn't the access. It is what people do with the information. The fear has always been, that person was literally in that conversation. So it wasn't that they're not exposed to that transcript. It's the fear that somehow any misrepresentation in the note may somehow be seen as a failure in care by the clinician. And so the issue has always been in these scenarios, it's about how do you take that information and understand it within the larger context of a broad healthcare interaction. And so the issues aren't about access, it's about ensuring that once that information is available, that it's used correctly, which is obviously a very complicated thing to do, but I think that it's important to just recognize that no one has ever had any issue with the data being available. It is only that it's trying to understand how do we do that in a way that actually makes that information access a positive thing for both parties.
So there's a question about cost, and we'll come back to the audience next. So smaller hospitals may not be able to buy these systems. There are disadvantages. What do we do? Thoughts about that?
There's a lot of discussion about that right now. I think it's an open problem. There are companies and labs and folks thinking about how can we test technologies in a standard way such that information is translatable from systems that have more resources to those that don't. And I think that's really the question from a technical perspective. How do we build up knowledge of how these products are working over time in different settings such that that information can be conveyed to health systems that can't particularly test new products themselves. It has not been solved, but the idea of we are going to be doing, I'll give an example, and it might be we're going to be doing continuous monitoring of some of these AI tools. And these AI tools are not unique to our health system. They're likely to be products that are purchased or deployed in many other health systems throughout the country. And so we have a very diverse patient population. We could do subgroup analyses. We have a large patient population, so we have enough statistical power to be able to tell if these things are working. And through this software that we're using to do this monitoring, let's say that software is deployed at 20 health systems, that they could actually develop internal knowledge of the variation of performance of some of these tools and be able to provide that information to other health systems that want to test them out. It's not perfect, but it starts to get at real quantitative collection of this type of information over time. And so to me, the question is, how do we capture the evaluations of these tools somehow, and how do we make that information available? There's also been discussion among organizations like TRI of creating national model registries and then keeping some of this quality information and performance information in some kind of a national registry setting. I think that gets really hard because it's hard to version a product and say it's exactly the same as this other product and submit information, but that's what needs to happen in order for smaller, less well-resourced health systems to be able to have confidence in deploying some of these tools. And I'm sure there are other avenues as well.
Your question. Just speak to the mic, Rach.
Hi. Part of this seems overlooking that this process should be seamless. Without friction, without dissonance, there's no knowledge. That's the whole point here. So I do think this is something of phrasing the wrong questions on how we look at this. And the other aspect of this is when you go through training, it's great to go to other institutions because other institutions have approached this problem in a different way. And so it's great to have that model that says no go. You don't want to do a system that's wrong, but I would like having less of an Occam's razor approach to this is the right answer, that this is mathematical, but rather these are a number of options that you can tailor for your patient, bring in that preference, and that's the type of sort of expanding the knowledge model and allowing for autonomy and actually thinking and making it more human and trust on what you're applying. And these models keep looking for a single answer, and we don't want single answer is worthless.
So I have a story to tell as it relates to that. So we wrote a paper in 2020 that is still not published, and I'll explain why, that looked at the trajectory of patients who have ulcerative colitis and how many of them need surgery in the next 6 months. And we had a system that could actually really effectively predict the risk of surgery in the next 6 months based on the treatment that you receive, basically the electronic health record data. So we write this paper, we called it Community Risk Intuition. We thought it was a really great paper. And my boss said, when we quoted Daniel Kahneman's book in that paper, because we said that the reason that we should be providing these tools is because clinicians have a lot of biases that may not actually make it so that they're able to do this effectively. And so we called Daniel Kahneman. I just kind of emailed him cold, and he was kind enough to review our paper. So we sat on a phone with Daniel Kahneman, this was before he passed, for an hour and a half while he spent 90 minutes basically tearing our paper to bits and explaining all the reasons why our paper was a bad paper. And it wasn't that he was against the modeling. It was that we hadn't really thought about it in that way, in terms of trade-offs. And so what we ended up doing, we went back to the drawing board. We really did everything, redid the entire modeling process. And ultimately what we came up with was a version of the paper where the system doesn't say, are you going to go to surgery? It says, these are the trade-offs of any given decision at any given time. What's interesting to me is that does seem a much more natural way of approaching this. That is patient-centered. But when we put this, so one other piece of this is we had actually been piloting this with gastroenterologists before and during this whole process. And when we put the second version of the tool in front of some of our friends, they were very unhappy. Because that lack of clarity, that Occam's razor, that line, is not great for clinicians, but certainly can make patients in some cases feel better, where, just to be clear, I haven't tested this on a large number of patients, I bet you there are some patients who would prefer the original version of the tool and some patients who love the trade-off based method.
Because when we speak to patients, one of the worst things you can do is talk about percentages. And docs do not know how to talk to the patient without bringing in these artificial statistical percentages. And that is part of that model. And that's why a clinician would like to be able to hand a straight line.
I'm just going to repeat the question. Was docs don't do well communicating percentages, just so people online can hear.
That's the worst thing you can do to a patient.
I also wonder if we have the kind of data we would need to create a nuanced model like that. So for instance, if a patient comes to see me for a pancreas operation for pancreatic cancer, and I say, no, the tumor's too far advanced or you're too high risk, that's the end of the conversation. Like we don't collect data after that.
But no, the first thing is you send them to a clinical trial. You see, so that's part of it.
Yeah.
And in harvesting clinical trials, the biggest difficulty is that the clinicians don't refer patients to clinical trials. So the end is unknown because part of it.
Right.
So then part of that rate of discussion, and hopefully AI liberates enough time so patients complain about that you don't have enough time with them, that you can have discussions of better meaning.
So I think part of what you're getting at is the amount of information that the clinician has available to them and how they use it, right? That's how I'm hearing part of your information. So given the variety of tools I think you've seen us discuss, some of them are not quite oriented towards that binary or non-binary output style, and that sounds very vague. So I'm gonna highlight it this way. I think that when I get that PE, like no PE is present, right? If I had gotten that as there's a 90% chance there's a PE present, I don't know that would have been as helpful than the thresholding. And even if I've told the patient then, here's 90% chance that you have a PE, I'm like, listen, there's an arrow sign. This is where it is. I think it's here. And I think that is definitely not tested for all the different usability cases that we have. That was one case. The other thing with the breast cancer thing, where I showed you there's a percentage over a 5-year course. Again, almost like a weather report, between 6 inches of snow and 30 inches of snow, somewhere Flo's not leaving her house. So that's, right, that is an important decision tree for me. Now, I think there was another piece of your question I do want to get to from the original question that you asked that I thought was very fun. So I'm gonna sort of answer that second question, which is how do you build knowledge in a different way now that you have AI present? And we had this discussion at dinner, actually. So if anybody's seen the Thinking Game movie with Demis Hassabis, the Nobel Prize winner, that same group has Bean Kim with Google DeepMind, and one of their questions was, how do we advance human knowledge? So if you heard this story, ignore me, but there's the grandmasters of chess, and there's like a pre-grandmasters level. And they took this group of people who usually have to pay coaches and sit with them to learn one new chess move because they've seen everything, right? And what they did was they introduced an AI coach instead. and had them play against AI. And the sub-grandmaster people loved it because they were learning new skills so quickly. It was on a weekly basis rather than monthly. And very famously, when they had challenged each other, the sub-grandmaster, the grandmaster, they made something called like Move 42 or whatever it was, that learned a new skill that was presented because AI had made this super skill, right? That no one else would have made the same decision, but because it was all this extra data, they had done this one thing that they had taught a human to be superhuman. And I thought that was a fascinating concept on its own because it's not training AI to be super AI. It's hey, let's boost ourselves and our performance. And I think this gets back to what Gabe was thinking with some of the surgery examples. And I think this is going to be a very fun expansion of knowledge in that other side of your question.
All right, so one question, and then we're gonna, I think this will be the last question now. We'll have a half-hour break before the next presentation, but we have 2 more Q&A sessions this afternoon, and maybe during the lunch, at least people in the audience, if you want to nab one of the speakers, you can. Thank you, and this follows a little bit from what we've been saying. Thank you for the thoughtful, provoking presentations. I'm wondering how to include patients and making them understand the possibilities and flaws of AI. And this gets back to the issue of informed consent. Sort of it's come up a few points about, what should patients be told or not told. So, and also in terms of trade-offs, how much should we leave this up to patients? So, thoughts from the panel.
So I'm going to give a really simple response simply because I think about it in these terms. I think that in many cases, the thing that is always missing is the denominator. And in most of the analyses, most of the conversations that people have, we only talk about the numerator. And that is a real problem. And a patient is a numerator, but a population is a denominator. And the difficulty is that when a clinician is describing risk or describing errors, they're describing a population level issue that people they're like, I'm a person, and you're talking to me like I'm part of a population. That dilemma, that gap, will always continue to exist, and it's very difficult to bridge. But if basically the patients, in this case I think, can understand that, let's say a clinician made an error in how they evaluated or how they used a tool, but 98 times before they used the tool correctly, that's actually a success. It's not a success for that patient, and that's what the difficulty is here. But it is a success for the clinical process when before that clinician would have made errors, 20% of the time instead. And so this is to me, this is a fundamental kind of issue because the numerical piece doesn't take into account the denominator. And so it's very difficult to have these conversations unless people are willing to accept that there is a denominator in all of this.
I will just mention that, so in my family, my grandmother, who's passed away, did not speak English, right? And I think that was really important for her she always had to go through another person to translate her care. And I always think about this in terms of now, don't use Google to replace my medical degree kind of comment, but then that's separate from now what we have access to. And we as clinicians now have to get used to the fact, right, that there may be another area of knowledge or things that people have access to that may actually supersede in my judgment call or whatever else. And that synergy and that evolution of the patient-physician relationship is something that nobody has an answer to. I think that this era of medicine will be different in how people have access to technology. That digital access, this digital determinant of health is something that I've published in a different way, right, is going to be so fascinating because if you have a cell phone and you have access to all these free tools that are out there, right, that's going to help your healthcare in some ways that you didn't have access to before, and none of us have studied that. That was not part of our training. That's not part of how the health systems think about access to care. But absolutely, that's another phase of evolution. So I invite you all to write and publish about this.
And just, again, zooming out a little bit and from a health systems perspective, thinking about rates of harm, I think we have to be very careful not to romanticize physicians and nurses and clinicians. We cause a lot of harm. Like I can tell you what my wound infection rate is. And we're also biased, right? and our data shows our bias. So I think if we're going to say, AI is not going to be perfect, but is it better than what we have now? And I think that has to be the question. And is the numerator and the denominator, right? What are we comparing? What's our baseline? And we can capture our baseline because we have the data. We're using it to train. So that's where we are today. And then how are we going to be in 5 or 10 years, right? Are we going to be better? Is this going to reduce our wound infection rate, right? Is this going to improve our diagnostic accuracy? And I think that has to be the question. And we can't vibe this, right? We actually have to apply some semblance of the scientific method to be able to determine, here's where we're starting, right? And there is some harm, but where are we going to go? And how are we going to improve?
So this is a total hot take. I'm going to give this example, so the hot take is, I was just reading an article about a suit that a couple of patients placed against a company that was providing intraoperative assistance for a specific area in surgery. And those two patients were, it sounds like they were injured by some aspect of how the surgeon was using the tool, okay? But the piece that is missing in that suit is, as a result of that tool, did that surgeon now perform the task 30 times better or 30% better than how they were performing the task before for the other, 70, 80% of patients? And so the problem that we have is that if we have lawsuits that say, well, it caused harm, but we don't have a sense of what it actually improved, then we don't have a good way to evaluate the value of a tool versus another. And I think that continually happens simply because in some cases we're not measuring the right thing, but in some cases we just don't have the data to evaluate how to actually define that improvement in performance.
It sounds too like at some point we need to reevaluate standards of care. So standard of care for such a procedure may become using this tool so that then he didn't deviate from what the standard was, for instance. Well, on that note, please join me in thanking all our wonderful panelists for the questions and answers.
Hi. I am really excited to be here. Thanks so much to the organizers for having me. It feels a little strange to be a non-clinician in this bunch, but here goes. We'll see what we can do anyway. So my disclaimer is I am a law professor and I am not a lawyer, and I am definitely not your lawyer. And so please don't take anything I say here as legal advice in any way, shape, or form. So I want to start actually by talking just a little bit about kind of different ways that I see AI being really transformative in the practice of medicine, just because I'll be honest, I am a total AI booster. I am so excited for possibilities of making things way better. There are lots of problems and lots of challenges, but I think there's just so incredibly much opportunity. So I want to start with saying I think of 4 ways that I can think of AI transforming the health system. One of them is absolutely the sexiest headline thing, which is pushing frontiers, doing something that no clinician alive can do, right? Like predicting acute kidney injury 24 hours before it happens in a way that's just, no one can do that now. Or identifying, as we've noted before, kind of subclinical disease or predicting things way in advance. Just incredibly exciting possibilities that are beyond the reach of any human clinician, no matter how skilled today. I think about democratizing expertise, which frankly is what I'm probably most excited about, which is the idea that there are lots of things right now that you need to be a specialist or really skilled or really good or have time or resources to do now. And AI has the potential to make some of those tasks available to folks without that training or that specialization or those resources or that time. So my favorite example of this is a technology called IDXDR. I guess now it's called Luminetics Core, but it was born IDXDR, which is a technology for diagnosing more than mild diabetic retinopathy from a retinal image. And it's actually cleared by FDA for just autonomous diagnosis. It's not here's information that you might find useful, clinician. It's just here's a diagnosis. And so previously, that's something you needed to have an ophthalmologist to diagnose, and now you can use an AI system and a technician or a physician's assistant. And that's pretty extraordinary for the kinds of places that have, you know, one ophthalmologist for every 1,000 or 20,000 or 50,000 patients. And I think this possibility of democratizing expertise is incredibly, incredibly exciting. The third possibility is automating drudgery. We've actually talked a bunch about this today. Every clinician that I have ever spoken to just hates paperwork so much, so very much. Pajama time is a scourge. And so the idea of ambient scribes making it easier and having more time to connect with patients on a human level and to do the work of being a clinician that they love to do is incredibly exciting and transformative, even if like the technology itself just seems unbearably boring. Just crazy boring compared to here's a cool medical task that we can do. And the last is allocating resources. This is the one that the bioethicists that I talk to always get really upset about, the idea that we can use AI to say, okay, well, you know, we got one hospital bed left. Who should get it? This patient's going to benefit more than this other one, and we can do some predictions, or less controversially, here's how we should think about staffing and making sure that we have enough staff available for the patients that we expect will come in because we've got a fancy algorithm that will tell us. So really different models for how AI can transform the medical world. And the first two of those really have interesting implications, at least to my mind, for how they work with clinicians, right? If we think about AI performing in a way that no clinician today can do, how do you know what ground truth is? How do you know what is right or wrong? How do you think about a clinician interacting with that AI system? When it's an AI system that is providing additional capacity that there's no one there that can do. If you're saying, well, we're going to use IDXDR because we don't have an ophthalmologist around, how does that interact with the clinician when there is, indeed, no ophthalmologist around? All right, so on to the law part of this with that as a bit of background. I'm going to talk about liability a bunch because I think it's super interesting and a lot of people seem to find it relevant. I'll talk a little bit about documentation and then I'll talk a Goldilocksian middle about disclosure. So I'm a law professor, and a thing that law professors talk about all the time is the elements of a cause of action, and so I'm absolutely going to do that even though you are not law students, and that's totally fine. When you think about a lawsuit, like, what does it mean to file a lawsuit? Basically, you're saying, hey, I would like you to give me money or some sort of relief because this thing happened, and this thing in law is almost always broken down into elements. And so if you ask about a tort lawsuit, medical malpractice, what does that actually look like? And there are 4 elements to a medical malpractice lawsuit. There's duty, which means you have some duty to this person. So if there is an individual, if you're a physician standing there and someone has a heart attack right in front of you, and you could save them, and you don't do a thing, you are not liable at all because you do not have a duty to that person. In almost every state, Vermont's different, but almost all states, there's no duty, and so it doesn't matter what you do or don't do or whether you upheld your ethical standard. Now, ethically, of course, you're very, very liable, but from a legal perspective, there's no duty that you have to that person with whom you do not have a pre-existing relationship, no liability. So you need duty. Breach is the part that we're going to spend most of the time talking about. Breach is when you act that is not according to the standards of that duty. So the law demands that you act according to the standard of care. When we talk about the standard of care, which we have earlier today, that's about saying, well, what is it that you have to do to be acting up to that duty of care? And so in most states, it's something like what a minimally competent physician would do, or a reasonable physician. Minimally competent feels like a low bar, but otherwise a whole lot of people will be engaging in a whole lot of malpractice, so we don't set it too much higher. You need to have breach, you need to have causation, and you need to have injury. And the causation, the breach needs to actually cause the injury. I promise there's a reason I'm going through all these things when we're talking about clinician divergence. Causation matters Well, first, injury matters. You need to have injury, otherwise there's no lawsuit or no successful lawsuit. And then causation matters. If you as a physician do something that is deeply, deeply wrong, and a patient also happens to get injured in the same encounter, but your deeply terrible thing did not actually cause the injury, there's no liability that comes from that, right? We need to actually have a causal link. All right, so with all of this as background, who's liable? Who should be liable when there is AI involved in a patient's care and that patient ends up injured? My focus here is mostly going to be on clinicians. We're going to spend lots of time going through clinicians, but I'm also going to talk about the other potential entities that might be liable for patient harm. Hospitals and health systems, the big one, patients much prefer to sue hospitals and health systems than to sue clinicians if they have the choice, because hospitals and health systems typically have way more money and way bigger insurance policies. It's actually harder than you might think. You have to find typically some reason to say, well, you can actually get at the hospital and not just the clinician. You have to find some way to say, oh, the hospital is responsible for the activities of the clinician. That could be because they are an employee, or because the hospital somehow controlled the actions of the physician as if they were an employee, or because it's an emergency room and we think everybody should just, if you go to an emergency room, you go to the hospital, not to a particular clinician, and so we're going to hold the hospital responsible no matter what. But fun quirk of the law, the basic fact that here is a physician, for instance, I recognize I'm going back and forth between physician and clinician. I'm trying a lot of the laws about physicians. I'll slip. But the basic fact that here is a physician who has staff privileges at a hospital, is on staff, can admit patients, that is typically not enough to find the hospital to be on the hook for any malpractice by the physician. So often want to go after hospitals, that can be challenging, and then want to go after the developers of the tool in the AI context on the theory that this was a poorly developed or problematic tool, and that problem ended up causing the patient harm. Now, all of these parties can be liable in any particular case. There is no exclusivity here. You can't say, oh, this was the developer's fault and therefore not the physician's fault, or oh, this was the clinician's fault and therefore not also the hospital's fault. Any one of these can stand or fall independently. And, fun fact, we can also change it all via contract. So not who gets liability in the first instance, but hospitals theoretically can indemnify physicians. Hospitals can and do sometimes indemnify developers. Developers theoretically could indemnify hospitals. This is actually a fun thing. Again, the only example of this I know of, I'm sure there are more, is IDXDR, where because they say it's an autonomous diagnosis, the company has its own medical malpractice policy. And they agree to indemnify, meaning they'll pay for any judgment against anybody using their product, according to their instructions, that gets sued in a lawsuit. They're like, we'll cover you. That's on us. That's how we stand behind our product. I don't work for them. I'm not advertising them. I just happen to know more about that particular instance. So you can change all this around with contract. All right. Finally, and by finally, I don't mean this is the last thing. I mean that at last, we are going to talk about divergence and liability, some of the theory. So this is from work that I did with Glenn Cohen and Sarah Gerke a while ago. There's a lot here, and we're going to spend some time kind of working through this. I think this is a useful, this is really a toy example of how we might think about clinician and AI divergence, how this plays out legally in a really, really simple example. If there's one thing that I think we learned from the first half of today, it's that there are a wide variety of examples of AI clinician divergence, all sorts of interesting contexts, all sorts of really complicated patterns, and I am going to abstract away all of that complexity for the purposes of saying, okay, let's add in, still, trust me, there's enough complexity, and just how the law thinks about this. So here's the toy example. This is an AI that is recommending a dose of a chemotherapeutic, and it's going to do one of two things. It's either going to recommend the standard of care, or for some reason, unbeknownst to us, a much higher dose. You're like, oh man, that's a scary dose of a chemotherapeutic. That's way higher than I would expect. So recommending the standard of care or something that is distinctly not the standard of care. So this is just a decision tree written out in a table form. So leftmost column, standard, non-standard of care. Next column, is it right or not? Is the AI system accurate when it recommends the standard of care or not? Then we go into, does the physician follow or reject that advice? And then what happens to the patient as a result? Is the patient outcome a good outcome or a bad outcome? So I don't expect you to work through all of this, but I'm going to talk through some patterns here and some implications that arise. So the first thing, all of these green boxes on the right, these are all instances when there's no injury. And so and when there's no injury, there's no liability, right? That's one of the elements of the tort, and also nobody's going to sue if they're not injured. So the first implication of this is really simple, but also shows up a little bit in the last question we had in the Q&A, which is reducing injury rates is the simplest way to reduce liability, which is kind of funny because we don't always we should think about this. And there are fun and interesting ways that the law kind of contrasts with this. The baseline, reducing injury, is going to reduce liability. Now, fun question I'll set aside for now. Happy to chat about it in the Q&A if you'd like. You can imagine scenarios where because of the way that liability law intersects with incentives for physicians and clinicians, you can imagine a situation where what is good for the overall system in terms of reducing injury and therefore reducing liability overall and making patients happier and everything being better for the world. Nevertheless, because of the way doctrine shifts liability onto clinicians, is actually bad for clinicians to do. And so the incentives, it's actually pretty easy to set up a system where the incentives are not to do the thing that's actually overall going to be best for patients if you think that in the instances where it turns out not to be best for patients, you're left holding more of the bag than you otherwise might be. So really interesting interactions between overall improving system performance and the incentives for individual actors within that system. All right, so green, no injury, no liability. Yellow, these are the instances. So we've got the AI recommending the standard of care, it's wrong about it, and the physician follows it. Yellow instance, because the physician followed the standard of care, there's no breach, right? Breach is you fall below the standard of care. So there's injury, it wasn't good for the patient. Followed the standard of care, no liability. Similarly, back in box 6, we've got AI recommending the weird care, the non-standard really high dose. The physician rejects that and follows the standard of care. Patient gets injured or doesn't have the benefit of this good treatment, but again, no liability. So if you follow the standard of care, even if the patient's injured, no liability. And then red, these are instances where the physician deviates from the standard of care, and that's wrong, or that ends up not being a good result for the patient, patient's injured, and the physician is liable. Now here's the first interesting implication, or I think. That analysis, the AI doesn't matter at all. Right? In terms of what does the law do, the only question is, did the physician or the clinician follow the standard of care or not? If they did, no liability. If they didn't, and there's injury, there's liability. You could take the AI out of the picture entirely and nothing changes. And to my best understanding, that is the current state of the law. That the clinician making that decision is holding the bag, and the question that we will ask is, was that decision according to the standard of care as we would otherwise conceive it? And whether or not you got bad advice or good advice from an AI does not matter for the outcome of that legal action. Now, the implication of this, of course, is that the thing to do with AI, at least according to the incentives of the law, is use AI to confirm what you'd already do. And if it says something different, well, do what you'd already do anyway, assuming that you are a minimally competent physician and know how to follow the standard of care. And so when Gabe talked about, oh man, the thing we really want to do is when the AI is right and the clinician's wrong, that's the value of AI. The incentive of this system is not to do that at all. All right, so Going back a little bit more, I want to highlight the different ways that divergence shows up in this system, because we've talked about different forms of clinician AI divergence, and I want to point out how they show up differently in this particular analysis as well. So these are going to be all the even scenarios, if you can see the numbers. So in number 2, what we have is the AI is correct to recommend the standard of care. The doctor rejects this, and the patient gets injured. This is bad. Like, this is exactly the type of liability we're like, yes, there should be liability there, no question at all. What's going on? This seems like really problematic. All right. 4th scenario, the AI recommends the standard of care incorrectly. The doctor rejects that incorrect recommendation and says, no, 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 I'm going to try non-standard care. There's no injury and no liability because there's no injury. But if there had been injury, there would have been breach and that doctor would have been liable. That's great doctoring, right? That is great activity to say, hey, nope, this patient is different, this patient is special. The thing that we should normally do is not the right thing to do here. I'm going to be exceptional and I'm going to save my patient, but man, is that a risky decision to make. That particular type of divergence is risky because we're stepping, well, it's risky on its own, stepping outside the standard of care or what's normally accepted. It's, as we'll see, even riskier if you've got an AI hanging out there saying, no, 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 you should do this thing that's normal. Scenario number 6, this is AI says, this is kind of the opposite. AI says, try something different. No, no, I know that that's what you should normally do with a patient, but we're not going to try to anthropomorphize, sorry about that. Don't do what's normal for the patient. Do this different thing instead. This patient is different, and the doctor says, nope, I'm going to stick with the standard of care. I'm going to stick with the normal treatment. Turns out that was wrong. Patient gets injured, doesn't get the benefit of AI. We're leaving the benefit of AI on the table. No liability, because the clinician did exactly what the normal standard of care is. This, again, this is leaving value on the table and the way that the law incentivizes that. And then last, we have scenario 8 where the AI says, hey, do something weird, and the doctor says, no, that sounds weird, I don't want to do that. That's the right answer. No, no liability, no injury. Hooray for the doctor who caught a clear AI mistake. So again, toy example. I think quite useful to just parse out really, really different forms of divergence and how they can end up looking. The very last thing I want to point out is these 2 things that you probably can't really see but are in italics, scenarios 6 and 7, because these, I think, are the opportunities for change and the places where things are most likely to change. So in scenario 6, I talked about just a moment ago, right, the AI said do something weird and the doctor said no, and there was no liability because the doctor was following the standard of care. I don't think that it is out of the realm of possibility that that may change. And that we may say, this one's a little further out there, but we may say, hey, if you had an AI recommendation, standard of care is to follow it. Absolutely seismic shift in the way the law thinks about the practice of medicine if that happens. We're not there yet. I think it's plausible that we will get there at some point in time. That will be huge if it happens. Scenario 7, this one I think is more likely to be on the horizon. So this is the AI incorrectly recommends something that would otherwise not be the standard of care. And the physician follows that recommendation and it ends up being wrong and the patient gets hurt. But we might imagine a change to the standard of care again that says, hey, following AI recommendations of a validated tool is enough to shield you from liability. That's the standard of care in a defensive sense that says if you're following that advice, we're not going to hold you liable because you are following good advice even if it happens to be wrong. Now again, to be clear, to the best of my understanding, neither one of those things is yet the law. But I would not be surprised if one or the other or possibly both becomes the law. I'm guessing 7 happens before 6. Is that clarifying or a quick jab?
Good question.
Yeah.
Does that mean that if we transition to a scenario where you are protected as long as you follow the AI, then you no longer have to worry about standard of care at all?
Right. So to repeat the question, If we shift scenario 7 and we say you switch to a move where you're protected if you follow the AI recommendation, do you not need to worry about the standard of care at all? I think that is the implication. There's a wonderful piece by Ian Kerr, Michael Frumkin, and Joël Pinot in a law review, which I know means none of you will read it because it's incredibly long, but it's super interesting. So in 2019, worrying about the idea that once we accept that AI becomes a standard of care, and this is themes that we've talked about today so far, is that there'll just be rampant and rapid de-skilling as people realize, like, oh, I don't need to care what the standard of care is. I don't need to keep up those skills because what I have to do is what the AI tells me. And then worrying about the downstream consequences, as we've discussed, of like, well, who's going to figure out when the AI starts going bonkers and off the rail? All right, so skip this bit. So I want to turn to a couple of empirical pieces where people have looked not at has the law changed, but if you can take this to a jury in a case. To be clear, we have not had any cases about this yet. But if you can take this to a jury in a case, what do lay potential jurors think about these things? What is the lay perception of liability? The imagination is that these folks would be sitting in a jury box. For various reasons, it's actually quite hard to get to a jury, which I'm happy to chat about later. But this is like, what's the intuition pump for whether or not we might consider the standard of care changing? So the first piece is by Tobia Nielsen and Stromitzer. They asked folks to rate the reasonableness of or when a physician followed AI advice or not, and they actually, and what was deeply flattering to me as a slightly younger scholar, used the scenario that we had from that earlier piece that I just mentioned. So they used the toy example, and we're like, okay, like let's survey people and ask them, or do a survey experiment and find out what do people actually think in this scenario, what's their rating of reasonableness. They only looked at scenarios where patients got injured, because otherwise you're not going to get to a jury. And what they found was basically following the AI was protective. So on the y-axis here we have reasonableness. Higher means more likely to find the physician's behavior reasonable, i.e. no breach of the duty of care, i.e. no liability. The light gray bars are when the physician accepts the advice of the AI, and the dark gray bars are when it rejects when the physician rejects the advice of the AI, and then the two collections are when the AI recommends the standard of care versus not. So what they found was in all of these situations, right, the patient gets injured. So something went wrong. But if the AI recommends the standard of care and the physician follows it, jurors are by far, well, not by far, by some, more likely to say, yes, that was reasonable behavior. On the other hand, if the AI recommends the standard of care and the physician rejected the standard of care, that was the least reasonable action by the jury. And then non-standard care somewhat in the middle. So they're, following AI advice is protective, but again, standard of care still mattering a bunch. Another empirical study I like, this is by Bernstein and colleagues. Excuse me. So this is in the context of radiology. This is a radiologist who misses a brain bleed on a scan. And the outcome here, inconveniently, is flipped. This is a flip from the last study. So higher was good for the physician in the last study, higher is bad for the physician in this study. This is the fraction of lay respondents who sided with the plaintiff, saying that behavior was unreasonable. What I want to highlight here is, again, this is all people who are injured. What I want to highlight here is the fourth dot, the highest one up, where if a physician disagreed with the AI, the respondents were by far more likely to find them to have acted unreasonably, right? They've breached the standard of care if they are disagreeing with the AI and missing the brain bleed as a result. So and then I'm actually just going to read a little bit from their conclusion about this, because I like the way they think about this in terms of false positives and false negatives. Our study suggests that radiologists will be judged more harshly in a courtroom when disagreeing with an AI system that determines a pathology is present. It is important to understand the likely consequences of this. Owing to defensive medicine biases, radiologists will be incentivized to call cases as abnormal that AI calls as abnormal, even when they strongly believe the AI is incorrect. Left unresolved, this has the potential to exacerbate our current problem of overdiagnosis and overtesting. Right? If an AI says, oh, this patient's got a problem, there's a strong incentive to say, oh, yes, this patient does have a problem. Because, at least in this instance, everybody else looks at that scenario and says, oh, the AI said it was a problem and you didn't say it was a problem. That's on you. You should pay up a bunch of money. Clarifying question.
So does this mean that now the AI company, in theory, is incentivized to maximize the false emission?
So fun thing added to this. So the next step in this, it's not the next step, they actually did it at the same time, but I think conceptually the next step in this is what happens if you add in additional information. Which is, if you disclose to these lay respondents the false omission rate, so the false negative rate, and they say, oh, here's the false negative rate. If you disclose the false omission rate, then if the physician agrees with the AI, they find this absolutely the most reasonable behavior. I interpret this as, hey, AI makes mistakes too, you made a mistake, it's fine, don't worry about it, you're good. And people said, oh, that's reasonable that you missed it because the AI misses some stuff too, and so you both agreed on this. On the other hand, sorry, I guess not totally on the other hand, when they disclose the false discovery rate, so the false positive rate, here, 50%, that penalty for disagreeing also went away. So if you say, hey, the AI sometimes finds things that aren't real, and the physician said, I don't think that one's real. Turns out it was real. But the jurors, or the mock jurors in this situation, are more likely to say, it's okay. Like, we recognize the AI is not perfect. We know now that the AI is not perfect. And so we'll let you off the hook. You missed it. That's okay. The AI is not perfect either. So really interesting results in terms of saying disclosing some information, what it is that the AI came up with as a result, can have a real penalty for physicians who disagree, or a benefit for physicians who, a little benefit maybe, for physicians who agree. Disclosing more information changes that around substantially. So a few takeaways from liability. Again, first, injuries are a prerequisite here. I don't want to get away from the idea that, right, the absolute best way to avoid liability is to reduce injuries. There are interesting asymmetries when we think about situations when we're thinking of false negatives versus false positives, right? When we think about the instance of radiology, right? What are your consequences as a radiologist for saying, I'm not sure if that's an abnormality, but I'll say, sure it is, and that's certainly the incentive that the liability system can give for you. Low consequences for a radiologist relative to missing something that was in fact there. The systemic consequences and the consequences for patients taken in the aggregate may be quite different. Under the law as it is now, following the standard of care is quite protective, even if there is value to be gotten for AI that suggests otherwise in some instances. But that standard of care may change as we go to saying following AI is either out there mandatory or closer in protective. And then the last thing is, all of this is a set of kind of default rules, and all of this is changeable through mechanisms of contract or all sorts of other fun and exciting legal doctrines about who actually gets into court, what other sorts of things you need to get there. All right. Clarifying question? We've got a hefty Q&A after this if you have general questions. All right. I see your hand slided out. All right, cool. So moving on to documentation, this is the only slide I have about documentation. Everybody keeps asking me, like, what does the law say about documentation? I'm like, no, it doesn't. To the best of my knowledge, the law doesn't currently say anything particular about documentation of AI clinician divergence. If you know that I'm wrong about that, please let me know. I'd be very curious, but to the best of my knowledge and that of my research assistants, there aren't specific rules about this yet. There is also quite a bit of divergence about divergence in documentation that I have been able to find. So two just totally opposite suggestions. On the one hand, we've got a bunch of folks, including the Federation of State Medical Boards ethics committees, the ethics committee of the Federation of State Medical Boards, which say, yeah, you should really document and explain any sort of divergence. So they write, if the physician uses AI and then suggests a course of treatment that deviates from the one delineated by AI, they should document the rationale behind the deviation and be prepared to defend the course of action should it lead to a less than optimal or harmful outcome for the patient. Relatively, a bunch of other folks agree, various forms. Some going so far as to say, if there's a deviation, you must get you should get a second opinion from another clinician to help resolve the deviation. On the other hand, there's a view that arises, and it might not surprise you to hear that this view arises because of what we've just been talking about in terms of liability. And this, I think, was also highlighted a little bit earlier in the morning. So Banya and colleagues have a piece in the 2023 European Journal of Radiology where they gave radiologists bad AI guidance. Like deliberately bad AI guidance, and found that, quote, they were especially susceptible to the erroneous AI guidance when they believed there would be a permanent record of the AI output stored in the patient's file. But they were less likely to be misdirected if they believed that the AI output would be deleted. If they thought, here's a record of what AI said, and they were worried, as we talked about a couple of slides ago, that they would be penalized for disagreeing with the AI, then they were likely, as Bernstein and colleagues suggested, to say, oh, okay, well, I'll call that an abnormality, even though I don't think it is, and I will follow the AI's bad guidance because I'm worried about liability. If they didn't think it was going to be documented, that effect went away. So another study, also by Bernstein and colleagues, clinicians were given, or in a particular environment, had a high quality AI that was made available to them that they had been using. This is, I think, an observational study. It had a fairly high false positive rate, very, very low false negative rate. I think it was actually 0 in their sample, 0% false negative rate. False positive rate, I think 67%, if I remember correctly. And the practice is like, yeah, this tool outperforms manufacturer standards, lots of useful information, we do not want to use it. Because that false positive rate, like we find ourselves following up on lots of things. We're worried about liability. We don't think we have free reign. We don't want to use this tool. And so they stopped using it in the practice. So documentation potentially has the ability to increase the incentive to overdiagnose. Negative. On the other hand, again, lots of people are suggesting if you're using AI, that should go into the patient record and should be available. Certainly plaintiffs' lawyers think that. That was a laugh line. That was also a laugh line. Tough crowd. Okay. Thank you, finally. Great, okay, cool. I'll take it. I will take the small pity laugh. All right, so last off, I want to talk a little bit about disclosure and informed consent. Lots of folks, lots of moral and ethical arguments for disclosing the use of AI to patients. As we saw earlier, right, we've got Patients certainly want it to be disclosed to them. They want choice over whether or not they can use AI, and for that choice to be meaningful, they want to know whether or not AI is actually being used in their care. There are strong arguments for disclosing the weaknesses of AI. So Kiara Bridges has a lovely piece where she argues that in particular, we should disclose to patients that AI is often trained on biased data sets. And so if they are a patient who is anywhere out of the absolute or diverse in any way, shape, or form, that we should make sure to inform them, hey, this AI probably isn't fully trained on folks like you, and you should worry about that. She makes, I think, a terrific argument on moral grounds for that. There are also arguments that we should specifically disclose to patients clinician AI divergence. Again, saw those data. Patients really interested in that. So, moral, ethical reasons. I am going to totally leave those aside for the next panel, which will talk about morals and ethics, and I'm just going to stick to what I do, which is the law side of things. That's right. We are back to elements of a cause of action. You know, you missed it. We just did it for malpractice, but now we're going to do the same thing for informed consent. And the bonus is, it should look pretty familiar because it's basically the same cause of action. Both of these are forms, some form of negligence. So here we have the idea behind this. This is actually the existence of informed consent comes from as a legal duty, comes from a New York Court of Appeals case from, I want to say, like 1917-ish, where the courts first recognized, hey, informed consent's important because patient autonomy is important, and the law should protect that too. So informed consent is about protecting patient autonomy. And so we go through our elements and we say, well, you've got a duty. And the duty here, first off, you have to have a duty or relationship with the patient. And then there's a duty to disclose stuff to the patient. The reason I say stuff is because it depends on what state you're in, what that stuff is. About half of states say what you have to disclose to patients is information that a reasonable patient would find material to the decision being made. The other half of states, including New York, say what you have to disclose is what a reasonable physician would find material. Everybody used to follow the reasonable physician standard. About half of states shifted over the last 37 years or so to a reasonable patient standard, reasoning that better protects the idea of patient autonomy if you're focusing on what patients think is material rather than what physicians think patients should have access to. All right, so that's the duty. And then the breach is, well, you didn't do that. You didn't disclose that information. Then we've got injury and causation. But here's the rub. You might think, neat, here's a cause of action, which is the law protecting patient autonomy by saying patients have a right to know stuff, and we can like turn the levers and say, cool, here's how patients potentially have the right to know some things about AI in their care, or do they, or like, how do we figure this out? Practically speaking though, it's actually really difficult to successfully bring a claim for informed consent. This is a weak sauce cause of action. Here's why. First off, you need injury. And you might think, what's the kind of injury you need for a cause of action which is designed to protect patient autonomy? Like, this is designed to give patients information, and you might think, well, the injury is you weren't given information. I didn't have the ability to freely make choices about my own body and my own medical care because they didn't give me the information that I needed, and that's the injury, and the law says, no, sorry, that doesn't count. The autonomy injury is not enough for the cause of action. What you actually need is medical injury. So you need to have been injured. So in terms of a freestanding right, you have to get this information. No, you can only bring a cause of action if you have been physically injured as a result of not getting the information. And then the other tough part is causation. Because what you have to show is decision causation, which is to say, had you gotten the information, or had the information been provided, a reasonable patient would have made a different decision. So I'm thinking about pursuing some course of care. I'm missing a piece of information that a reasonable patient would have found material. And had I gotten that information, I would in fact, sorry, not I would, a reasonable patient would in fact have changed their decision based on getting that information. And if you try to think through hypotheticals where you say, would I really do something different if I had known that AI had been consulted in my care, or AI was being used in this hospital, or that an AI system was biased, when I'm standing there and the clinician that I am talking to says, no, here is the right thing to do, it turns out that's a difficult cause of action to win. Or it's, at least, it hasn't happened in AI yet, so I can't say it's factually difficult in the AI context, but it's a difficult cause of action to win generally. It's just tough to make the elements fit together. Which is why, thankfully, we have ethical and moral reasons to do this, which will be in the next panel, but the law, unfortunately, is not super helpful here. Also really tough to demonstrate causation in instances where what we have here is a tool that is essentially going to be probabilistic and has black box reasoning. If you think to yourself, man, this does not feel like it actually vindicates the autonomy interests of patients, if autonomy does not count as an injury, and if we're not asking about the patient in front of us, but some hypothetical, mythical, reasonable patient, and we're not asking about what that hypothetical, mythical, reasonable patient would want to know, but what they would find material to make a decision, what would actually cause their decision to change, you are not alone. It is not great at vindicating the autonomy interests of patients. But I'm talking now about what is, not what ought. All right, so takeaways, just going over things in general. Liability, we talked some about who's liable, who could potentially be liable, and who should potentially be liable. We talked about the idea that the standard of care inherently creates an incentive for conservatism in care when interacting with AI, for sticking with what you know to be a tried and true standard, what you know to be the practice of medicine and the custom in your area or in your field, rather than following AI if it says something different. We talked about how AI can incentivize the practice of defensive medicine and how defensive medicine can interact with that in problematic ways, just providing the incentive to overdiagnose and over-provide care. And then last, we talked about the idea that the standard of care here may in fact change. And following AI may either be protective or effectively mandatory at some point in time in the future, though certainly not now. With respect to documentation, there are really differing views, and the law, frankly, doesn't say much about it yet. And then we talked about disclosure, which I think is probably a good idea in at least some circumstances, even though I didn't raise my hand when asked. But here, the law is not going to help us out much because it's relatively weak, at least as it currently stands. You could imagine passing a law saying, hey, you have to disclose this, and that, I think, is probably a much more reasonable option to say, if you want disclosure to happen, that's the way to do it, not through looking for tort or informed consent. All right, with that, I'll stop. God damn, 7 seconds over time. And I look forward to your questions and thoughts.
Well, thank you, Nicholson.
Sit here now?
If you'd like to sit, you can sit, yes. And we now have a Q&A for questions for Nicholson. And if there are questions for other speakers, you can ask them, but we're going to first prioritize questions for Nicholson. So, yes, just if you don't mind waiting for the mic here.
Hi, thank you for your speech. I'm a PhD student from Columbia School of Nursing, and I just find that earlier the discussion about the standard of care and non-standard of care and then the AI recommendation, very interesting. My question is, if there is standard of care, why wouldn't AI just give you the recommendation for the standard of care so that physicians, clinicians are safe because they are following the standard of care, and also the AI did not make a mistake because they recommended the standard of care?
Yeah, so I think that's totally that is totally a plausible way to go. And like, frankly, that's the, as Beth was saying earlier, right, that's the kind of, the 1980s version of AI was absolutely that, which is rule-based system. Like, what is it that we should do in this situation? What's the rule? What do experts say that we should do? Let's output that. I think the exciting thing about machine learning and modern AI is that it has the possibility to say, like, how do we do things better? How do we do things differently? How do we notice things that aren't what is normally noticed? So within the let me break it down in terms of what I talked about at the very beginning for like areas of transformation. When we think about pushing frontiers and AI doing things that no one can do now, by definition, that's not going to be, or at least in some instances, that's not going to be standard of care, right? Because that's not the normal practice. People aren't doing that. People haven't been doing that. Certainly not the standard custom. And that's exciting, right? That's a big part of the possibility of AI. Now, to be clear, I think there's also a lot of room for AI that does exactly what you're suggesting, which is to say, hey, I noticed that you are not an ophthalmologist. Here's what an ophthalmologist would do, which I know because I've trained on what a ton of ophthalmologists have done, and my goal is to replicate exactly what the average ophthalmologist does. And so I am going to augment your capabilities and let you do what an average ophthalmologist does, and like, that's my goal. I absolutely think that is a plausible model for certain AI products, which would avoid this issue entirely by just going kind of straight down the middle for average standard care.
So people online, again, feel free to use the QR code to put questions. And Gabe, wait for the mic. Hit Gabe first and then the back.
So this is, what a great presentation. Thank you.
Great question. Thank you.
So so the question, so it's going to take me a little bit of time to formulate this, but basically your standard of care historically has been defined by clinicians sitting in a room saying, you know, Dr. Bratt, what he did was within the standard of care because this is what we would do as the typical surgeon, physician, whatever, okay? But there's a weird thing that is happening now where with the advent of these AI tools that people are using to essentially look at how they should be treating their patients, even what people are thinking of as being defined as the standard of care is starting to be manipulated essentially by the way in which you're interacting with the data. So if I read open evidence, and open evidence is telling me what everyone else is saying I should be doing, then my understanding of the standard of care is actually changing. And so what you were describing, is it reasonable to have, let's say, an AI define the standard of care? As you were saying, that I've trained over 10,000 historical people. Is that even a reasonable way of thinking about this? To actually do this? Because we have a weird thing that's now happening. It certainly is happening outside of my specialty, but I can see it happening even in my specialty. The urologists are starting to use these tools in a way that they haven't historically used them. I'm wondering how that plays out if now what people define as the standard of care is being affected by the interaction with these tools already.
Wait, can I jump in for 2 seconds? So because I think everyone keeps using radiology examples, maybe because we have our 1,030 something odd tools, I'm going to mention this as we have done this, right? I think the example I showed was EIL and is not BI-RADS. BI-RADS is the clinical standard of care, but they avoid that with the EIL. I will say, because someone's about to start or run a clinical trial on this, is the number of recalls that get yanked back is higher with the AI tool, right? And I want to say that the false negatives here are not harmless. What I mean by that is, okay, you were called back, but you were fine, right? Typically people are like, oh, woof, that's fine. But what happens if that person went to biopsy, right, got a biopsy done and had most of their breast removed for whatever reason, and it turned out to be completely negative? That is not a harmless false a false result. So that kind of thing, I don't know what the legality of it is because it hasn't been challenged, but there has been a marked increase in recalls. Whether or not someone is now going to go run to the lawyer and see if they can go find which institution I'm talking about and then go prosecute is a different question. And then the next thing about how it's changing our practice, I think in radiology specifically, it has been changing how our trainees are training. One, and even not trainees, external specialties that interact with radiology. And the story is that at a rural hospital, somebody had, a radiologist had read this study and called in the finding and said, hey, ED physician, you've got a stroke, you should move them to the next hospital. They're like, oh, that patient was already airlifted. And the radiologist said, how, right? And they said, well, we looked at the AI result and it was positive, so we just flew them out. And that saved them time, but also was that actually hemorrhagic stroke or a embolic stroke? And those are very different treatment pathways, and that's a very different question. So I think it absolutely has changed it in a practical sense, and I have the same question now, is how do you think it's going to evolve? But I just wanted to, I guess, contextualize some of the question.
So I'm a law professor. My answer is almost always going to be, it depends. That was actually one disclaimer I forgot to make at the beginning of the talk, which is that I suspect that lots of this is going to be frustrating and irritating because I don't have clear answers for this. And here's another thing where I don't have a clear answer. One fascinating potential result. So different states have different ways that they explain what the standard of care is. Like some states say it's a minimally competent physician. Some states say it's a reasonable physician. No states say it's an average physician because then half of physicians are below average. Shocking. Nobody does that. But I don't know. I frankly don't know how courts are going to interact with this question. The way that this happens is wildly old school, which is that you call physicians up to the stand as expert witnesses who say, here is how fancy I am. And not here is what I would do, but here is why I know what the standard of care and here is what the standard of care is based on custom and practice in this particular specialty. And I think it's totally plausible for one to say, well, custom and practice now is shaped by open evidence because everybody's been using it for the past 5 years, and everybody knows that this is what you've got to do, and also you've got to do open evidence. But I haven't seen that argument made. And it would not shock me if that argument were like, yep, that totally tracks with us, and it would not shock me if the answer were, yeah, no, what we want to know is not what people think is the right thing to do, which is certainly not the standard of care, but what people actually do. As a law professor, I could say it's an exciting space for creative lawyering. As to how this is going to shake out in practice, I am super curious to find out, and I don't have a clear answer for you.
But let me just follow up. So getting back to some of Gabe's points earlier, so standard of care is not necessarily a fixed thing. And so let's say a physician says, well, I know this is a standard of care, but I didn't follow it for this particular patient because of X, Y, and Z clinically or whatever it is. So presumably that's allowed. In other words, exceptions from standard of care are now allowed. So it's not like it's a automatic, you deviated and so you're liable.
No. You can certainly, there are various ways to find that there are various ways to find that is okay behavior. One of them is, we talk about standard of care as if it were an actual answer, and in our Tory examples, there's an actual answer, but in reality, if you're like, what's the standard of care? It's going to depend. The question is, the reason we have experts is because you say, okay, physician, here are these 17 relevant characteristics of the patient in front of you, and also here is some information about what physicians do. What would be the right thing to do for this patient in this circumstance? What would be the standard there? And that's an opportunity to flex what would be an inflexible rule to say, no, here's how it would apply to my patient. In practice, that's one way to do it. You can talk about clinical innovation as, we don't actually have a custom for how to use this particular tool in a pediatric population. But it was the only thing available, and so here's how I used it. And ultimately, we toss it all into the black box of the jury and say, did you find this reasonable? And they don't typically give you an answer as to why they found it reasonable or unreasonable. They just say, yep, that was reasonable, or no, it wasn't.
So I could imagine if a doctor says, well, I followed what OpenAI said, that you'd have people who would then say, in support of that, testifying, yes, that's reasonable.
Yeah, and so I think that is the question evolving going forward. Like, what does it mean to say I am following AI, and does it meaningfully differ whether we're saying here is an AI tool or, as Charles was saying earlier, like, is an AI curated textbook experience like Open Evidence meaningfully different from an AI tool that says, I have curated that and here is the relevant bit of information as applied to your particular patient without just showing you the evidence, right? Do those show up differently in a standard of care analysis? Is one of them protective and the other not? Again, alas, I have no answer. All I can say is it's super interesting.
Okay, we have a question in the back.
And also, he has been holding this question since
you have, okay.
Just for next.
Hi there. What do you think about a world in which the risk is not just all on the clinician, but also on the AI vendors? For example, we just had Doctronic and their specialized malpractice policy that came into being. I just was wondering if you could comment on what it would look like to have both parties share the risk in the future, if that's a possibility, and what it would look like for entirely autonomous systems to practice, as it were.
Great question. Sorry, I said it. I said great question. Now I should say the other questions that I have received were also great questions. And I expect that the rest of the questions I received will also be great questions, even if I don't remember to say it. So it's super interesting. So I think it depends a little bit on how you think about what I call contextual bias in how we apply AI in different scenarios, right? There are going to be a lot of instances where the application of AI is going to depend a lot on where you're using it, because of different patient populations, but also different clinical workflows, different resources, different clinical populations. And so a system that works one way, at New York Presbyterian is just not going to work the same way if you just take it out and you plant it down in, Cedar Rapids Community Hospital. So, however, I think there are probably other systems that roughly are. So, I am very far from an ophthalmologist. My understanding is that one of the things IDXDR did when they developed their tool was to say, we're going to try it on a lot of different patients in a lot of different environments to make sure it works basically the same everywhere, because people's retinas look basically the same. If there are any ophthalmologists in the audience, I am so sorry, because I am sure that is wrong. Go with me. Pretend that even if it's not the case, that there are some instances where it is the case. And in situations like that, what I think you would expect to say is like, here is a system where the developer can really be responsible for the tool across lots of different contexts, and say, here is, I've made sure that it's safe, and that's on me. And the law should put that burden on them and say, yes, this is going to be the developer, and if somebody else is using it in a reasonable way and there's an error, right, that's really on the developer. I'm mixing kind of is and ought a little bit here. I think there are a lot of situations where contextual bias is going to matter a ton, and how well a system works and whether it works for particular patients is going to depend a huge amount on where it is used. And I think that's probably not going to change for a while, if it ever changes for certain circumstances. And in those instances, from my perspective, the right entity to kind of take on the liability is probably the hospital or the health system. Because going back to a theme from our earlier conversation, right, the entity making the decision should be the entity that has the most relevant information. And that's often not going to be the developer if the answer is, here are wildly different clinical environments that require deep local knowledge of a workflow and patient populations and clinician availability. It's probably also not the clinician, to the extent that a lot of these tools are going to be developed in a way that that require knowledge of systems and require the ability to kind of change systemic functioning around. If you have things that are embedded within the EHR, right, that's not something that the average clinician in a health system is going to have any control over.
All right, so now I have a question. Yes.
Wait, I have a little bit more.
Please.
But I want to come back to right now to the very end of the beginning of your question, which is like, well, what about the clinician? Like, what's the world like if it's not just the clinician? And I think our world is so set up to put the moral blame on the clinician and often the legal blame on the clinician, and to say that responsibility of getting it right matters for the clinician who is there, and like that's the one that we're going to set this on and say, like, you deal with this. You deal with this question of, does it work for your patient in your particular hospital in these particular circumstances, when often they don't have the knowledge or the ability to control that particular thing. But we want to say, like, yeah, that's on you. And there's a concept that I find so powerful from a scholar named Madeleine Claire Elish. Actually, two related concepts. One of them is the idea of a moral crumple zone, which is a human who is effectively the equivalent of a crumple zone in a car that absorbs all the moral approbation and protects the driver, which in this circumstance is the developer, and saying like, oh, yeah, our system was fine. The only problem was that you didn't know how to use it for your particular patient. And the similar concept is a liability sponge, having a human there to soak up all the liability that comes around. And I think these are really powerful concepts that apply quite well to the way we conceptualize a lot of care and onto which we've glommed AI, that also really don't accord well with who has the most information to resolve the problem, who has the power to resolve the problem, who has the time and the training and the ability to resolve the problem. And that's a fundamental mismatch we're going to need to grapple with as we think about the adoption of AI across more and more dimensions and contexts in healthcare.
I think also psychologically humans evolved to sort of blame a person. Like in so many events, what's COVID, what caused COVID, we wanted to blame a person, not just there was a virus somewhere and whatever happened. So we have a question from Annette Greer online. Do we know how insurance companies are already using AI to identify patterns and claims for approval or denial?
So we know some about this. A lot of it's relatively opaque. I don't know why I'm looking at you. You didn't ask the question.
Look at Annette.
Hi, Annette Greer. There you are. We know some about this. A lot of it's opaque. We definitely know that like there's this fascinating, disturbing arms race that's happening, right, where hospitals and health systems are adopting AI to increase billing and find, oh, here are things that we can code for, and here's how we can upcode, and here's how we can make sure that these activities are being properly, sorry, let me rephrase. Hospitals and health systems are figuring out ways to avoid losing revenue that is rightfully theirs for activities that they've already done but didn't realize how to capture in the past. You can phrase it either way that you'd like. And then insurance companies are on the flip side of this and using different AI systems to say, here is where you're billing excessively or here's where you're billing too much, and there is just an arms race back and forth. There is also in the instance of the particular instance, right, AI systems to write appeals letters, AI systems to evaluate and deny appeals letters, AI systems to rewrite appeals letters in response to denials. It is an active space.
So I think what we're going to do is there's a few questions. So I think we'll do is have a few questions and then, because we just have a few minutes left. So Gabe and then the back and then here.
So I'm going to ask you to basically put your prediction hat on. And one of the things that the question from where we are today to that world where you say we've grappled with these issues and we've come up with some decision, I don't really have a sense of what that looks like. Is that a bunch of people get sued and there's tort law and a bunch of physicians like lose their jobs and a bunch of healthcare systems pay millions of dollars or don't? What does how do we get from here to, what's that trajectory going to look like? Does it go through the courts? Is it going through policy? Like, I don't understand how we get to that future state that you're talking about.
And before you answer, let's just do one other, someone in the back had a question there? Yes, we'll do her question as well, and I'll have you answer both. Or
maybe all three.
I want to fit in as much as we can within the limited time.
Thank you. This was fantastic. My name is Leanna. I'm a recent bioethics grad from the University of Toronto. My question's about the causality piece. So what happens in the law when an effects cause might have multiple causes? Is there any priority over like acts of commission versus omission? Like say a clinician prescribes or wrongly prescribes a treatment and a patient dies, and say 6 months ago, another physician maybe could have said something that would have prevented the cause. Who's in trouble? The person who omitted the information or the person who actually committed the wrong treatment?
And then let's take the third and final question.
She has my omission
all right, cool.
One thing.
Just wait 1 second, we'll get the mic.
When you go before a judge, you're never supposed to quote case law if you don't have it correctly, right? But there was a case, I believe it was at Cornell, where a researcher in the field had gotten results that showed better improvement than standard of care. But he gave his patients standard of care. And he was sued for not using the more advanced knowledge that he had. So it is an evolving state. I don't have the case, but it was taught to me here. Okay?
Great, so I'm going to take these questions in reverse order. So yes, it is. The law is a wild, fun, and exciting place, and it is definitely the case that sometimes courts say, yes, I know that this is standard of care, but you had special knowledge and we're going to hold you to a higher standard. Or maybe nobody had special knowledge, but you know what? I'm the court and I say you're all wrong and you should have done this test. That happens extremely rarely, but it has happened. It's kind of wild when it does, and law professors get all excited when it happens. With respect to omission versus commission, there's no real particular preference in the law for like, you did something, like if you miss something and that fell below the standard of care, or you catch something wrong and that fell below the standard of care, there's not a huge distinction based on that. If there are multiple people who are independently responsible for something, you can hold them responsible independently or as a group, and then they kind of divvy up how much they each owe for that. And then last to Gabe's question, how we get there? I hope it's not through the courts. I hope it's through more considered policy. Courts, I think there are a lot of moving pieces here, and it is possible that we will get here through the slow and strange majesty of the common law, figuring out cases one by one and eventually resolving things. I don't have a lot of faith in the liability system to set the incentives right, so I'm kind of hoping that's not how we get there. One of the other reasons that I hope it's not through the courts is because access to the courts is something that is highly variable. And when I think about kind of AI as transforming the health system, I think about how do we make sure that this is a tool that works well for lots and lots and lots of people. And if you're relying on who brings lawsuits, that's a really distinct slice of possible folks. And so if we're looking for a system that works well for patients and clinicians across a huge variety of different contexts, I hope we take a broader kind of policy view to get there, and what sort of combination of various American colleges and policy organizations and legislatures is, I'm not sure what it's going to be, but I'm hopeful that that's the path we take.
We're just in 1 minute. So any thoughts at federal levels versus state levels with the rest of AI that's sort of been an issue?
Man, I already ended on such a good note. I don't have a super, well, this isn't being recorded or broadcast, right?
This is.
I don't have a wild amount of faith that we are going to reach a short-term resolution to any of these pressing challenges at a federal level, although I think there are exciting opportunities for some action on this. I'm excited to see what HHS and CMS and FDA are. They have a request for information about how they can improve clinical AI, and I have my hopes up that they will do awesome things. And also, I think there's room for interesting action at the state level.
Well said. Please join me in thanking Nicholas Price. Nicholson, thank you. And next, our last panel is going to be Nancy Berlinger, who's a senior research scholar at the Hastings Center, and Dr. Binkley, and they'll be talking about how should human-AI dissonance be addressed ethically. And after that, we will then have another Q&A session. So, Nancy and Charles.
Everyone has been very patient and attentive today. There's been a lot of talking. And we are going to continue that, but we would like to involve you in the talking more. And so what we've done, the sort of piece of the ethics piece that we want to focus on, and there are myriad ethics pieces, but the ethics piece that we want to really focus on is how do you think about talking to patients about AI, but particularly when there's a disagreement. Or if there's a disagreement that may have caused some harm, how might you think about that? And so we've written some cases. There's going to be audience participation. And we invite those of you who are joining us by our live stream to participate also. So what we're going to do is go through the cases. There'll be a question for the audience, and we'll look at the results in real time. And then we'll sort of talk about that. So, sound good? All right, great. So let's have the first case. This is Mr. Singh's pneumonia, and I'll just hit the highlights. Mr. Singh is 86. He has lung disease, chronic obstructive pulmonary disease, diabetes, kidney failure. He requires hemodialysis, and he's recently undergone a lower extremity amputation. After surgery, Mr. Singh develops signs of pneumonia. The hospital has an AI clinical decision support tool that's integrated into the electronic medical record. So essentially, as the clinician is typing their note, or if it's an AI scribe note, as they're editing it, you'll get real-time clinical decision support. So the hospitalist who's caring for Mr. Singh decides to start Mr. Singh on an antibiotic to treat his pneumonia. As that hospitalist is typing in the antibiotic name, antibiotic A, a real-time clinical decision support box pops up and says, based on this patient's characteristics, antibiotic B is recommended. The clinician acknowledges it, clicks it, it goes away, and proceeds with ordering antibiotic A. So clinician, antibiotic A, AI provides pushed out decision support that antibiotic B should be ordered, and the hospitalist overrules that and orders antibiotic A. Next slide, please. Essentially, should the hospitalist disclose to the patient the discordance, the dissonance, the divergence between themselves and AI? So we'll just take a show of hands. Who believes that the hospitalist should disclose that to the patient or the patient's family? Should disclose that I'm choosing A, the AI recommended B, but I'm choosing A. Yes. Yes, yeah, we're going to assume. So who thinks that that should not be disclosed? Should not be disclosed. Okay. Great, so it's about half and half. Maybe slightly more about non-disclosure. Nancy, what do you think?
So
As an ethicist, I often think it depends. I found myself thinking, when I look at, this is an 86-year-old patient who's very, very ill. He's got a lot of things going on. Probably family members are there as well. Usually for a patient who is this ill and of this age, you're going to see other people. So the disclosure the patient may or may not be in a position to understand what's being said. But let's assume that there's somebody in the room who would be able to take this. I'm wondering how this disclosure would work. For example, let's say the hospitalist had conferred with an infectious disease specialist or someone else. There's always other specialists there. And they might say, well, I do this. And the hospital's like, yeah, but I get better results with Y, with B. I'm gonna go with that one. Would you say this doctor who you don't know, who is my colleague, we did a little drive-by on the hallway, said A, but I'm going to choose B because I think it's a better match for you or your dad? You probably wouldn't. You might say, well, some people would use this, and I'm going to use this. I'm trying to figure out how naturally you would say this. So I think part of the question is would you acknowledge dissonance, period? Would you acknowledge it if it had been a human who you asked? Or and if so, how would you say that? Because usually clinicians don't like to present disagreement because it's like, well, which doctor do I pick then? Who is this? Who decides? So there is this interesting thing about, well, if it's an AI, are we viewing it as more reliable than your colleague who you would have asked before that prompt was there? Now, having followed the piece on law, that would be interesting. It took based on what we just heard, it would have been easier to just accept the prompt, especially since it's sitting there in the clickable record and you're like, ooh, am I going to get a bad mark for not following it? So I figured the hospitalist must have had a reason. So part of the disclosure might be what your reason is. Actually, that usually would be, rather than just saying, I've decided because it's Tuesday or something like that. So it depends. What's the context here? Is there something about this case where you're saying, I get better results with a patient this age with this, or there's something in Mr. Singh's record, or something that's been disclosed to me that perhaps isn't in the record that I'm afraid the AI didn't pick up? Don't know.
Question in the back.
But if you consult multiple AIs and get multiple answers.
Sorry, could you repeat?
What if you consult multiple AIs, say Gemini and ChatGPT, and they each give you a different answer?
Would those be the ones that would show up in the chart, though?
Yeah, I think about, it's a really good question from the perspective, the idea is that, if you've got this built into the chart, you're going to get a single prompt. But if you actually go, and this would be where I would highlight the difference between a push and a pull. If you actually go request the information, then I think you're looking for information and you're seeking information out as opposed to having it pushed out to you. In this case, the idea is that you would just open the chart and you would get the information. You may not even have questions about which antibiotic to use in this particular circumstance, but you've received the information and you've been asked to act on it, to act and to do something about it.
So what would you do?
So again, I try to think about similars. And a similar would be that you may look it up, like if you're in question, right? If you're in doubt. I round with a clinical team, an inpatient team, one morning a week, and it's very frequent that there are more than one way to do things. That people will have different ideas, and when it comes to an antibiotic, they may well accomplish the same thing. I certainly, I many times will err on the side of broader coverage with an antibiotic. Other clinicians may err on the side of a more narrow. There's so many variations there that sometimes there's not like one right or wrong reason as long as the patient gets better. And so I wouldn't find it important to say, I also want to say two other things. I think it's a little bit of a misnomer of about autonomy to say I'm going to present every option to the patient. I don't think that's respecting the patient as a person. That's your job. Your job is to make recommendations. There are some value-laden choices, but which antibiotic to choose to treat pneumonia is really, you can't push that off on a patient. You can't say, oh, look, I want antibiotic A, but AI says antibiotic B. Which would you like? Like, that's really an abdication of your responsibility. Bob.
It's an interesting twist. As interesting twists, there are, third generation plus antibiotics, which are much, much more costly than generics, which are much cheaper. So another issue is if the patient is paying, whether or not the clinician, in that case, the clinician may say, there's this, I'd recommend this, which is going to cost a lot of money, or versus this, which is less money, which some might do. Here's why I might give them more expensive or something like that.
I've certainly seen that in the discharge setting where a patient has been required to be on antibiotics at home, and their copay, they're going to have to pay more for it, or they're going to have to pay for a home health service. And then there have been those sorts of trade-offs. And at that point, the patient and their family have been included in decision making. I certainly see that like post-operative wounds, sending somebody home on a wound vac, where you can say to a patient, like, I can send you home on a sort of low pressure, your wound's going to heal much quicker, it's going to be, change it once every 2 or 3 days, but it's much more expensive than wet to dries. You got to do that 3 times a day. It's messy. It's going to take it forever to heal. But you let patients enter into that. That's in my mind, that's sort of a different, yeah. I'm sorry, Sarah.
Yeah, listening to this conversation, I wonder if the question around disclosure really often in the clinical setting boils down to time, because it doesn't sound like we're saying we don't want to disclose. And we're often here, I think, talking about something that you already have a recommendation for, right? You're not in question about which one. But it's a matter of having the time to sit down and provide that rationale. Just speaking in my experience as a patient, right? I'm probably quite an empowered patient that asks a lot of questions. I find that my physicians will go into details in that regard. But this then brings up kind of, the time we have, amount of time with patients, and patient advocacy as well.
I'd love to hear what other people think about this. That request to be more involved, can cut both ways. Sometimes it's met with sort of open-heartedness. Oh, let me explain to you why I've chosen this. It can also be accompanied by an eye roll. And, oh no, another, more questions, more challenges to my authority. And so we're certainly seeing that with patients coming in and using ChatGPT before they come in. How does the audience feel about that as I'm just curious, like how do you think, and again, I'm sort of thinking out loud with you, how should that influence when a patient comes in to see you and they disclose that they've read through ChatGPT and they want more information, or that they come in with sort of preconceived notions? How do we think that should influence us? Yeah, Chad.
Yeah, it's something I've had happen in practice. So, as a primary care pediatrician, I have a lot of parents, sometimes they're hesitant to mention it, but they will start to mention, oh, I asked ChatGPT about this. And I'm of the belief that we should be more transparent, encouraging that these are tools that are here to stay. And I think what's actually important as clinicians is that we actually start to ask and understand how patients are using these tools. So I sometimes start to have questions of, okay, what tool are you using? How did you prompt it? Not in every visit do I have the time to get into all of that, but these are relationships with patients over time. So I think it is important to start to be that bridge, to be able to understand how families are using these tools. And then going back to the kind of the case, what I would add, I think, coming especially as a pediatrician, we've had a decade plus of inpatient rounds that's really family-centered rounds, where at least in the pediatric community, there is this preference to sharing more in the room around the uncertainty in medicine, that actually most decisions are not necessarily this definitive thing, but that there is a lot of deliberation that happens between different clinicians, different family members. So at least from that kind of training and practice I've experienced, I kind of lean towards the side of actually being more open with disclosure. But I think there's also a few other facets to this. We talked about earlier, I think Gabe had mentioned the role of the pharmacist. So imagine when as if I was the physician choosing antibiotic A, I might also send off a message to the pharmacist, or the pharmacist may actually also intervene, being like, hey, we noticed that the AI tool said this, so that there's probably more happening there. And then the other thing that I'd be interested in knowing is, why is this AI tool recommending this? Was this, what level of transparency do I have as a physician with this AI, clinical decision support tool? Does it tell me, was it trained on patients that are like the patient that I'm taking care of? What are the different biases that I need to know of there?
Right. There's a question over here.
I was going to say, one should proceed with the assumption that the patient has checked it on and going forward, it's a collaborative process
between you and the patient. That's one. And two, getting to the case, you consult a colleague and you're discussing, or you're consulting AI, you have to admit to the patient that you don't know exactly what you should be doing. And that is something we're very uncomfortable about broaching, but that is absolutely necessary in coming to a trust relationship.
I just wanted to follow up. That's a very interesting point there, because I remember in talking with an infectious disease clinician once, she said, there are so many antibiotics. It's not just A or B, there's so many. And we're going to try things. So sometimes if something is pitched in the sense of, we're going to try this, we're going to try that, and presenting risks, burdens, and so on quite clearly, that's part of the relationship, especially to the family, who might be looking up, how do you spell the name of that drug? I'm entering it in right now. I mean, in the contemporary family member, if that family member is there as the patient's caregiver, advocate, surrogate, I could speak to this as a caregiver myself, you'd see it as part of your job, to do what the patient is not able to do for themselves.
We have a rising luminary in the world of patients consulting with ChatGPT and other devices. So Andrew, I saw that you had a comment. I'll channel my inner Oprah and bring you the microphone.
Yeah, so I am actually interested in seeing how parents use ChatGPT. My comment was actually going to be a little unrelated to that, about kind of that ethical dilemma of wanting to know what information an AI is giving. I think that in this scenario, it's actually somewhat unique in deciding a drug, because rather than giving a diagnosis or, I guess, surgical decision or behavioral guidance, there is an incentive to a third party for which drug is chosen, which I think is to some extent a public bias, that maybe doctors are being led by pharmaceutical companies or whatever to choose particular drugs. But in the same way that doctors can now be given information sessions on new drugs, as a physician or a patient, you could be skeptical as well of, is this company giving information about their novel drug, and how is the model actually taking that information and making legitimate decisions based off of it. So it is, I think, in the situation where there is choosing money to go in one direction or another, there's just additional complications that require a lot of transparency with whatever company's creating that specific AI.
Well, I think you're also defining what may be a conflict of interest. And when we talked about, one of the other slides, I listed values, that you don't always know what values are encoded into the AI solutions. And it doesn't pose a problem as long as, so for instance, if the health system if there are two antibiotics that would work equivalently for this patient, you order the more expensive as the clinician, but the AI system recommends a cheaper one because it's more cost effective. Again, as long as it's effective for the patient, I don't know that that's a real conflict. I don't think that that's wrong. In some ways, that's a good use of resources. But to what extent would it be helpful to know for that to be a transparent trade-off? So the health system may have, or the AI agent may have made that sort of trade-off for you in some ways.
Yeah, I think there could also just be a bias one way or the other, even if it's not influenced by a third party, towards deviating towards not using novel medications, going off of a mechanism in small trials. If we say it's not justified and we're not actually gathering data on if it continues to work at a larger scale, and then we could also, the AI is going on what's traditionally used in trials that we have the most evidence for, but small trials aren't giving any evidence.
And one thing in this dialogue that I should just mention is there tends to be in bioethics the idea to say, don't do rationing at the bedside. Don't decide that you're in charge either of saying, well, this patient's not worth the investment, or I'm going to save the system money through my deft knowledge. I'm going to make sure that we find drugs to save the system money, not necessarily the patient money. But with everything we've learned today about the fact that the system is counting on billing for as much as possible, so that the system might not appreciate you trying to come up with a cheaper option if it's looking to bill for something that they can get reimbursed at a higher rate. So it's quite confusing on all of this. And I think this is going to be a time when there's got to be a lot of very direct discussion about these issues. Clinicians don't also, to be fair though, clinicians usually don't know the price of the drug at that moment. It would be hard to discern that in the moment.
I think we have a question back here, and then we'll come over.
Hi, really interesting discussion. Do you think that maybe this is not just about the AI and technology, but a larger shift towards consumer-facing, or healthcare becoming more consumer-facing rather than like a patient-facing? So much of healthcare that has been happening in the past has been almost like a black box. And now there's a spotlight essentially on that black box, opening that up, and people can actually see what that is, and they're starting to ask questions, and they have their own little, LLM explaining things to them so they can ask more questions. So do you think this is more of just like a cultural paradigm shift? And as clinicians, how do we start thinking about that? I don't know.
Yes, I mean, I think this is more information. Whether even leaving the patient and the family to one side, this is a lot more to take in. This isn't you seeking out a colleague and running it by them. And again, I really appreciated the comment earlier. A hospitalist carries a large census. They carry a large number of patients. That their presence in the hospital is meant to help with the billables, to increase the throughput, to keep the Medicare reimbursements flowing for a patient like Mr. Singh. So the idea that hospital is going to have a lot of time to run around, the AI might be like, oh wow, this is so helpful, because hospitals also tend to be early adopters of technology. I did some work with hospitalists some years ago, and so that time suck issue is a really present concern with them. That said, this hospitalist decided against the AI. He or she went against the easiest solution, which is just go for the default. So there had to be a reason there. And so our question, I think, right now is, do you need to explain your reasons? You don't want to say, well, this is so technical, the patient or the family won't understand. And there could be a sense of, am I going to have to defend this later? This is going to, there's always the concern about liability. So I do wonder about that when you are diverging at this moment where standards are not clear. Do you need to explain yourself to someone?
Yeah, the other piece I would add to this, I just want to pick up on the distinction that I think you're making between a patient and a consumer. I think we're going to see probably more and more direct-to-consumer AI. The issue there is that the patient role has distinct both legal and ethical obligations, normative expectations that are different from a consumer, right? There's consumer law, and then there's sort of patient legal medical law. And ethically, there are different expectations. And so I think, and I think about this in the context of somebody going and getting a full body MRI. I'm going to go out and I'm going to buy my full body MRI. That's a very different process than if I talk to my clinician about having, imaging done or whatever that might be. So I think you're on to something about a distinction that's going to be becoming more clear in the future between the role of the patient and the role of the consumer relative to AI. Flo?
I'm going to go back a few points and then come back to you mentioned full body MRI, and that was my little cat. Okay, so anyway, the first thing about the pediatric comment I just wanted to raise was that if you think about it, pediatric data on its own is very limited, right? So most people, there's like a law or something where technically you're not supposed to engage with the internet or store information for people who are younger than 13 years old, like that kind of thing. So by default, there's a gap in a lot of AI training for generalizability to patient populations. So I'm always a little concerned when people say they've looked at it for pediatric folks in particular, and even also extreme elderly, right, 89 and up. So I think that there's gaps there, and part of that then translates to the consumer versus patient conversation is, well, without that education and understanding and transparency, how much information in the background do people need to know to use it safely? And then the last thing about the whole body MRI and those kinds of things is, again, back to the false positives and false negatives and what could cause harm, and the alertness for people who don't know something that's in their thing. And full disclosure, I've gotten one of those just because someone had offered me one for free, and that's been such a fun thing to realize that a nurse is calling me being like, so-and-so, can I explain your MRI to you? And I was like, okay, please go ahead. So I would love to have that conversation as a separate thing, but I don't think that technology is actually ready, but at the same time, there's no gatekeeping from the radiologist saying, this isn't appropriate for your situation. But of course, if you wanted to pay $3,000, have at it.
Yeah, no, great, thank you. I'm sorry, did you have a comment or a question?
Yes. Thanks. So I teach ethics to engineers, and they would be surprised to hear our conversation today, because pretty much we see like a sort of collaboration between people from business and engineering, whatever. But my point is to address your point regarding rather we should disclose information. I was thinking about risk in the sense that we should kind of know if disclosing information would change the patient's perspective on who has or who is holding responsibility in case something goes wrong, right? And I'm not quite sure, because I don't know how hospitals work in terms of compliance or all of that, but in that case, would you say that are there situations in which doctors and physicians have to hold responsibility by themselves apart from what the hospital would recommend? For example, if they have a new protocol and the hospital is enforcing somehow physicians to use their AI tools, but the physician is led to his or her own responsibility in case they want to reject the recommendation. Would that be possible to frame such a two ways about internal rules in this case, when the physician has to deal with their own responsibility apart from the organization? That's basically, sorry, my brain works a little chaotic.
So just from a health system perspective, you can't really opt out, because the predictions are going to occur when you open the medical record. So you're going to get them whether you want them or not. And then you can't not know the information. It's not like click the box and we'll give you the information. You're going to get the information, and then you can't not know it. So that raises lots of ethical and legal concerns. Also, if you can't ignore it. right? A lot of the prompts that have traditionally been in the electronic medical record, you can just push ignore and pretend like you don't know it. But I think in these, if we've said that this information is beneficial, you can't not know it. Even for ambient AI scribes, it just, from a health system perspective, letting people choose, like, oh, I want to use the scribe, and other people choosing, we don't, that sort of system is inefficient. And in general, we need for everybody to be on board with it. I do think that it asks an interesting question that Gabe asked earlier about how much information about clinicians we're retaining. And I can tell you, just being in conversations about these clinical decision support tools around antibiotics or medications, because there's a huge variation in how people are treated in patients, and it having to do with antibiotics or medications. And that leads to increased length of stay, that leads to readmissions, that leads to all the things that hospitals don't want. And the idea is that these would be embedded, offer real-time support as you're typing your note, and it would track the times that you overwrote it, right? That would not just be, that would actually be a tracked metric for how many times you overwrote it. And I mean, and you can see how that can, I mean, do clinicians have an expectation of privacy? Right? I don't think so, not professionally. And then the other part, I mean, I think about some of the surgical models where, for instance, the amount of pressure that's being applied to structures, if we know that there's a higher rate of complications associated with too much pressure, and a surgeon, despite remediation, training, simulation, continues to place too much pressure on structures that results in complications, should we tell that surgeon they can't do the case anymore? Or during the case, if they're about to exceed that threshold for an individual patient, and this is my hospital quality hat, do we lock them out and say you got to go find somebody else to finish the operation? Because if we know harm's going to be, I mean, that's going to make you very popular, let me tell you. But I mean, there are these questions, because if we know that there's the very bright threshold for harm, and we're able to actually know in real time that somebody's about to cross that, I think there are ethical and legal reasons why we would not want to let that happen. Do you have
basically, what we are talking are large hospital systems, which are governed differently than private practices, at least in the state. So small private practices are closed entities, and they wouldn't get into regulation or even have greater information systems coming in, which the larger hospital is. But we have a system right now where the consumer does by default have to decide, and that is anyone who's tried to make a medical appointment. If this is a medical emergency, please hang up and go to the nearest emergency. Or therefore, that weight is placed back on the patient/consumer. So part of that system has already begun in terms of having judgment into the system on who's making that decision, and it's being forced back.
I know it's always a good case when you're discussing the case number one and you know there's others in the hopper. But one final point I just wanted to make with respect to, we're talking about hospitals and we're talking about clinical workflow. Hospitalists work on shifts like nurses. So if we imagine that, should there be a disclosure to the patient? Shall we discuss this? If a patient who's 86 years old, who has multiple comorbid conditions, develops pneumonia, and there's nothing on his chart that says don't treat for pneumonia, or maybe an advance directive or something, or don't use antibiotics or something. Let's assume there was no barrier. You wouldn't necessarily, let's say this happened at an odd hour of the night or very early in the morning, and maybe there was maybe the patient was asleep. Would you, I will ask the nurse, would you just go ahead and order the antibiotics?
You make a really good example. I'm a former ICU nurse.
Yeah.
the nurse wouldn't order, the physician would order it, but certainly for an ICU patient, that treatment would occur. The family's called at a certain point, but not for administering an IV biotic. That wouldn't be typical. It's a change in patient state, which you would call the family in the middle of the night, but typically really for, a major change.
So this is something that seems like it's high stakes, but in the context of what could be going on, might not be seen as a really high level decision, not an intubate kind of a decision. But routine medications all have ethical dimensions too.
Yeah, and you can imagine, taking this case a step further, if the patient needs to be intubated, or if he's on 3 medications to keep his blood pressure up, and he's intubated, and there's something that may need an operation, right? He starts to have signs of ischemic bowel, say. So you can see how you can escalate the case. Let's actually just skip the second part of this case. The second part, I have this slide. The second part of this was simply that we were going to say that basically the clinician made the wrong decision. The patient didn't respond, and you had to change antibiotics. Antibiotics are changed to the antibiotic that AI had suggested, and then the patient starts to improve. At this point, does anyone think that you should disclose that you overrode AI and that may have resulted in a delay in treatment? Gabe? Oh, yeah, no, I'm...
Oh, can I have an opinion or am I just...
Yeah, what's your opinion?
So, yeah. I think that, and I wonder what Nicholson would say about this, but there's fundamentally in all of this is, as the issues, there are 2 issues. I'm gonna keep it actually simple, because otherwise I could talk about this for 20 minutes, but I'm just gonna say the simple thing is, if I went and grabbed a book, okay, I grabbed Stanford's antibiotic guide, and I read in Stanford's antibiotic guide that the recommendation would be for antibiotic A, and I chose to give antibiotic B for whatever reason I chose. No one would say you need to go disclose that to the patient. No one would say you read something in a book that had a reasonable description as to what you would do in this case, and you made that decision. No one would say this requires disclosure. It seems to me a little bit arbitrary to say that just because this was a system that is a recommendation engine, which is essentially a book in digital form, that this is any different than that. And this happens all day, every day, where clinicians make these decisions, and sometimes they're right and sometimes they're wrong. And the only scenario where this defines or requires disclosure is when we think that the realms of what defines the autonomy of a surgeon, or what defines the practice of a surgeon, is now being limited to the point where they can't make decisions individually about how they choose to organize data that is brought to them as it relates to antibiotics or other things. And so in my opinion, the only scenario where this is a disclosable event is if we no longer believe that clinicians are able to integrate data effectively, and that requires them to make some kind of disclosure to the patient. So I think the problem in a lot of these discussions, and that's why I said I could talk about this for 20 minutes, is some of these things that we're doing are pushing the role and autonomy and what we believe to be what clinicians are responsible for. We're pulling it out of their hands.
Yeah, I agree. Bob?
So I'm wondering if it becomes more relevant not switching antibiotic A versus antibiotic B, but doing an intervention that's much riskier, for instance, or where the risks and benefits are significantly different and there's a high degree of uncertainty. So, saying, for instance, most people, usually I would treat this with, medically with medications, but AI is saying to do it with surgery or something like that. In other words, and it's riskier, but, or if there's some sort of calculus that changes in terms of risk-benefit uncertainty, I think that might potentially shift some of the disclosure responsibility. I'm not sure. Just wondering.
I mean, one thing, I started my career in bioethics in the disclosure of harm, and the encoding in the medical record with the prompt, I think to a clinician would look like it was standard of care, such that to override it looks like a departure. So it could be somebody feeling like this was a liability situation, even if it wasn't. That's the frame. But that's just an observation.
Yeah, a couple of things. So in general, when patients come into the hospital, unless they state otherwise, they would like for you to do what aligns with their goal, which is typically to get better, right? To reverse the illness trajectory. And so we don't disclose every lab we order, we don't disclose, but there are categories of things that we do disclose, or at least that we ask for assent or consent, right? So we don't go in and examine patients without asking to examine them. We don't take them to surgery without asking informed consent. So these are so I think it's a bit of a sliding scale. The other question is, from a trust perspective, are we at a point of exceptionalism? And I think we'll go on to another case, and we're just going to go through our Q&A, and we can incorporate Q&A into this. So we'll just go on until 3:30. But one of the questions is, is it important for us to let patients know, and people debate this back and forth. Some people think it's beneficial and fosters trust. Other people think it's unimportant to disclose every instance, and it confuses patients. In my mind, there should be a place that patients can go to if they want to know, but that we don't really tell them every single instance, because that becomes tedious and a burden to everyone. But I do think it's important that if somebody says, look, I really want to know in what ways AI is being used in my care, and there's going to be a subset of patients who will want to know that, not so that they can exercise agency because they're curious or for whatever reason. I do think it's important to have that available, but not necessarily to, and you can actually see there are a number of health systems that have started listing their sort of AI inventory on the website. So that may be an opportunity there. So, let me go into the next case. All right. So this is getting at again about telling patients that AI is being used. It's a case, patient 72, multiple admissions for congestive heart failure. At baseline, before she's had these congestive heart failure exacerbations, she's been highly functional. But she's been admitted several times recently. During her current admission, when the cardiologist caring for her opened the patient's medical record, an AI-enabled mortality model predicted that the patient's risk of dying in 3 months was 85%. The cardiologist looks at this prediction and thinks that it is wildly too high, that her chance of dying, 85% chance of dying in 3 months is too high for this patient. The patient's daughter is there when the cardiologist makes rounds and asks the cardiologist, Dr. Hart, Mom has been in and out of the hospital several times in the last few weeks. My family and I are concerned that she's not going to make it. Is Mom going to be okay? What would you tell, if you're the cardiologist, what would you tell the patient's daughter? Yeah, Sarah.
Yeah, just offering a nurse's perspective here. What was so interesting is the risk of dying. That's not just from a cardiology issue, right? And so this is a bigger conversation, and it's a conversation that happens now. Nobody can say, you can't say, yes, your mom's going to be okay. That is not something that, you know with any level of certainty. There's, depending on the patient's particular state, some things you can know, but That's probably one of the most challenging questions any clinician can get.
100%. Many of these mortality models are built on like 10,000 individual structured pieces of data, so huge amounts of data that they're built on. You just don't know. I mean, my nightmare case is the 19-year-old who comes in with a femur fracture, and the mortality, a healthy 19-year-old femur fracture, comes in, mortality predictor is 90% in 6 months. Everyone's like, does this person smoke? Does this person use drugs? Like what's, they go through the sort of the screen, high risk for cancer, no. And so they dismiss it. But the trauma surgeon I think will appreciate this, because it turns out the femur fracture was from a motorcycle accident and they don't wear a helmet, right? So pieces of data that's completely unrelated because, again, there's a lot of data. I'm sorry, Nicholson.
I think similarly, I have two questions, which is this a good AI mortality model, and are you a good cardiologist?
I think you're referencing my talk about the moment for reflection, right? Assess your skills.
I mean, I say that jokingly, but like, I'm not really kidding, because if you are a world-leading cardiologist and this is a pretty good mortality model, I think the answer is really different. And if you are a run-of-the-mill cardiologist and it turns out this is a world-leading mortality model, like those, I don't think those come out the same way.
Yeah, but and we don't know if this is her cardiologist or the cardiologist du jour that you're seeing in the hospital. I'm probably guessing the latter. If you left AI out of it, my mom has been out of the hospital over the past few weeks, but that right there should be, that you would train people to say, if you see a patient who's coming in enough for a chronic progressive condition, it's time to talk about prognosis. It's time. That's like what you're trying to get people to, don't pass that on to the next shift, don't wait for the next hospitalization, readjust hopes, all the things. The second is, you'd want people to pick up on that. It would be so weird to lead with, well, AI says, that would be so weird about this scenario. Interesting thing though, the 3 months, this patient, if this is, 3-month prognosis would put you comfortably inside hospice eligibility. So that is, while there's a lot that's wrong with the idea of 6 month being determinative and it's overinterpreted, you'd be comfortably eligible for a Medicare financed scope of service, and which takes discussion in and of itself. But so there's a lot here that has to be discussed. Whether or not, it's almost like whether or not you even mention the 85%. A patient who's been in and out of the hospital with congestive heart failure right there suggests that there's deterioration going on. And time to talk about hopes, where do you want to spend the rest of your life? Not 85% chance of 3 months, but you may have to give people some idea of, is there going to be going back to a baseline or not, because the baseline's gotten very elusive.
Yeah, I think that's a great point. It is not just about the risk of dying, but what's that going to look like, right? Is mom going to be in and out of the hospital for the next 3 months? The other point here that I wanted to use this case to highlight is that unless the cardiologist understands that prediction is made on a day-to-day basis, right? The cardiologist may diurese that patient overnight, may increase her dose of some sort of heart medication that helps her heart pump better, and the next day, her mortality risk may have gone down to 50%, right? So you have to understand the tool, and in this case, the prediction is made every 24 hours based on the data that's available to it. So this patient's labs, her function, her weights may have all suggested that that's true. If she stays the way she is today, then that's true of her survival. But if she's optimized, right, if her cardiac function's optimized, we may actually be, so it can be mitigated. So the prediction can be mitigated, does not have to be an eventuality. Yes, Flo.
So I have a few questions around this, probably also from last night's conversation. Was one, values, right? Is the, I guess, the clinician and the patient, right? If the patient brings this information to the clinician saying, hey, I have a tool that says my mother has an 85% chance of dying. What do you think now, right? I think that conversation is going to be really tricky. And what then how much value you place on the AI tool. And then I'm going to pause and go into the next question, which is, we were talking yesterday about how you can always make things look better for a little while, right? Then the next day it says 50% chance of survival. We were talking about how sometimes you can make the vital signs a little better for a 24-hour period, but the person's actually deteriorating for whatever reason. And that gets a little tricky and hairy as well. And finally, the last point is, in radiology, and I actually don't know for the rest of the EMR, we only have to store records for 2 years. So a lot of, some states have extended that law for longer, but in this case, if let's just say something goes wrong and you're having some injury, right, that they can't go back on like the 2 years and 1 day, it might already be deleted, right, to have that AI result. So I don't know in this case for all three questions what you have thoughts about.
I'd love to see a discussion of this in some way where you're presenting this to a group of residents, and one half of you're in two different rooms, and one half gets the case with the AI tool and the other without the AI tool. So one is just, what would you do? How would you talk about prognosis, talk about the patient's preferences, what she wants in terms of treatment relative, now that I know that my prognosis is it's congestive heart failure, so she was never going to be fine. But if she knew that her time was shorter rather than longer, maybe she would not want to come back to the hospital so much. Maybe she would want to spend her time at home with her grandchildren. Since she's a churchgoer and she's been in and out of the hospital, maybe the chaplain should be involved in these conversations. But how much does the AI, does that make it seem harder or more certain because you've got a percentage attached to it? Of course, you could look up the percentage without it being the AI prompt. So I would love to know, somebody could run that as a little study, to say what happens when you add AI when this is a very recognizable common scenario in an aging society like the United States. You've got to be ready for this. A nurse might notice, this patient's been in and out of here 5 times in 5 weeks. What are we doing to this family? These are the ones that set up moral distress. That someone isn't talking, someone isn't leveling to this family, or it can be blamed on the patient or the family. They're choosing this. They're torturing this woman. It gets so unpleasant. I'm not sure AI alone is going to fix that. Certainly not coldly saying 85% of being dead in 3 months. That could turn the whole situation against anything else that doctor says, if that's the way you say it. If you just cite the AI, it's going to look like you're hiding behind the data.
Yeah, and I think it also is, just reflecting Nancy, not everything needs AI, right? Bob, did you?
So I was thinking of the slides that someone showed this morning showing that like 90% of patients would want to know if AI was being used in their treatment. So I think there's a gap there between what we're saying and what patients are feeling. And so wondering how we might best address that. Is it patient education? Are we missing something?
That's a really good point, because I think sometimes when we imagine that patients would want to know, the patient isn't imagining this scenario. They're not imagining, you're about to give me really bad news and you're going to tell me AI came along for the ride. There's lots of wonderful research that this reminds me of on, do patients want to know their risk of developing dementia if they have elevated risk? They tend to want to know. And then later, when they're told you do have elevated risk, they discount that information because they'd rather not bring it in. So this would be such a new thing to bring in. I'm not sure whether people would say, oh, well, I guess that means that I'm a goner here, or I'm going to discount this. Well, AI technology, what do you know? And what could happen then, if that happens, then the family might say, well, we don't trust you. I mean, we don't trust, you're saying my mom's a goner in 3 months. You don't know, she's a fighter. She's got her faith. What are you talking about? So you have to think about how something about technology and percentages is going to land in a conversation that has to be about people and feelings and mortality and all of those things. There really is a way that this could be helpful. I can't see just landing in a cold fact about as though AI has settled it is going to help you with the conversation. This is exactly the sort that's called a difficult conversation for a reason.
And from a consequentialist perspective, I think about what does it mean that these predictions can be discovered by the patient and their family? Because the interpretation that I get from my compliance colleagues is that anything that is pertinent to medical decision making regarding an individual patient that's generated in the clinical setting should be in the clinical chart. So that means that almost every AI prediction will go into the patient's chart. They may not be in your My Chart when you open it, but it's going to be in the chart someplace. So just playing this scenario out, and again, this is sort of a consequentialist perspective. So mom codes and dies that evening, right? And you find out that the doctor was told that morning the patient had an 85% chance of dying, and the doctor didn't say anything. They didn't get to say goodbye. He knew. Dr. Hart, she knew. They knew. And so you can imagine how that could feel, getting to Bob's point about wanting to know disclosure. And I'll just sort of throw this out somewhat facetiously. In the mornings when I drive to work, I listen to NPR and I hear, "Come to New York Presbyterian Hospital, where we offer the latest in artificial intelligence and machine learning technology for your personalized care. Stay amazing." Right? I do. Is that disclosure? Should patients reasonably expect that AI, and it can cut both ways. My 85-year-old mother-in-law just went in for a procedure a couple of weeks ago, and she asked the interventional radiologist, "Are you going to use AI to help you with this?" She was getting a lumbar, epidural placed. "Are you going to use AI to help you locate where that needle should be placed?" Right, 85. So, I mean, it can cut both ways. Let's go, are there any more? Oh, yes, Sarah.
Yeah, I think this is an excellent example of making sure we don't predict the wrong thing. So we talk about user-centered design all the time in informatics, but here is where you should engage with the care team to say, what is it? What is the information that you want the prediction to tell you? And I would venture a guess, it may be a recommendation for a family meeting, which is something that is often delayed, not happening in as timely a manner as it perhaps should be. And when we develop AI, a predictive model just has an output to it. But that's not something that immediately we just present to a clinician. We have to go through the work to say, how do we turn that into a score? Do we show a percent? Do we turn it into something else?
100% agree, because if an AI is saying that a patient is 85% likely to be in the hospice eligible range, to me, I would want to know what other patients are being scored like that, and does primary palliative care know about this? Because is somebody talking with these families about, after a discussion of prognosis with their treating clinician, about POLST or MOLST as it's called in New York State, saying, now that we know this, we should talk about the fact that the nature of your condition is such that you're going to keep coming in and out of the hospital. Now, where would you like to be spending your time? Is there any way that we could manage this at home if that is your preference? Most patients do want to be at home, and they're coming into the hospital either for symptom management or because they think they can fix the situation. So that would be the other, is where's the quality improvement point? It's been proposed for decades, the idea of pulling charts back in the day and saying, here are the patients who look like they're moving toward the end of life, but we have no advance directive or we have no surrogate. And so that would be one of the, but I do completely agree that this is an indication for a family meeting, not for here's your number. It's not good.
Yeah, absolutely. I couldn't agree more. Let's go to the next case. So this is a case, Mr. Gonzalez wants surgery. So in this case, Mr. Gonzalez is 88. He has what looks like relatively mild coronary artery disease. He had a stent about a year ago. He's been recently diagnosed with liver cancer and is seeing a surgeon to have the cancer removed. We're going to, for the sake of the case, we're going to presume that this is a very operable tumor. Mr. Gonzalez wants to have surgery to remove the cancer, but the surgeon believes that Mr. Gonzalez is too high risk. The surgeon uses an AI-enabled surgical risk score, similar to the one that Gabe talked about earlier, and it predicts that Mr. Gonzalez's surgical risk is low. The surgeon disagrees. Oh, so the prompt should be, well, what are we going to tell Mr. Gonzalez? So Mr. Gonzalez wants surgery. He technically meets the candidacy criteria for surgery. The surgeon has made the determination that he's too high risk. AI says he's low risk. That coincides with what the patient's values are, but the surgeon feels otherwise.
And what is the definition of surgical risk here? That he survives the procedure or something beyond that?
Yeah, how's surgical risk being measured? And is it, so here's where surgical risk, is it the patient's risk of dying? Is it the patient's risk of serious morbidity? Is it the patient's risk of prolonged hospitalization, potential need for subacute rehab? Or is it the surgeon's risk?
I'm a physician with electrical engineering computer science background, so I designed computer chips before going to medical school and did software even before that, hardware, software, and medicine, all by design. At 17, I decided I wanted to do that process. So I'm very much involved in care quality, and in engineering, you can imagine a chip being recalled, right? The expense of it all, and it's happened. So I apply that to care delivery, and the thing with stent placements in or any kind of these surgeries in elderly people, often it's underestimated the risks of stroke and other events. In this context, if I could, I'd ask for a second opinion.
Yeah.
And that's to say the same was true with the hospitalist. There are too many things going on. Is a community hospital, is a tertiary center, is an order set already in the computer that's monitored by the ID experts? There's too much nuances in care delivery. So when I go to the AI conferences, some of them have mostly computer scientists, very few clinicians, and what I like to bring into, and I'm very STEM, but I bring into the emotions in healthcare and how important it is. And so there is no one kind, how do you address a patient? Well, it depends on the patient. Certain patients with an engineering background, almost probably anybody here, quant-oriented, they want to hear all the alternatives. Other patients will say, you're the doctor, you should tell me what to do. The exact opposite. And then there are other patients that'll say, I don't want insulin. My aunt died of insulin when she was really late-stage diabetic, and there are all these things that are going on. And that's some of the frustration in healthcare, but also some of the enjoyment, in a way, this connection with the patient, and that's what I emphasize. And I emphasize to them, if they get a chance, round with an inner-city doctor for a day or two, do a little volunteer work, see that world, which I never understood until I went to medical school. And so in all this discussion, the emotion, we're doing all the STEM with the AI and the percentages. Don't tell them the percentage, in my opinion, because that can actually lead to their death. We are often wrong. We don't always know. And so just suggest the hospice care sort of option and things of that nature, but also possibly suggest if they're in a community hospital, and this is not an indictment of community hospitals, that maybe they come to a tertiary center like this center, which is where Bill Clinton went when he had a heart attack. Yeah. Of all the medical centers, there's a heliport, I believe, at this center for cardiac care. It's a Bellevue for trauma. So the President of the United States, when the President comes to town, it's Bellevue's trauma center goes on alert. So that and Cornell are the two level 1 adult trauma centers. So this is the system's perspective. And so I guess Anyway, so these things are so nuanced, but it's good to bring these things out in the open.
Yeah, one of the things I hear you say, and I appreciate your comments very much, is that this may not be an AI issue, right? That this is and for a lot of these cases, the disagreement with AI has been incidental. That this is really good patient care, right? And I think that is probably the theme that I've heard the most today, and I'm sort of segueing into our closing. But I'm certainly, this is what I'm hearing, is that these are age-old questions in some way. We're just applying this new technology to them.
This is the kind of case that might actually be referred for an ethics consultation if the surgeon doesn't just want to withdraw from the case and say, go find yourself somebody who agrees with you. But it isn't to say, well, it's patient's preferences plus AI equals right decision. The surgeon might be saying that you're 88 years old and have more than one thing wrong with you, and I'm concerned about the effects of the anesthesia on you. Here's these potential bad outcomes, and but it might need more of an airing than just simply 2 against 1. It would be weird to give AI the status of another professional or more weight on the scale in that case. It just doesn't seem like that would produce the best airing of the challenge.
I have 2 thoughts. The first thought is that, the major risk calculator that is available in the United States actually has an adjustment available to it specifically to include surgeon intuition. So if you look at the NISCOP risk calculator, there is a segment on the bottom right hand. It says, does the surgeon think that the risk is slightly higher than the prediction or significantly higher than the prediction? And what that does is it changes the risk by 1 standard deviation or 2 standard deviations. So so it does change it. And so there is already this belief that there may be data elements that are not available to the model that are available to the surgeon that the surgeon is able to integrate. The second piece, which is maybe counter to the overall move of this conversation, is that it may actually be that Mr. Gonzalez's surgical risk is low. And we did a study where we asked surgeons specifically to predict risk for patients across the entire continuum, and especially patients at high risk, because there were many acute care surgery patients, and their ability to predict outcomes was poor. And so it's not 0, right? It is significantly better than random chance, but it is significantly worse than an AI, not an AI, any risk prediction model. Yeah. And this is in line, actually, since I mentioned it before, this is in line with Daniel Kahneman's perception of the value of algorithms versus human capabilities, which is that the nuances of data that define someone's outcome risk, in some ways humans are not that well designed to actually evaluate that, whereas an algorithm that takes data over 10 million patients has a capability of, at least at a population level, defining that risk much better.
And the other thing is that the data on which AI is trained is the result of those decisions, right? Those historic decisions. So it's not like the results of a randomized controlled trial. It's the result of the accumulation of those decisions. Just the other piece that I wanted to bring, this case I wanted to highlight, is this very point, our overestimation of risk, many times relative to age. And if you look at cancer survival curves based on race, Black patients have a worse survival for almost every solid organ cancer. And when you drill down, in large part, a large contributor is that they're not treated with complete longitudinal cancer care, which oftentimes, in those cases, omits surgery based on Black patients being scored at higher risk. than white patients, even if for similar physiologic risk. Surgical preference, surgical risk calculations overestimate the risk of black patients, and so black patients oftentimes aren't. And so our data reflects that, right? Our data reflects those sorts of biases when it comes to risk, and many times it's intuitive, it's subjective. You look at a patient and it becomes self-fulfilling. So if you're taught that black patients are at higher risk and you don't operate on them and they die of their cancer, and it looks like they're higher risk, and so it becomes self-perpetuating. I'm sorry.
So two thoughts. So one, I assume surgeons are underestimating the risk. Is that right? Is that where the error is when you said they
overestimate? Yeah.
Because I was going to say, on the one hand, I'm wondering how much psychologically there's an element of sort of therapeutic hubris to a certain degree. Like, I'm going to operate, I'm going to make them better, kind of thing that may be leading to sort of inaccuracy in the prediction. And then I'm just wondering how much is sort of racism. I mean, in other words, if there's, we know that people of color often have much poor access. Often there's less intervention suggested for them or recommended, which I think reflect racial attitudes.
Yeah.
Or that might be embedded in the AI.
Yeah, I mean, I think there's a greater chance of de-biasing AI than there is of de-biasing people. When we talk about, it's easier to scrub data than it is to scrub a human being. I mean, when we've looked at some of the interventions, the lung cancer data are the data that I know the best, where if you look at black patients who've been offered surgery for lung cancer, or who've even seen a surgeon after the diagnosis, and then have seen a surgeon and are actually taken, and then if you have expert reviewers say, yes, this patient should have been taken for surgery, patient's risk was overestimated. If you look just at lung cancer, and then in one study they did focused interventions with groups of surgeons that tended to overestimate the risk of black patients. And so they did like an 18-month intensive feedback education, and then they observed them for the next 2 years, and it didn't change their practice. So that study in and of itself, when I looked at it, it made me wonder if AI may be able to help us de-bias, and not necessarily instantly, but in an incremental fashion. If we measure our own levels of bias, and we say this is where we are today, and we don't sort of throw AI out, but to say it has the potential to help us incrementally de-bias some of our decision making by making it more objective, giving us more objective criteria for making, so that we're not overly influenced by our own hubris, but at the same time we're not overly biased by our own risk and concerns about our liability, our reputation, our referrals, all those sorts of things.
No, just the point that the way we have generated AI at the moment is sort of fossilized empirical data. And the other aspect of AI is to try to bring in as many dimensions as possible. So, for example, removing race, that decreases data, which is contrary to the logic of what AI tries to do in bringing in all points to it. It's sort of, there's a loop here where because the one with the most information, the toy with the most information wins, and we don't know when to throw away the toy. In terms of our teaching, one of the things, whether you teach residents or otherwise, or fellows, is when to bail. And it's very difficult. AI doesn't tell you when to bail.
Yeah.
Yeah, thanks so much. Charles, that seems like an advancement of the conversation, in my opinion. I think that there's, for a long time there was a sort of idea, I think a sort of naive idea that AI will allow us to get rid of bias inherently, as opposed to in a very conscientious way dealing with the data that it's trained on, right? So I think that the way that you've reframed that is quite helpful. I think the question of race and data that was just brought up, and that's more information is better is not always, I think, I don't know, is not always right, and race is not always the right construct, but I don't know that that we want to go there now. But I did also want to hear from you all. I mean, so how the comments on bias in these programs relates to the conversations we've been having all morning. I mean, it feels a little like an add-on at this point. I'm not. That's not an accusation. It was just a comment that, you know, I felt like we were this morning coming up to some takeaways, some conclusions, and I know we're moving towards the summary section right now. Would be how to think about that in a more systematic fashion about how it feeds in on some of the bigger takeaways we've gotten, like the entity with more information makes the decision. We had a few sort of takeaways. How do these bias questions fit into those?
I just
Sorry, that was a lot.
Mention something about that is we're going to keep coming back to the idea of this has to be embedded in a human-to-human discussion. So if they're saying, well, no matter how you talk about the surgical risk score in this case, and if the patient wants the surgery, so there's his clear preference, and the surgeon is saying, I don't think you should have it, and enters this tool that backs up the patient, and you're still saying, but I still don't think you should have it, it could trigger, so you don't want me to have it, or you don't want my father to have it because he's old, or because he's Latino, or what is it? So there's going to be another, there's no settlement here with respect to the AI. So as one colleague said, you're going to need to probably bring in get another opinion in some case. Am I missing something here? Is there something about this case that it isn't just a patient and wishful thinking? It actually could be a better outcome than I'm picturing, you know. But I think that's one of the things we're going to have to do when we're training people and practicing these scenarios in which AI is now a factor is how are you talking about it, but it is never going to cancel out the conversation that you're having.
Hi. Hi. So I just had one question, your thoughts on this. So how would you think AI will filter into personalized medicine? Like personalized care versus like what you mentioned before, that there may be racial or socioeconomical biases that's built into the system, like the healthcare system already, that the AI models are learning from, but then also that could be something that the AI has embedded into it versus the clinician or whoever the provider is. Did it make sense?
Yeah, no, it makes total sense. So this is my concern. I can run a model and I can assess its accuracy across patient populations. I can say, does it work? And that's really what we're getting at. That's what bias for an AI solution is. It's bias if it isn't as accurate for a certain group that it's intended to be accurate for. So I can actually look and say, is this statistically as accurate for men and women, age groups, races, whatever sort of population? But then when you put it into human hands, that's my concern. And that's kind of where the collaboration comes in and the potential then for the human biases to overrule or to misuse so we're spending a lot of time, and my data science colleagues are doing a really fantastic job, and they're so concerned about getting it wrong. But I think that the greater wild card is us, right? It's not the AI solution itself, but it's that collaboration that we've been referring to today. I think that's where we have the risk of getting it wrong. I think that the in vitro system is generally much more stable than the in vivo system, just across use cases, AI and non-AI.
Just one quick follow-up on that. Yeah, I mean, I think when I talk to developers, I would say my colleague Kelly Owens and I wrote a piece now several years ago that in Nature Medicine about the need for anti-racism training of AI and health developers. I think that I think the conversation has moved on substantially since then, but I still find that in my research with developers, very few of them have very much training on how to think about racial categories, especially as it relates to medicine. What is race versus biological ancestry, genetic ancestry? Those are different. What kinds of categories should we use and how? So I do think that while there's possibility, I totally agree with you on that point. And I can say, sorry, I should have probably given a preface that I'm faculty in the Department of Medical Humanities and Ethics here at the Medical Center. Yeah, I think I'm with you on some of that, what is possible versus where we are now. I think also that the design of those systems, I think also part of what we've been hearing about or thinking about is, are you the best cardiologist or are you the best AI system? Similarly, are you the best AI developer and know all of, your data science institute colleagues are very concerned, maybe not the sample of the average designer. So anyway, just to say, I think there's space, I agree with you on that, and I appreciate the ability to have time to say this, so thank you for having it be an open discussion. Yeah, that there's space, but still a lot of room for needing to train on the sort of in silico models also.
Yeah, thank you.
Oh, so just a follow-up question. So what about in a lighter light, personalized medicine? So right now there's different. I think Tempest AI is working on different models of creating targeted medicine based off of your genome, what will work best for you and such. So what's your take on that as far as using AI to personalize medicine versus the standard care system?
Yeah, I think one thing to remember, as many, I'm sure this isn't much of a reminder, is that AI isn't just one thing, it's many, many things. And I think if we're talking about the development of new therapies, a bench scientist might say, well, of course I'm going to use AI. It's going to speed up the calculations. I'm going to be able to run models that I wouldn't be able to run. So it could move toward that kind of precision medicine. I have a dear friend whose life was completely turned around by an immunotherapy for a very hard to treat form of lymphoma. And he happened to say last week, he said, I know now it involved all these different lab technicians, and I think about them, though I don't know them. I guess soon AI will do it. There's just the idea that you could move along to the promise of precision medicine more quickly. But that's just one AI tool. That's just one way of doing AI. So that could happen. I think in the broad, one thing I've observed is that there's kind of, sometimes we've been talking about AI in clinical settings, so usually AI in healthcare system. There's this broader category of health AI, which is this sort of idea of personal wellness and monitoring and lifestyle factors that can be a bit messier, like the idea of well, how much of this is going to be actionable? So it isn't really, it could be about you, but it isn't necessarily a precision diagnostic or precision medicine. So yes, of course AI is going to be used to develop these advanced matched therapies, but how it's being used socially toward health it's a whole other area, a lot of which you don't see in the clinical setting because it's direct to consumer. So there's a lot of promises certainly that are being made about AI and optimizing your health and developing profiles of things you should do and on. But that's another topic for another day for sure.
Great, thanks everybody. We're going to segue now. We'll do a truncated conclusion. So thanks everybody.
So we sort of morphed into a Q&A, but I realized people online, there were a few questions, not that many. So people online, we have a few minutes, so please feel free to ask questions that you may have. Here, bottom line, Well, here's one question, just came in. Bottom line, this is from Anonymous online. Bottom line, diagnosis and treatment is a collaborative effort whether AI is utilized or not. Does AI need to be specified as consultation? So I'll just put that out there too, rather than have our speakers come up. But I don't know if speakers or others have thoughts about that. Should we consider AI as a consultation? Does that matter? Or if other people have questions, please feel free to ask. But let me just first see if any thoughts on that.
I think it's going to vary a little bit by the question. So I think radiology may.
I think I needed a little bit more definition on the question itself, because when we talk about AI as a consult, I think we're making it equivalent to a human consult. And I will also say that there's a lot of questions around consultation, I'll make this short, in that in the hospital setting, I feel like some consultations are CYA consultations, right? And sometimes you just need a second opinion, and sometimes you're just, and CYA just cover your whatever. So I couldn't finish that sentence. So if that is the case, that's where it gets tricky, and that gets back to the legal thing that Nicholson brought up, right? Is if you agree or disagree and you're using it as a real consult and you trust that value system and want that, then that is a little tricky. And if there is that liability, that's where I think we have to decide if AI has that same weight and we trust it to that degree that it's considered another consult and has that liability on it.
There's also sort of curbside consults versus official consults, sort of informal. So if anything, it may fit more the model of sort of a curbside informal consult. Other questions? Yes. So this is in general of any of the issues we heard today. And for people online also, just a few minutes, but if you have general questions.
Yeah, thank you. So this goes to any of the speakers, but trying to take like a step back and think about, before you even get to clinical, more like the academic and science production aspect, and use the AI as academics and the ethical considerations there with all these tools to maybe increase abstract productions, grant submissions. I don't know, just general thoughts on that, using it in that process before you even get to the clinical applications.
So using, everyone heard the question, so thoughts on that? I think it is being used in a lot of grant applications and writing papers, but let me see if others have thoughts. Gabe?
You know, we have, the concept of a learning health system was developed for a reason, right? There's so much information out there, and it takes a long time to get it to the bedside. So adding on then abstracts and papers that are kind of auto-written and don't have, you know, the thoughtful science behind it, that can be very problematic. I'll just offer that opinion.
And just as a brief thought, that of the people that have been presenting this actually arose also from a AAMC conversation around should people be using generative AI in governance inside of the university system. And I do wonder that not everybody has that policy. So I wonder what it is here at Columbia and how people are advising students and faculty and their uses. And I've seen that happen badly on either side, right? People have either told or failed students because they thought they were using it, and also for faculty suddenly generating questions and being lazy about their courses. I don't know that society has a good answer yet, and that would be an interesting governance principle from the academic side as teachers and faculty, and also in the clinical setting.
Yeah, just so I think it maybe putting together this point of consultation. The journal that I'm one of the associate editors for has explicitly come out and said, you know, we recognize that lots of people are using AI systems to write journal articles. And so what we're going to do is we're going to test out and generate and publish, and they're out there now, a set of prompts that you can use to evaluate your papers. And we had a long discussion at our editorial meetings around what we should do with this prompting system that we'd put together, because it turned out to actually work pretty well. And in the end, we decided the best thing we can do is to give it to everybody, because if everybody is already using these tools to generate the articles, then they might as well use these tools to review them for them before they send them to us, so that the quality of the articles that we get is improved. And so I think that in terms of, there's a question of using these tools for generation, and then there's a question of using these tools for consultation. And I think in general, a lot of people would argue that there's a huge benefit in using these tools for consultation, and a lot less if you're using them for actual generation. So I have to give just this one final story. I get a lot of emails from students asking me that they're interested in doing research, and one of the things that I've noticed over the last several months is that the quality of the proposals that they're sending me has actually increased dramatically, to the point where I got an email from a medical student with a proposal for a research project that like a PhD student would normally not have come up with, because they wouldn't have had the ability to actually learn the technical language that was used in that document. And so I emailed the student. I said, hey, this is really good work. Here are the reasons why I think there are some issues with this project, but I have to ask. Either you have a family member who's amazingly strong and helped you with this, or you are some kind of savant, or the third option is you leaned heavily on the AI pedal. And the student was he wrote back and said, you know what? You're right. I really leaned on the AI pedal, and this is why. And I appreciate that you pointed this out. So those are two sides of the same thing. In one direction, one side, I think the consultation piece, great. I think it actually can potentially, if you're still getting a system to help you in that way is really good. But if you're actually using it to actually generate the novel thoughts, that I think is problematic.
Wait a minute. So I just have a question for you. Did you find that student actually knew what they were saying? Because I found that the quality has gone off a cliff. So people have told me that they know this thing, and then in person, when they don't have the AI next to them, it's like there's a blank stare. And that's what really worries me, is then I have them just write or say something, and I'm like, oh my goodness, please just write, actually I need a computer next to you so I don't feel like I've completely pushed you into an area that you're not comfortable with. And that's a little worrisome. And I'm going to hand this over. I think someone else had a comment. Did you have a comment? Oh, sorry. I thought you raised your hand.
No, I said, start again. I mean, I don't need you to write like a PhD level student. Do something that you generated and start. And there's something really important in that honesty, that I don't expect a high school student who's cold calling me or cold emailing me to generate something that looks like a PhD student. And in fact, I think that's really a little bit creepy.
So as an educator, because I teach bioethics classes, so it's very difficult, because I want to be able to assess our students' learning, or they're able to think critically, how to teach critical thinking. But when I assign a paper, I can tell a lot of students are using AI. So we say, you need to tell us if you're using AI or not. And last time, only one student said they were using AI. I think many others were and just didn't say it. So then I thought, okay, here's an assignment. Ask the AI to write an op-ed and then critique it and grade it. So I thought, they're going to use AI, at least be able to think critically about the AI. So they did that, but some students asked the AI to critique the op-ed. So I have a new assignment, which is I'm going to try out this semester. I'm asking students to interview someone else in the class about an ethics issue that they or family members face, et cetera, instead of talk about the interview. So it's a problem. I should say I happened to speak to the editor-in-chief of Science last week. So I asked him, what does he think about what's going on with AI? And he made an interesting point, which is that from his perspective, he likes the fact that there are scientists around the world for whom English is not their first language, and their papers are now much better thanks to AI. So in terms of the good and the bad, those are factors. Yes, go ahead, then we'll do final questions very quickly.
Okay, thanks. Yeah, just a quick couple of points on there. So to Gabe's point, I just wondered, if students are quite good at prompt engineering, right, because it does take skill to be able to get a Gen AI to give you something that made sense to you, for example, there are some skills there, and I think it's important. I would get for them to understand what they've generated, but you need to have a level of understanding to get it there. Usually, one point to Bob's, I've been thinking of some of those similar things, and I've moved completely to oral exams for my bioethics classes, for reference.
I do those too, but they take a long time. Usually a large class. So, Florence, you have a question?
Yeah, but did you first comment your question?
Oh, Gabe, go. Sorry.
I guess I'd say 100% I agree. That's why I chose to respond, because otherwise I wouldn't have even responded. But yeah, I mean, if that is 100% true, it's a different set of skills. And at first, when I was responding to that email, I thought to myself, am I being a Luddite here? Because, exactly in an era where a 25-page proposal could be generated in 5 minutes. Am I being a Luddite for not appreciating that the student who is able to sit there and put together that proposal and prompt it in such a way as to generate this kind of proposal? Am I just being old school in my thinking? I don't know the answer to that, but that's why I chose to respond, to say, you know what, if you want to go back and try again, here's my honest evaluation of the proposal that you put together. And I'll let you decide as to how you wish to proceed.
Yeah. And then to answer the question about directly, I'm Florence Hudson. I'm in the Data Science Institute here at Columbia. I lead the Big Data Innovation Hub. The National Science Foundation requires you to disclose if you use AI writing a proposal, and you're forbidden to use AI when you're reviewing proposals. Because once it gets into the cloud, so to speak, in AI, it can be disseminated anywhere, and this is, competitive proposals and new research and all this stuff. So there are rules like that. And interestingly, on March 4th here on campus, there's going to be the Data Science Institute is hosting Learning in the Age of AI and talking about reimagining teaching and learning in the age of AI. And that's here on campus. It's March 4th if you Google the Data Science Institute, if you want to join that, anybody. So we have to keep learning through this and working through it and trying to make things better without, as I say, making America dumb again. Where, like, just use the AI. Why do I have to think now? It's like, well, you kind of have to think. So I think that's one of our responsibilities as educators and doctors and things like that.
So Sarah, last comment, and then Charles, maybe if you want to cover your final closing comments also.
Yeah, just a brief comment to reflect that, at least when I was in my PhD program, and I'm sure for many, my advisor would say, you need to be able to sit there and just speak to me about what your research idea is, not with any materials to reference. So, these expectations, we have to kind of reflect on them, that we still have those expectations, even if there's a written product that looks, perfect.
So that brings us to the close. I'll make a few comments, and if you want to make some comments. So first and most, I want to thank everyone, particularly the speakers. So let's have a round of applause for our speakers. And as I said earlier, special thanks to Charles Binkley, who really organized the day and really put it together. So a round of applause. And the staff at Data Science Institute and Bioethics who helped us, thank you so much. So applause for them. I don't think it's possible to summarize everything that's been said. I mean, one standout to me is how we use AI as a sort of stand-in for a whole breadth of phenomena. And I think that in the future it would be like talking about books or something, well, all kinds of books, or saying, well, the person has cancer, well, there's all kinds of cancers. So, and I think that leads to some confusion where people are thinking one kind of AI and there's another kind of AI and uses, et cetera, and how unpredictable the future is. I was so struck by some of the slides that Flo showed, for instance, the number of patents, and I think a few people showed such slides, but just, where we'll be 5-10 years from now, who knows, and how much it's a missing target. And the amount of uncertainty, but I think opportunity and excitement. So with that, Charles, you want to make any comments? And again, thank you all so much for being here.
Yeah, thank you, Bob. Yeah. A round of applause for Bob. You know, Bob approached us with this idea. Bob really put the grant together, got us the funding, and then invited, and I want to introduce Florence Hudson. For many, many reasons, it's been such a pleasure to get to know and to work with Florence in the process of putting this together. Florence will be leading another conference on April the 27th on digital twins. So in my mind, that's the extension. That's the next extension, the next application of artificial intelligence. And you know, Florence is a real luminary in that field. And so I'm so looking forward to that conference on April the 27th. So mark your calendars. Again, reflecting everything that Bob has said, thank you to all of you who attended, both in person and online, to our speakers, to the Data Science Institute, Alexis and Aaron, and Marie and Katie from the bioethics program. Really, really appreciate it. In terms of takeaways, the thing that keeps coming back to me, I just got a text from my father-in-law, who yesterday I was Zooming with him and my mother-in-law, and he had gotten an echocardiogram, and I said, just upload it into chat. Upload it into chat, and you can ask it all the questions you want. So I just got this long text from him saying, this was remarkable because it gave me the language to use to talk to my doctor, right? He'd taken an airplane, he got shortness of breath when on the descent of the airplane, so he was able to describe all this in his 85-year-old meandering way of communicating that I'm sure ChatGPT is much more patient with than his doctor. And he said, thank you. You gave me a way of describing this, right? So the human issues aren't going away. AI is just being introduced to them. Questions about communication, about truthfulness, about these things that we've always, truthfulness, transparency, consent, patient-centeredness. We just have to figure out what it means, right, that AI is part of it. There's nothing, as we say, there's nothing new here, but everything is really new in some ways. The other thing that I take away is really the sense that that we're all after the same thing, that we really do want to take good care of patients. And that was the thing that really came across very clearly, is that we want to be critical in what we let into that relationship and how we collaborate with it. The third thing that sort of strikes me is that AI is not going to be this moment of science fiction where something comes in and we're going to say that's artificial intelligence. It is going to be progressively, and again, reflecting something that Bob has said, it is in our lives, and it's going to be increasingly in our lives. There's nothing that we're going to do that doesn't have artificial intelligence embedded in it. And at some point, it's not going to be a thing. It's just going to be there. But right now, it's not there. And the trust from our patients and from the public and from society, for those of us who provide care, for those of us who lead health systems, for those of us who are involved at all in medicine, nursing, patient care, that trust is so precious. And in some ways, that's really all that we have. So I think we have to be super careful right now about the patient's perspective, making sure that we're truthful and transparent, but that we not assuage our responsibility to integrate, that we don't just say you have an 85% chance of dying because AI said so, right? And being able to kind of straddle this line between not being paternalistic and maternalistic in how we withhold, but being truthful and honest and integrating AI into our decision making. So I think those are my big takeaways. Be on the lookout for publications coming from this conference today. We certainly want, this issue has not been addressed as methodically as it was today. So we want to get this into the literature. And of course, April the 27th, I look forward to seeing everybody back here, not here, but back here together for the conference on digital twins. Thank you all so much. It's so good to see you.